Right, I think we are on now. Hi guys, good evening. I hope you can all hear me. Some studio glitches always keep happening, and sorry for the delay, this 7-8 minutes. I hope you're all well wherever you are, and let's cut off the introductions for once. All the best for your INI-CET exam. We are here for a quick fire revision, and I hope all of you are ready with your books. And we are going to do a lot of revision on whatever topics we keep coming in the exams. We'll also do the new things which are important to learn. But remember, when we're learning the new, it does not mean that we forget the basics. The outright basics, the core basics come in the PG entrance exams, whether it's the INI-CET or the NEET PG, or even if it's the MCI exam. So I would want all my students to understand, please know the core basics. Understand what is done in the outpatient departments of the medical colleges, of the hospitals in our country, what the Ministry of Health and Family Welfare would say, what are the guidelines given by us Indians. These are the ones which will come in the exams. Okay, so please do not get into the Royal College guidelines or the American guidelines or the Australasia guidelines or the WHO guidelines immediately, because this is something which is confusing a whole lot of you. And I understand the confusion is sometimes by a lot of reading on the internet. So always stick to the books, stick to what your teachers are telling you, the people who are practicing in the hospitals, your teachers, all these teachers, they are the ones, because you're doing internship. Most of you have finished or doing internship, and you people, those who are having these teachers in front of you, please ask them what is practice in the hospitals. Once you know that, you'll never have confusions, because we want you to know the outright basics. All right, so that's enough. I think we'll just move on and say yes. Good evening, good evening, good evening. All right, fine. Let's start with the outright basics. We'll do a quick revision of almost all the topics which are coming in Obs and Gynae. So we'll start with the transformation zone, and if you see the transformation zone, it is the area which is between the anatomical and the histological internal os. You know, this is the internal os, the anatomy, the uterus becomes the cervix here, so in anatomical internal os, and then the epithelium changes. I've given blue color because this is the ciliated columnar epithelium in the patient's uterus, and then it is still the ciliated columnar epithelium in the blue, but it becomes the epithelium changes after some distance, and it becomes the columnar epithelium. Once it becomes the columnar epithelium, this columnar epithelium is the one which is the epithelium which is changing after some distance. So first it is the anatomical internal os, then it is the histological internal os, and between this anatomical and the histological internal os is the area which is called the isthmus. That is the area which is called the isthmus. All right, so isthmus is the place. You must see the isthmus. Is it not to, wait a minute, okay, isthmus is the place where the area which is between the anatomical internal os and the histological internal os. So between that anatomical and the histological internal os is the isthmus, and after isthmus we have the columnar epithelium, and then the columnar epithelium becomes the squamous epithelium at the outer surface of the cervix. So where the columnar epithelium is trying to become, see this area, where the columnar epithelium is trying to become the squamous epithelium. Very important for us to understand. Okay, once more, please try and understand the columnar epithelium here and the squamous epithelium on the cervix. The area between that is known as the transformation zone. So two things in the anatomy of the uterus you have to understand for our exams. That is, the isthmus is the area between the anatomical and the histological internal os, and the transformation zone. The transformation zone is the area which is the place where there are rapidly dividing cells. The punchline for the day, the rapidly dividing cells are in the transformation zone, because the columna is resting and the squamous is resting on the cervix. The yellow area which I have shown here is the area of rapidly dividing cells, or the transformation zone, and that is the area which will get affected by the HPV first. So yes, this transformation zone is located 1.7 to 2.3 centimeters from the external os, and this area, the significance is this has the rapid dividing cells. When they are rapid dividing cells in this one, these rapid dividing cells are the first to be affected. They are first to be affected by the human papilloma virus. That's why importance in pap smear is should be sampled. That's your MCQ. Should always be sampled in a pap smear. If it is not sampled in a pap smear, then we know that this sample is inadequate. This question came in INI-CET a few years back. Woman is undergoing a pap smear. In the pap smear, the cells which are seen, they are not showing any malignant change. However, the transmission zone component is missing. What is the management of this patient? When the transmission zone component is missing, the next thing to do is repeat the pap smear. So, the pap smear is a screening test, and that screening test is done on an asymptomatic woman, and it is done at the transmission zone, because that's the first area where the effects of HPV will start, which can later cause a CS cervix. So, yes, what else we have to know about the isthmus? This isthmus is 0.5 centimeters in size. This is in a non-pregnant woman. In a non-pregnant woman, this isthmus is 0.5 centimeters. Now, what happens in a pregnancy? In a pregnancy, this area, this becomes a very big uterus and a baby inside. Now, this area, which is the isthmus, that becomes the lower segment. That is the lower segment of a woman at term. The cervix will efface and will become the lower segment, and this is the upper segment. Now, what is the importance of this lower segment? You know what is the importance of the lower segment? What is the contribution of the lower segment in labor? It does not do anything in labor. Remember that lower segment relaxes in labor. So, upper segment contracts. This upper segment contracts and the lower segment relaxes. Between this upper segment and contracting upper segment and the relaxing lower segment is the retraction ring. The retraction ring is between the contracting upper segment and relaxing lower segment. And when the upper segment contracts, lower relaxes, the uterus will go down and cause a delivery. This lower segment is hence the area which is relaxing in labor, and this contracts in labor. So, yes, that's why when we have to do a cesarean section, remember guys, a cesarean section is always the lower segment cesarean section. Why do we do an LSCS? A lower segment cesarean section is done only for the purpose that next time, suppose the woman is pregnant and I want to give a trial of normal vaginal delivery, I can give it only if I had done a previously lower segment cesarean section, because the upper segment contracts, the lower segment relaxes. When the lower segment relaxes and you made an incision in the lower segment last time, maybe there was a fetal distress in the first pregnancy and you had to do a cesarean section. So, this incision is in the lower segment. Next time when you have to do a normal delivery, you can do a trial of labor. This is possible. Autolac, trial of labor after cesarean, or we call it a VBAC, vaginal birth after cesarean. This is possible only when you do a lower segment cesarean section. That is what is prerequisite. One LSCS and you can give a trial of normal delivery. Look, the Royal College says you can do it for 2 LSCS also. Now, we are not the Royal College, we are the Indian hospitals, okay. So, we do it only for 1 LSCS and we go trial of normal vaginal delivery for previous 1 LSCS only if it is, of course, in the lower segment, right. That's the significance of this. What is the basis of the menstrual cycle? Let's quickly have a look at that. The hypothalamus from the mediobasal nucleus. The mediobasal nucleus, it will start the stimulation of the pituitary by the gonadotropin releasing hormone. Gonadotropin releasing hormone will release the gonadotropins. This FSH and LH are basically the gonadotropins, GN. And this FSH will act on the follicle to grow the follicle, and this follicle will convert the androgens to estrogens and make a increase of estrogen in the body to cause proliferation of the endometrium. And this estrogen will give a message to the brain, please stop the FSH, enough FSH has come, no more FSH because I am ready. This estrogen is adequate estrogen to give a message to the brain, please don't send me FSH anymore. But this estrogen is a high amount to tell the brain to send the LH. So, this high estrogen is negative for the FSH, but it is positive for the LH. So, LH will come because the follicle is ready. Why? Because estrogen tells the LH to come. Please remember, the cause of the LH surge is the high estrogen. The direct cause is always asked in the exam. So, that high estrogen tells the brain to send the LH, and that LH will rupture the follicle and make it a corpus luteum, and that will make progesterone. Progesterone will make the endometrium secretory. So this follicle, when it ruptures, now it starts making progesterone. So remember, this follicle was converting the androgens to estrogens by the aromatase enzyme. ARM I have written, aromatase enzyme, ARMT I will write so that you don't forget. So aromatase enzyme, it makes the estrogen. Now this follicle, when it ruptures because of the LH, luteinizing hormone, it gets luteinized. So that corpus luteum, luteinized follicle, corpus luteum, that is going to make progesterone. The granulosa cells which are now luteinized will preferably make more progesterone, and that progesterone will give a message to brain to stop the LH. So this high progesterone, which is causing secretion of the endometrium, gives a message to the brain, and that is negative for the LH. So yes, please remember the punchlines here. The FSH came to make estrogens and the LH came to make the progesterone. My very important punchlines. Remember, FSH came from the brain to act on the follicle, and the follicle became big and it made estrogens, and the estrogen gave a message to the brain to reduce the FSH and increase the LH. You know that. How is the estrogen made? Aromatase converts the androgens to estrogens. You know all of this? Fantastic. But even if you don't remember this, remember the purpose of the brain releasing the FSH is to bring back the estrogen. Remember the purpose of the LH is to rupture the follicle and make it a corpus luteum and convert into corpus luteum, correct, and make progesterones, correct. But the purpose is that when the LH comes out, it gives the progesterone to come back to the brain. So the purpose of FSH is to make estrogen, purpose of LH coming out from the brain is to make progesterone. Remember these two lines and we'll understand many more things subsequently in the lecture. So what are the normal FSH values? 2 to 6 international units. By the way, what is the purpose of FSH? Just now we discussed, yes, to make estrogen. So if a woman is having enough FSH acting on the ovary, making enough estrogens, it will give a message to the brain to stop the FSH. Now this is a young woman having lot of follicles making enough estrogen. Young woman makes a good dominant follicle every month, makes enough estrogen to tell the brain there is enough estrogen, so FSH stays somewhat low. But the woman becomes old. Woman is now 45 years. You know the follicles reduce in women after 40-45, there are hardly any follicles left. So the progressive reduction in the follicle means progressive reduction in estrogen. Ovary is old, not much estrogen going to the brain, but the brain is always young. The brain is always young. The brain tells a message to the ovary. Ovary, make estrogen. It increases the FSH even more. But the ovary is like, look, I'm running out of follicles. I cannot make much estrogen anymore. Brain is still young. Make estrogen. So the FSH goes on increasing as the woman gets older. Remember that. So that's why they ask you, if the FSH is high, more than 10, it is suggestive of a menopausal woman. And if it is more than 40, it is diagnostic of menopause. And if FSH is more than 40 before 40 years, that is known as premature ovarian failure. That is what is known as a premature ovarian failure, guys. So please understand, premature ovarian failure is ovarian function stopping before 40 years. Any ovary will stop function at 50 years, but that is what is expected. If a woman loses ovarian function before 40, we call it premature ovarian failure. How do you diagnose premature ovarian failure? FSH is more than 40 international units. Okay, let's get into the understanding now. So this FSH is part of something called the ovarian reserve. So young women have a lot of estrogen. That's why the FSH is low. Old women have less estrogen because less follicles, so the FSH is high. So a woman is 45, the FSH is high, it is expected. Woman is now 65, FSH is 150. Okay, it's very high, but it is expected because the woman is not making any more estrogen. So 2 to 6 in a woman who is 25, more than 10 in a woman who is 45, and more than 40 who is more than 50 years. That is what is expected. Now, there is a woman who comes to me and says, Sir, I'm married for the last 5 years. I'm 29 years of age. I'm not getting pregnant. We've been trying for the last 2-3 years very regularly. I do some investigations. One of them is to see the ovarian size. Ovarian size is very small in this woman. The number of antral follicles, the number of follicles which are recruited in the early part of the month, they're only 1 or 2. And I do the serum FSH in this woman. The serum FSH is 15. The age of the lady is only 29 years. So that high FSH in a young woman is telling me this ovary is not working properly. She has a poor ovarian reserve. So poor ovarian reserve may be the cause of infertility in this lady who is 29 years. So quickly I'll do IVF. I'll try to use the eggs, whatever eggs are left. Whatever is the cause of premature ovarian failure? That is besides the point. Maybe because we cannot reverse ovarian failure. Yes, even though we have a lot of methods of helping women in fertility by in vitro fertilization, ICSI and so many other things have come up, but we cannot reverse the aging of the ovary. So what I can do at 29 when I get to know she's got a poor reserve, that I can do IVF early. So that is what is a hot shot topic in exams also these days. Yes, I learned it only when I got into the, my MD and I was doing a thesis on infertility. We learned about infertility in detail and ovarian reserve, and all these topics used to be MD topics when we were postgraduates. Now you guys have to know the best test for ovarian reserve. That's how things are becoming, tougher for all of you. So yes, ovarian reserve is the capacity to conceive. Okay, capacity to conceive. So it is a good reserve in a young woman, and it is a poor reserve in an older woman. Why do you say so, sir? Because the size of ovary in a young woman is 3.5 into 3 into 2.5 centimeters, and antral follicular count per ovary, that is 6 to 7 antral follicles are there per ovary in the beginning of the month. Serum FSH is 2 to 6 international units. Serum inhibin is let's say 40 to around 200 picograms per deciliter, and serum AMH is 2 to 6 nanograms per ml. So these are the parameters which tell me that the woman is having a very good ovarian reserve because she's a young girl. Now what is happening I mean to say in an older woman? In an older woman, I'll see your questions guys, just I'm in the middle of something important. What is happening in an older woman? Poor reserve. Why? Because age is more, size of the ovary is much smaller, and the antral follicle count is less than equal to 3 per ovary. Please do not get distracted. Don't think that I'm telling too many unnecessary details. This has come as a question. What is a number of antral follicle which is considered as poor reserve? Less than equal to 3 per ovary in the beginning of the month. This question has come in, I think, in your INI-CET exam. And then serum FSH, if it is more than 10 international units, serum inhibin if it is less than 40 picograms, and serum AMH if it is less than 1 nanograms. So this is the reason why older women do not conceive. So yes, you are like, okay sir, we know this. Young women conceive because they have very good parameters. Old women do not conceive because they have bad parameters. What's the big deal? We know this anyway. Sometimes, like I gave the example before this topic, sometimes these parameters, yes, if seen in a young woman, yes, if they are seen in a young woman, she is having a poor reserve. Yes, that is what is a poor ovarian reserve. If these parameters are seen in a young woman. So that's why I told you in the young woman who came to me at 29 years of age and not conceiving. Okay, poor ovarian reserve. I'll not change the slide. I'll see what you guys are asking me. Very excited. Okay, thank you so much. Fat production. Yes, fat will also make estrogens. You are correct. Fat will make estrogens, but they are not the best estrogens. The best estrogens are made from the ovary. Fat will make estrogens in postmenopausal women also, right? So those are the estrone, estradiol, and estriol. So estrone is the fat made kind of estrogen, and also made in older woman, not a very potent estrogen. Estradiol, young woman, E2 we call it, and E3 is estriol, the one which is seen in pregnant mothers. So pregnant women will have high estriol. So that's why we say in triple marker VSS what? Estriol. Okay. Which topic is this? Can you explain the significance of AMH? Okay. Anti-Mullerian hormone. Anti-Mullerian hormone. Okay, I was just coming to that. Good, you asked me the question. So the granulosa cells, what did I tell you? Sometimes earlier in the class, I said the follicle is making the estrogens in the granulosa cell. The androgens are converted to estrogens in the granulosa cell. So if there are good granulosa cells, good number of follicles, that means there is good granulosa cells and there is good amount of estrogen production. Now these granulosa cells, yes, you can see my hand, okay. So granulosa cells, okay, I might as well write the whole damn thing. Okay, the granulosa cell, okay, I'm writing it small. It makes the estrogens, which I told you earlier, but it also makes the inhibin and it also makes the anti-Mullerian hormone. So the anti-Mullerian hormone, the significance is it is made from the granulosa cell and it is made from the time the girl is around 12-13. It starts increasing. Anti-Mullerian, no further uterine growth will happen because AMH is made in a high amount in a young woman who is around 12-13 years, young girl who's 12-13 years. So that is the ovarian function to make AMH, so that you don't want the uterus to endlessly grow. And that AMH is coming from the ovary. It is giving us a very good assessment that the woman is having good granulosa cell function. Now that is why we ask you these questions. Which are the best 3 parameters to assess the ovarian reserve? I've told you a few, right? But the antral follicular count, the serum FSH and AMH are the 3 better parameters to assess the ovarian reserve, and the single best assessment of ovarian reserve is by the AMH. That's what they keep asking you in the exam. Which is the single best assessment? Okay. Now let us see something else. The complete ovarian menstrual cycle and the pituitary cycle, all of that together. Quickly we'll do this revision. The pituitary hormone FSH is high initially for the first 2 to 3 days, and that high FSH will recruit around 6 to 7 antral follicles, which I told you just now. Now the FSH goes low. Low FSH is good only for one of these follicles to grow in size. So that's why we say one of these 6-7 becomes dominant. And now this low FSH is good enough to grow that one follicle. That's why we say this is that dominant follicle over others, because it can use the low FSH also to grow. Now this follicle becomes a good mature dominant and a mature follicle, which is 15 to 20 millimeter in size. How much of estrogen does it make? Multiply by 10. 150 to 200 picograms. So as the estrogen increases, the endometrium starts to proliferate. So proliferative phase is same as the follicular phase. Follicle makes the estrogen, which causes the proliferation. I told you this high estrogen gives a message to the brain that send the LH. LH surge is high estrogen, guys. 3rd time in this lecture I'm telling you. This LH, when it increases, it ruptures the follicle and releases the oocyte. Ovulations happen. From the onset of the LH surge, yes, from the onset of the LH surge, it takes something like 36 hours to ovulate. From the peak of the LH surge, it is 10 to 12 hours to ovulate. Now the follicle ruptures, oocyte goes out, and this shrinks to make the corpus hemorrhagicum. H I have written corpus hemorrhagicum, blood is there. Then it becomes the corpus luteum, yellow. Then it becomes the corpus albicans, white. Now this corpus luteum makes the progesterone. Look at the endometrium, which was proliferating. This has now become secretory. So secretory phase is because of progesterone from the corpus luteum. So secretory phase is same as the luteal phase. Now that makes the endometrium secretory and stabilized. The endometrium is not growing anymore. Watch this, guys. The endometrium was progressively proliferating. Now the endometrium has become secretory and stabilized. That's why progesterone is important, because it prevents the further growth of the glands, prevents endometrial cancer. Yes, that's why women who are not ovulating, they do not have progesterone, and the endometrium will go on increasing in size because of the high estrogens. So that secretory endometrium is because of the high progesterones. And then the corpus luteum maximum function is 10 days. The corpus luteum starts to degenerate. Finally, when the corpus luteum has totally lost its function in 14 days, it makes the endometrium shed and cause the periods. There's something about the inhibin which you have to know. The inhibin is coming around day 10. Around day 10, the inhibin is high from the follicle, that inhibin inhibits FSH. Please understand, inhibin inhibits FSH. FSH is activated by activin. Activin activates FSH. Inhibin inhibits FSH. So when do you want the FSH action? In the beginning of the month. So activin works in the first few days. Inhibin inhibits FSH. Around day 10, inhibin comes out from the follicle and FSH is not required. The follicle can grow without the FSH, independent of the FSH. Yes, once it is 12 millimeters, day 10, it's around 12 millimeters. It can grow independent of the FSH stimulation. So inhibin inhibits FSH. Remember that. Then there is a rupture of the follicle and the oocyte is released. Remember, there is, can you see here? There's a small FSH peak again. This is again FSH. Because FSH is required for the estrogen production. FSH is making the estrogen, and that estrogen is required for the endometrial blood supply. The endometrium needs blood, right, to grow. So this FSH will make a minimal amount of estrogen which is required for the blood supply, and that estrogen will be there a little bit because the mid-cycle FSH increase. Now this FSH is again inhibited by inhibin here. So inhibin comes again to inhibit the FSH. What stimulates, what activates FSH? Activin. What inhibits FSH? Inhibin. So there are two molecules, two co-molecules, or we can say two elder brothers of FSH. Activin activates FSH, inhibin inhibits FSH. Now the question is, which comes first, which comes second? So yes, inhibin B before ovulation, inhibin A after ovulation. No, it's my way of remembering things. Of course, inhibin A was recognized first, inhibin B was recognized later. But yes, inhibin B before ovulation, inhibin A after ovulation, convenient for us to just remember. But inhibin inhibits FSH. Just remember these things, guys. Right? Million per ovary, I am writing 6 to 7. It is the antral follicles. Primordial follicles are 3 to 4 lakhs at puberty. Those are primordial follicles which you are talking in millions, Rishabh. The antral follicles, these antral follicles, see, these are the ones which are recruited out of 3 to 4 lakhs follicles available at puberty. 6 to 7 are antral every month, and one will become dominant over these antral and ovulate. So yes, the primordial follicles are in lakhs. They are in millions when the girl was inside the mother's womb. 6 to 7 million in the uterus, 1 to 2 million at birth, 3 to 4 lakhs at puberty, and out of 3 to 4 lakhs every month, 6 to 7 become antral in an ovary, and one will become dominant and ovulate. Alright guys, chalo. Koi baat nahi, keep asking. I hope we can justify everything. Now let's see what happens if this woman is sexually active. Yes, just a minute. So if this woman has intercourse, cycle with IC I am writing. If this woman has intercourse on the 14th day, you know the normal. This I told you the normal. Are you asking me something else? Yes, corpus albicans after corpus luteum. Good. Let's stick to this right now. Yeah, fine. I think it's okay. So when you see a woman having this normal menstrual cycle and she has intercourse on the 14th day, the sperms have gone into the body. She has ovulated, the egg is here, and the sperms have come and fertilized the oocyte in the ampulla. The site of fertilization is ampulla. That's why ectopic is in the ampulla commonest. Okay, don't do a mistake. Now this fertilized embryo will implant earliest on the 6th day. It implants earliest on the 6th day. But what you have to understand, that the corpus luteum maximum function is only till the 10th day. After day 14 till the 24th day, 10 days, the corpus luteum is making maximum progesterone. Then the progesterone reduces. So the secretory endometrium, consider it guys, secretory endometrium is required for the embryo to continue its life. Secretion, juicy endometrium, full of nourishment. Now that endometrium is about to shed because the corpus luteum is about to die on the 10th day, start degenerating. So that's why We must remember the corpus luteum was made by a gonadotropin called the LH. The corpus luteum is now about to degenerate, but this is a pregnancy now. So the pregnancy makes LH. Pregnancy makes LH. Wait, not LH. Like LH. Alpha LH is same as alpha HCG is same as the alpha subunit of TSH. So the LH-like action from the embryo itself, which is human chorionic gonadotropin. See, LH is a gonadotropin, acts on the gonad. So the pregnancy, the embryo makes a few syncytiotrophoblasts, the early placental cells, which makes the human chorionic gonadotropin, which will act on the gonad obviously. And the gonad is corpus luteum, which will make the progesterone, and the progesterone will make the endometrium secretory, and the pregnancy will continue. So the pregnancy was about to degenerate. It was about to abort. It implanted on the 6th day earliest, implants earliest on the 6th day. Okay, embryo can happen on 7th, 8th, 9th, 10th day. Why till the 10th day? Because the corpus luteum is working till the 10th day. Corpus luteum was about to degenerate and cause the bleeding, but this woman got pregnant. And this pregnancy gives LH like HCG. And this HCG rescues the corpus luteum. That's the word you have to remember. The HCG from the pregnancy rescues the corpus luteum. So corpus luteum says, all right, fine. तुम मुझे HCG दो, मैं तुम्हें progesterone दूंगा. You give me HCG, I'll give you progesterone, and it becomes a good symbiotic relation, and the pregnancy continues. So that is what is your MCQ, which comes many times. Corpus luteum will continue function till 12 weeks, but around the 6th week, the placenta starts to make the progesterone. Placenta starts to make the progesterone, and this placenta now will maintain the pregnancy till delivery. So yes, the corpus luteum alone maintains the pregnancy till 6 weeks. After the 6th week, the placenta takes over the function of maintenance of pregnancy. So that is what is known as a luteoplacental shift. Luteoplacental shift. It occurs after 6 weeks. Luteoplacental shift occurs after the 6th week, and now this placenta will maintain the function of the pregnancy till delivery. So that's why you must remember this relation very well. Okay, the placenta is very cunning. The placenta says, I am going to take over the function of maintenance of pregnancy. I'll make progesterone. Corpus luteum is saying that, okay, I'll also help till the end of pregnancy. But the placenta actually reduces the HCG, which was maintaining the corpus luteum. So now they'll ask you the HCG value sometimes. So HCG, which is made by the placenta, reduces after the 66th day of pregnancy. That is also MCQ. 66 days is basically 9 weeks plus 3 days. So 66 day of pregnancy, the HCG is highest. That's why you see now the corpus luteum is going to work. Corpus luteum is going to work maximum till 6 weeks. It has got some function. I'm not saying it has not got function. It is still around because the HCG will always be there till the end of pregnancy. But the major progesterone is by the placenta. In fact, there will be some corpus luteum function till the end of the delivery. It won't degenerate totally. It has got lesser function. But the major function of making the progesterone is now by the placenta. Right. So what are you guys asking me? HCG follicular. All right. So tell you. So after understanding all of this, now I told you two punchlines, that the purpose of FSH is to make the estrogen, purpose of the LH is to make the progesterones. So now let's see that. FSH acts on the follicle, makes an oocyte, and this follicle makes the estrogen quickly, okay, and this estrogen will act on the uterus to make the endometrium proliferate. Now the LH is going to rupture the follicle and release the oocyte, and this is going to now make a corpus luteum which makes progesterone, and this progesterone acts on the endometrium to make the endometrium secretory. And I told you to remember these punchlines. Please remember FSH for estrogen, LH for progesterone. Now guys, stop doing anything else and please concentrate. Yes, do not do anything else and give me your ears. This is where this gets very important, those two punchlines. I know this basic, so I give this woman tablet of estrogen to eat sometimes. I try to do a experiment. I give a tablets of estrogen to eat. The estrogen goes into the circulation of the woman, and this gives a circulatory estrogen, which gives a message to the brain that there is enough estrogen in the body. Stop the FSH. So when I give her a tablet of estrogen, it gives a message to the brain. It stops the FSH when there is no follicle, obviously. So the woman will not ovulate, and ovulation. I also make her eat a tablet of progesterone, and that progesterone is going to give a message and stop the LH, because what is the purpose of LH? LH is for progesterone. I give her a tablet of progesterone to eat. That progesterone is going to give a message to the brain and stop the LH. So now there is no LH. So if at all there was a follicle in the ovary, that will not ovulate. So you make sure that when you give estrogen progesterone combination, you're going to make the woman anovulatory. So if she has intercourse, she will not conceive. So we achieve contraception by this combination of estrogen and progesterone, which is known as combined oral contraceptive pill. Yes. Combined oral contraceptive pill you understand so simply because you understand just the two punchlines. The FSH was to make the estrogen, LH was to make the progesterone. You give estrogen progesterone from outside, make her eat a tablet of estrogen progesterone, it stops the brain's production of FSH and LH because the brain is satisfied. There is estrogen progesterone in the body. I will not send gonadotropins. So that's how the COCPs work. They inhibit the FSH and LH. So pituitary sleeping, ovary sleeping. Obviously, there is no estrogen progesterone production. Wait. There is no estrogen progesterone production by the ovary. There is no estrogen, there is no progesterone by the ovary. So how does the woman get periods? You give a woman tablets of COCP Mala N, and after stopping it from 21 days later, you see the woman gets a periods on 27-28 day. If the endometrium is not having estrogen progesterone, how will the uterus grow? How will the uterine lining grow? If the uterus is not getting estrogen and progesterone from the ovary, how will the endometrium lining form? It will form because the tablets which I am giving, my estrogen will causes the proliferation in this lady, my progesterone causes the secretion in this lady, and when I stop the tablet, she gets periods. So yes, this menstrual cycle is because of my tablet, the OCP which I am giving to this lady. Once again, what is the estrogen production? Maximum source of estrogen production in the body of the woman. Maximum estrogen in a normal woman is made by the ovary. Ovary is sleeping in this woman. The pituitary FSH and LH is not made. The ovary is sleeping. There is no estrogen progesterone from the woman. There is no production. How does the endometrium form? It forms because of the estrogen progesterone which I am giving from outside, and that's what makes the endometrium. So when I stop, she gets periods. I give 21 days, stop periods, 21 days, stop periods. So this is a very regular cycle also because it's under my control. So please remember, when I give COCPs, it is not a natural cycle, it is a pill period. It's an artificial cycle. Yes, that's a word I always use in my classes. It's an artificial cycle, and that's why when I give for 21 days and stop, the periods come at 28 days. So woman knows that her periods are now regular. Look, you're not treating a disorder of the woman. She will get regular cycles as long as you give the tablets. Remember that. A lot of you come and tell me, sir, we give COCPs for 6 months. After that, what will happen? After that, the periods will be regular forever. What nonsense. If she's having a PCOS and she's 25, you're giving her COCPs for 6 months. After that, PCOS ठीक हो जाएगा. Everything in PCOS will get all right, right? She'll be okay. Her ovaries will be fine. You are giving for 6 months, and that's the biggest lie you interns keep telling me. I don't know how you get that from. So please, COCP is given for 6 months, she'll have periods regular for 6 months. If you stop it, she'll get into irregular cycles again. So now, let's come to the crux of this discussion. When I give estrogen and progesterone, the period is under my control. It's a pill cycle. So periods are known as the pill periods, or I like to use the word artificial cycles. They are under my control. So stop pill in 21 days. So periods on 28th day. So that's why we say the woman is having regular cycle. Now, how much of estrogen do I give? Now, that's the question which keeps coming. I give ethinyl estradiol 0.03 milligrams, or I give 0.02 milligrams, which is basically 30 micrograms or 20 micrograms. So I give the least dose. I give the least dose which can give a message to the brain and stop the FSH. I give the least dose which gives a message to the brain and stop the FSH. So yes, I could have done it with the highest dose, but why? My least dose is able to stop the FSH. So when the FSH is reduced, the ovary is not working. So I achieve it with the least dose. Fourth time I am saying, guys, the least dose suppresses the brain. Come back, revise. What is the major source of estrogen in the normal woman? Ovary. When I am giving COCP, is the ovary working? No, it is sleeping. So what is the major source of estrogen in this woman now? My tablet is the major source of estrogen in this woman, and I am giving a high dose or a low dose. I am giving the least dose which can suppress the FSH. So yes, when I give COCPs, the estrogen in the body is from my pill, and I am giving a low dose OCP. So the estrogen in the body is low, guys. Don't say when you give COCPs there will be high estrogens, and high estrogen will cause estrogenic side effects. That's why you should not be giving estrogens to women, because OCPs are bad for women. What? OCPs, if at all, are going to do so much good for a woman. There are so many disorders which are better because of COCPs. That's what keeps coming in your exam. So you should know that OCPs are basically going to help the woman having so many benefits, especially women who are having hyperestrogenic disorders like endometrial hyperplasia, endometrial cancer, fibroids, endometriosis, all because of high estrogen. So OCPs, if you give, these are reduced. So the punchline is, when you give COCPs, the net amount of estrogen in the body is low. So yes, COCP is a low estrogen situation. So yes, remember this. Suppose I give somebody COCPs for 10 years. And she's married, and she says, I've got a child, I'm 26 years, so now I don't want to have a child for some time. She takes it for 5 years, and then she comes and says, sir, enough, I don't want to have any more children. You continue my COCPs. So 10, 12 years in her life, she's taken COCPs. So 10, 12 years in her life, she had high estrogen or low estrogen? No, sir, she's taking tablet every day, so it will be high. No, every day she's taking less number of estrogens. Very simple. If you are used to eating 4 slices of bread in your breakfast and 2 slices of, okay, let's keep it to only chapatis. If you are taking 2 chapatis in the lunch and 2 chapatis in the dinner, you are taking 4 every day. I reduce it to 1 chapati for the next 10 years. So if I reduce to 1 chapati, you will have less food for the next 10 years. How will it be more, man? So do not get confused that when you give COCPs, there will be high estrogen and there will be problems of high estrogen. No, we are giving less estrogens. That's why the woman is having benefits. So it's a low estrogen condition. That's why there are benefits. Okay. So benefits are so many. There are lesser. Okay. I'm just not going to write all of that. This is a revision class. Remember, lesser proliferation, lesser hyperproliferation. So lesser bleeding, lesser anemia, lesser estrogenic conditions like hyperplasia of the endometrium, C endometrium, lesser fibroids, lesser endometriosis, and lesser ovarian cyst and ovarian cancer. So many benefits are there. And very important, there is lesser colorectal cancer. Write it and remember it. This has come twice in the last year alone in 2 different exams. Colorectal cancer. Why? Because COCPs bind to the bile acids, so the lesser bile acids circulating and lesser bile acids especially in the gut. That's why there is lesser colorectal cancer when you're giving COCPs. So there are so many benefits of COCPs. Yes, if you're giving COCPs, rare side effects is rarely gallbladder stones, but not gallbladder cancer, hepatic adenoma, but not hepatocellular cancer. It may increase cancer cervix of the adenocarcinoma type, not squamous cell carcinoma. Please listen to me, guys. Do not say COCPs cause cervical cancer. No. COCPs cause very rarely adenocarcinoma of the cervix. Very rarely. Again, yes, the squamous cell carcinoma of the cervix is the most common gynae cancer in our country, and that's because of HPV. So don't confuse on this fact, okay? And yes, there may be increased chances of thromboembolism, but these are all theoretical things, okay? Please do not say that they happen. And one thing which you have to remember, that there is no no change in CA breast incidence. Don't say CA breast increases, don't say CA breast reduces. CA breast incidence, there is no change when you're giving a woman COCPs, because you're not giving high estrogens, you're giving low estrogens. So low estrogens given for a long time will not increase CA breast. Of course, they don't reduce CA breast also. If at all there is a controversy in lot of literature which is coming, always refer to the reference book. Latest editions of Williams, latest editions of Novak's, these are the reference books. Data you should say always Indian, but you should refer to these books, because these books will give you what is accepted by everybody. That's why there's so many guidelines, so many updates coming. Once they come in books, standard reference books, then only we teach you those. I know some books say that CA breast incidence may increase, but most people say that they actually do not increase CA breast. Williams says that the incidence is not increased. Whatever little bit increase is there, once you stop the COCPs, whatever number of years you take, when you stop, that incidence also is reduced. So don't say it increases, don't say it reduces. Unchanged CA breast. Okay. Colorectal cancer is reduced. Okay. Minimum effective dose 10 mg, नहीं 10 microgram. 10 microgram hai. Okay. 10 microgram. Enough to complete, or you are Alam, nothing is enough to go. I mean, we do 3-4 hours of Obs and Gynae revision. You may say, sir, you left these lines. Obs and Gynae I read for 3 years as a postgraduate. So I was being taught constantly at the job. So they might not be enough whatever I do with you. So we are doing the common things which are commonly asked and a few rare ones. So if you say this is enough, yeah, it should be enough for a good revision. But yes, you have to go on seeing the PYQs. That's why the easiest way to do a revision is to do the PYQs of the last 5 years, whichever exam you're writing. Because you know what are the topics coming regularly, itna to pata hona chahiye. And then you read your books, whatever extra you can read. All the PYQs and then the books. So if you read the PYQs, you know what is regularly coming. If you read the books, you know what has not come, and if may come, you are able to answer. That's how you prepare. Medicine is an endless thing, man. The whole body is your course. The whole body is your course. You cannot say that I have completed my 19 subjects. No, if we want to get tough with you and you're a postgraduate of Gynae, I am your examiner, I'll ask you something which has never been asked. But it is seen by us in the OPDs regularly so many times. So we can ask you anything, because you know my professors can ask me anything even now, and I'm scared of meeting them sometimes, that am I good enough to even stand in their presence, because they know much more than me. So please, medicine is an endless science. What we are doing is a revision, guys, of the regular things. Okay, good you asked me this question. Let's move on. So contraindication of COCPs, pregnancy you obviously cannot give, and lactation, it cause inhibition of lactation, because this high COCPs will go and inhibit the estrogen component. The estrogen component is the culprit. So that estrogen component will reduces the prolactin, and it also reduces the alpha the high estrogen. So when a woman is pregnant, naturally the estrogens are high and alpha lactalbumin is reduced. So moment the delivery happens, the breast production starts. Now when the breast milk production has started and she is breastfeeding the child and you give estrogen again, so that will inhibit the breast milk production. So it reduces the alpha lactalbumin and also reduces the prolactin. So liver disorders, estrogens are metabolized in the liver. You cannot give in cirrhosis and hepatitis. Uncontrolled diabetes and lipids. Mark my words, I am saying uncontrolled diabetes and uncontrolled lipids, because if a woman has controlled diabetes, COCPs are not at all contraindicated. In fact, you ask me what is the best contraception for a woman with diabetes, which is controlled. I'll say COCPs and I'll say IUCDs, both can be given, but it should be controlled diabetes. Now, history of deep venous thrombosis, thromboembolism, that is also a reason, because the estrogens causes the arterial thromboembolism, the progesterones will cause the venous thromboembolism. So that's why these are, if the patient has this, then it is contraindicated, and coronary artery disease. Then blood pressure, yes, you must understand, if the blood pressure is more than 160 by 100, in fact most books will say 159 by 99. So basically that is just to say, if it is touching 160 by 100, you should not give. So mild hypertension you can give, but high you cannot. Smokers you cannot give. Age more than 40 years, I'm sorry, I'll just come to smokers. Age more than 40 you cannot give because it increases coronary artery disease risk. Smokers more than 35 you cannot give. If a woman is a chain smoker or at least 15 cigarettes a day, then she is as it is increasing her risk of coronary artery disease. And on top of that, if you give COCPs after 35, you will increase the risk more. So, normal woman stops COCPs at 40 years. Smoking women stop COCPs at 35 years. That's the meaning of this statement. Migraine with aura, don't give. No contraindication, I made it highlighted. This was your MCQ. If there is STD, if there is HIV, it is not a contraindication, please. A woman with HIV can take contraception with COCPs, no doubt. Okay, of course, they use condoms or barriers to prevent the infections to the partners, but yes, they can easily take COCPs. And starting COCPs ideally is day 1 to day 5. But remember 7 days, that 7 days thing you must remember. It takes 7 days for the effect to establish for the first time. 7 days for the effect to establish for the first time. Remember that, okay? So, suppose you're starting in May for this woman. For the first 7 days, the effect is not there. It is not true for June, July, August. No. For the effect to establish, it takes 7 days. After that, she is protected throughout whenever she is taking. Only for the first time, for the first 7 days, we say. Okay, starting ideally is day 1 to day 5. Day 1 is what? Starting of periods. Starting of periods from that day to 5th day, anytime she can start. Now, mixed pills. Now, that is what is important. Mixed pill. What is that? Mixed pill se pehle. Risk of hepatic adenoma and CSF adenocarcinoma. Hepatic adenoma, yes, but not hepatocellular cancer. CSF is adenocarcinoma type, yes. Gallbladder stones, yes, but not gallbladder cancer. Good. Okay, missed pills. If 1 or 2 missed pills, if she misses 1 tablet, tomorrow she takes 2. If she misses for 2 days, then again she takes 2, not 3. So, 1 or 2 missed tablets, take 2 and continue the pack. Whatever she is taking, continue the pack. But yes, if she's missed 3 or more, if she's 3 or more is missed, contraceptive effect is lost. You know that the contraception is because of the constant estrogen progesterone tablet which I am giving and constantly suppressing the FSH and LH. So, there should be constant suppressor of FSH and LH. If she misses 3 days, that means the suppression of the brain is gone and the pituitary will start firing again and she may actually ovulate because there is a rebound kind of phenomena. The high FSH and LH will make her ovulate very fast, and that is why we say that do not miss for more than 2 days. If she's missed 3 days or more, then the effect is lost, and that's when we have to think in terms of restarting the whole procedure again. Yes, you will have to give. Now she misses 3 or more, don't say 4. You have to, she has to take 1 tablet she takes today and continue without a break. Continue without a break. Okay, so if she's in the she's, let's say, on the 15th day of the month, she comes and says, sir, I've been taking it regularly, but for the last 3 days I missed. It is the 15th day of my cycle. So, you will tell her that, yes, now start and don't take a break, because in another 6 days, you would have come to day 21 and that 7 days iron tablets would have started. So, don't take a break because it will take 7 days for the effect to re-establish. So, yes, if you have missed for 3 days or more, you take 1 tablet and continue without a break. So, whatever extra pills you had, you can throw. You can start a new pack. It is like starting it again. So, take 1 tablet and continue without a break. Extra pills have to be thrown off. Now, the problem is, if she had sex, this was NEET exam question. If had sex in this missed period, then emergency contraception to be given. Yes, we have to give her an emergency contraceptive pill. So, remember, 1 tab is given and she continues without a break. It is like starting again. So, next 7 days, she has to take a alternative method because it's going to take another 7 days for the effect to establish. And if she had sex in these missed pill days, she has to take emergency contraception as well. Right. Okay, so if your connection was lost, I would request you to just pause and rewind. It's in recorded also, it'll be there. I'm so sorry. We have to do a lot of other topics, my friend. I'm so sorry. We'll just get on with this, okay? So, Miss Pill is there in front of you still, okay? Don't feel bad. You can always rewind and listen to me again because it's being recorded, okay? Chalo. Now, basically, FSH and LH, you remember? Now, with that, we'll understand PCOS also. You'll see the incidence of PCOS is 1 in every 5 girl is PCOS. Yes, 1 in every 5 girl is PCOS. 15 to 20% of all women are PCOS. So, yes, the main criteria for PCOS are 3. Any 2 of these are enough. There are 3 criteria, more than equal to 2 are enough for the diagnosis. Classically, we have all these 3. So, clinically, the Rotterdam criteria, see, this is initially the Rotterdam criteria, and this Rotterdam criteria is the one which was formulated in 2003. After that, it's been accepted by almost all the societies, the Androgen Access Society, the European Society of Human Reproduction, American Society of Reproductive Medicine, everybody has accepted this. So, yes, 3 criteria. Hyperandrogenism means clinically hirsute, she is hairy, clinically hirsute. You have to go by the Perryman and Galloway scoring. You will not say that she's got prominent eyebrows and prominent locks, so she's hirsute. No. A lot of girls have prominent eyebrows and side locks. That is not hirsutism. She's got upper lip hair, she's got chin hair, she's got intermammary chest hair, she's got abdominal hair, upper back, lower back, and upper thigh, lower legs, okay, arms, shoulders, all these places. There are 9 sites of Perryman-Galloway. Each site is given score from 1 to 4, and a score of more than 8 is hirsutism by Perryman-Galloway scoring. That was also INI-CET question. So, yes, let's see. If clinically she is hirsute is fine, otherwise laboratory increase in androgens, the androgen level of testosterone, androstenedione, if they are high, that is also going to be enough for us to say she is having hyperandrogenism. So, either clinically or laboratory, either one of them is enough. Anovulation is the most specific. Yes, we'll spend some time here to understand this. It's the most specific feature, and ultrasound picture. I'll just explain that to you. Ultrasound picture. So, any 2 of these. Classically, you will have all the 3. Hyperandrogenism, anovulation, HA is hyperandrogenism, anovulation, PCOS morphology. This is the most common PCOS type seen, but they can be combination of the other 2 also. Gross appearance of ovaries in PCOS. Now, that's what I want you to spend some time. So, gross appearance, polycystic ovary. Please, polycystic ovary, like the name suggests, it does not have many cysts. Please do not say polycystic ovary is many cysts in the ovary. So, that's where we are wrong many a time. So, please, polycystic ovary is a misnomer because at that time the definition of the cyst was not there. So, Steen and Leventhal, wonderful gentlemen, they discovered PCOS and they described it, but they called these small follicles as cysts. So, with respect to them, we have kept the name going. Polycystic ovary has no cysts, okay? There are multiple small follicles, okay? There are multiple small follicles which are not increasing, and there is thick stroma. So, yes, guys, I hope you are not still reading the old criteria, okay? Small follicles of 2 to 6 millimeter in size, always less than 9 millimeters, more than 20 per ovary. 12 and more per ovary is ancient now. Okay, ages back that criteria was there. Once it comes in books, we are very vehement. You must know what is in the books. Okay, yes, so more than 20 per ovary. And then the trauma is thick and mild enlarged ovary. Mild enlarged ovary. Remember I told you the size of the ovary is 3.5 into 3 into 2.5 centimeters. So, what is the volume? Multiplied by 5/9. Okay. So, length into width into breadth into 5/9 is the volume of the ovary. And in the case of PCOS, normal ovary, it's a volume of an ellipsoid. In maths, they teach you an ellipsoid, volume of an ellipsoid. So, this is volume of an ellipsoid, and then if it is more than 10 cubic centimeters, that is the PCOS ovary. Large volume. We don't say it's a big cyst of the ovary, just that the ovary is a little larger than normal. All right. So let us see what happens in PCOS. So guys, quickly we'll do this revision. I hope you're not getting distracted. You ask me something else. Hi Kashif, good to see you here. And right, so let's do the PCOS cycle. Let's do the PCOS cycle now, and we'll do a quick revision and no distraction again. We discussed about the normal, we discussed about FSH and LH. Now let's see this. So yes, in PCOS there are multiple small follicles and there are more than 20 per ovary. So these small follicles are not the primordial size, they are antral follicle size. Look, I already told you they are 2 to 6 millimeter. So this also came in, I think it was MCA exam. Antral follicle, they are antral follicle size. 6 to 7 follicles are normally seen in a woman. More than 20 follicles are seen antral size in a PCOS woman, and they are 2 to 6 millimeter in size. So they are not the very small primordial, they are not dominant also, but they are 6 millimeter size. They start making estrogens. They make estrogens. It's not a dominant follicle, but some estrogen is made. Now there is some estrogen made by so many follicles, 20 in one ovary, another 20 in the other ovary. So there are 40-45 follicles. So the estrogen is progressively increasing. So the endometrium is progressively proliferating. And this high estrogen gives a message to the brain to increase the LH. So it looks the same, yes, but the size of the follicle is what is important. Size really matters, isn't it? So size should be at least 15 to 20 millimeters for it to rupture, but the follicle is small. So the small follicle does not rupture. When it does not rupture, which hormone which was supposed to increase after ovulation, yes, will not increase? Progesterone. Which hormone will continue to form? Estrogen. And because of the estrogen, the endometrium goes on proliferating and proliferating. So that's why day 14, day 28, day 60, day 90, endometrium is only proliferating. It can be 120 days also. I know girls who get periods once in a year sometimes. So yes, PCOS, the periods are delayed because there is anovulation and there is only estrogen, there is no progesterone to cause secretion and stabilization, which I told you. So yes, now you understand there is anovulation, infertility, and the periods are delayed. More than 35 delays, oligomenorrhea. More than 90 days delayed, more than 6 months delayed, amenorrhea. How does the woman finally get periods? The blood supply, oh God, I'm reversing the colors. Blood is in blue here in my chart. Never mind. So this blood supply which is going to the top of the glands cannot get blood supply anymore because they are just too tall. So the top of the glands become ischemic. The ischemia causes the shedding of the endometrium, and that's why this ischemia is not always sudden for complete glands. The top becomes ischemic. So that top sheds and cause some bleeding. After a few days, these glands will become ischemic and they will cause the bleeding after a few more days. So that's why there is irregular bleeding and delayed bleeding in PCOS. So yes, now you understand the delayed cycles. Why is there hyperandrogenism? Because of high androgens. Where are the high androgens coming from? From the stroma of the ovary. Yes. Please don't say the estrogens are converted. Androgens are converted to estrogens, and PCOS, the estrogens are converted to androgens. Please don't say that. That's a big joke, guys. Don't say estrogens never convert back to androgens. Would have been very difficult to, have normal humans behaving then. Because androgen convert to estrogens and the estrogen will convert to androgens. Then how does a person stay a man or a woman? Thank God it's not vice versa. Please don't say that, okay? Androgens convert to estrogens in the ovary. And don't say estrogens also convert back to androgens. No, not at all. So this androgens are coming from the stroma of the ovary. The stroma of the ovary is normally stimulated by the LH to make the androgens. Remember that. Now guys, let's start revising. Concentrate guys. What is the purpose of FSH? Make estrogen. What is the purpose of LH? Make progesterone. Remember those two punchlines. We've discussed that today also. Now, what is the amount of estrogen in the PCOS woman? It is high. So, the FSH is always low in PCOS. So, FSH is low. Now, what is the purpose of LH? LH is to make progesterone after ovulation. Is this woman ovulating? No. Is there any progesterone form? No. So there is no feedback to LH. There is no feedback to LH. And what is the cause of the LH increasing? The high estrogen causes the LH to rise. Remember, I told that to you in the beginning of this session. So the LH is high in PCOS and the FSH is low in PCOS. So that's why we say the LH FSH ratio in PCOS is more than 2:1, and for diagnosis we say it is more than 3:1. This is a better answer. And this high LH, yes, the LH is going through the roof in PCOS, guys. This will act on the thicker stroma than usual and make more androgens than usual. So that's the cause of the hyperandrogenism in PCOS, the excess androgen production from the stroma of the ovary. All right. So now you understand the LH-FSH ratio importance, right? So let us now summarize what we discussed. Yes, syndrome, PCOS, anovulation, infertility, that we understood. Then hyperandrogenism, because of increased hyperandrogenism there is hirsutism, and periods after 35 days oligomenorrhea, after 6 months is amenorrhea. Now that is the syndrome. I have already written that for you. And the lab parameters, LH-FSH ratio is more than 3:1 for the diagnosis. Normally it is 1:1. Okay, normally it used to be 1:1 in normal women. So don't keep saying it gets reversed. Normally it is 1:1 LH and FSH. What happens if it gets reversed? We'll say 1:1. So a lot of you keep telling me funny answers sometimes. LH and FSH normally is 1:1 and PCOS get reversed. We'll stay 1:1 if it is reversed also. So it increases 3:1. Okay guys. So androstenedione is increased, testosterone is increased. Now these androgens which are made from the stroma of the ovary, they are bound to something called the sex hormone binding globulin. Now this sex hormone binding globulin is made in limited amount by the liver. Liver makes a limited amount of SHBG. SHBG protein binding androgens. This is limited in the liver. But the androgens is just too many because the stroma is there. So now you have a problem. There are just too many androgens. The liver cannot make so much of SHBG. Let us compare this to 5 gundas and 5 policemen. 5 gundas can be taken care of by 5 policemen. But these gundas are just too many. There are 50 gundas and there are 5 policemen. These 5 policemen cannot take care of these 50 gundas, right? So that's how we say there are too many androgens to be bound by the proteins, the sex hormone binding globulin, which is limited. So the net result is there is increase free androgens, and those increased free androgens really causes the hirsutism. So yes, all of that we discussed about PCOS. Come guys, again, all of that we discussed about PCOS is the ultrasound picture which I told you. There are multiple small follicles. The small follicles is the punchline of PCOS. Small follicle, guys, quickly, I want to do PCOS once more. Fatafat. Small follicle does not ovulate, infertility. Small follicle does not ovulate, so there is no progesterone. So there is no feedback to the estrogen action. Okay, so estrogen, okay, I'll take it other way around, make it simpler. Small follicle does not ovulate, infertility. When there is no ovulation, there is no production of progesterone. But what production goes on? Estrogen production goes on. So endometrium goes on proliferating very tall. Now, the high estrogen is also the cause of the LH to increase. And the LH purpose is to make the progesterone, but there is no progesterone, so there is no feedback to LH. LH goes on increasing, acts on the stroma and causes the hyperandrogenism. So yes, now you understand, anovulation causes infertility, anovulation causes delayed irregular cycles, and when there is no ovulation, there is no progesterone, no feedback to LH, and the LH is high because of the high estrogen, and that high estrogen causes the stroma to make a lot more androgens. So everything is explained by the small follicle. Why is the follicle small? Why is the follicle small? That's the main cause of PCOS, yes? The follicle is small because of the insulin resistance. Yes, the insulin resistance only on the ovarian receptor. So, insulin resistance, that is what you have to remember. Insulin resistance only on the ovarian receptors, and that's why the energy, the amount of glucose utilized by the ovary is less, and you need energy for the follicle to grow. Anything needs energy. I need energy to, I'll have to take a water break. I need some, maybe take a cup of tea while I'm taking this class because I need energy to continue this class. So energy is required for the follicle also to grow and become a bigger follicle, and that energy is not there because there is insulin resistance on the ovarian receptor. That's why the follicle is small. All right. So that's why you say insulin resistance is part of the syndrome, and it is also associated with obesity. It is also associated with obesity. So that is now the complete syndrome. And in the lab test, increase fasting insulin levels. Because the increased fasting insulin levels, the fasting glucose to insulin levels, fasting glucose to insulin levels, that ratio is less than 4.5. That also came in one INI-CET exam a few years back. Of course, the fasting insulin only, fasting glucose to fasting insulin is less than 4.5 because the insulin is very high. So that's what is the reason, insulin resistance for the PCOS. Now, why is there insulin resistance? You can ask me that. Of course, don't say the girl is diabetic. She's only 17 years and she has PCOS. It's because of insulin resistance on the ovarian receptor. Why is there insulin resistance? Okay, fine. That could be inherited, that could be familial, that could be environmental. So there are many things. It's the PCOS occurrence is known to be polygenic. There are many factors. So PCOS is an endless problem. That's why I try to make it a very short discussion. But that also was possible only if you read the hormones. So I promise that I'm going to increase the pace of the class now so that we have done the PCOS understanding. So simply remember that PCOS is associated with acanthosis nigricans, dark shiny velvety deposits on the nape of the neck, and then there is a syndrome X, metabolic syndrome. What is metabolic syndrome? Increased weight, increase waist more than 35 inches, increased lipids, increased sugars. So increased blood pressure more than 130/85. 5 things I told. That along with PCOS will cause more coronary artery disease. So metabolic syndrome plus PCOS is equal to more coronary artery disease. That's why we say PCOS later in life can have more coronary artery disease, more diabetes mellitus, and more CA endometrium also. But very important also CA ovary. Yes, come. I'm taking a water break. Come, let me. Tell me, come, I'm waiting. What is the drug of choice of PCOS? Come, I'm waiting. I'm going to see what you guys have, been learning before we do this quick discussion on the treatment. Yes? Lifestyle management is fine. Drug of choice. No, drug of choice. Don't tell me this. Drug of choice of PCOS I want to know, because a lot of you will ask me in the breaks where I'm taking a live class, or you'll send me messages while I'm doing this. Drug of choice of PCOS all over. Yes. Metformin, letrozole. I'm waiting for your answers. Come guys. OCPs. So yes, I got the answers which I was looking for. Yes, thank you so much. Now let's start. So please, the biggest problem is that you get some questions from so many sources saying what is the drug of choice of PCOS. And the bigger problem is you have answers from many sources saying the drug of choice of whole of PCOS is one drug. Guys, PCOS is a syndrome. And a girl will come to you with a peculiar problem, a particular problem. A girl is 17 years, she has irregular cycles. You want to give her letrozole for ovulation induction? She's not even planning a pregnancy, she's 17. She has got a problem of irregular cycles. A woman who is coming to you at 25 years and she's married for 3 years and not getting pregnant, I want to give her letrozole, clomiphene citrate. If a girl is coming to me at 26 and saying, sir, I've got a lot of acne, hirsutism, and my cycles are irregular. So I will have to first take care of the hirsutism. I'll give her anti-androgens. For irregular cycles, I'll give her COCPs. So it depends on what symptom she's come to you with. So there is no one drug which is the drug of choice of PCOS. No, that nothing like that exists. I've been teaching PCOS, I've been managing PCOS all my life. I'm taking care of a reproductive medicine department. And for me, PCOS is like a daily bread and butter kind of a situation. And I still cannot fathom that somebody is going to ask me the drug of choice and then expect the answer for one drug which can take care of complete PCOS. Nothing like that exists. So what is the particular problem? People come to me because they are having an infertility problem. I give them clomfencetide, I give them letrozole. One young girl is sent to me by her relative saying, sir, this girl is 19, she's having irregular cycles. I'll give her COCPs or other methods. So there's no one drug of choice, okay? So I took some time to tell you that. So good, Dharmesh, you're giving me the answer which I like. So lifestyle management, yes. Lose weight, exercise and diet, good. So specific management for irregular cycles, yes. For irregular cycles, if you ask me, drug of choice is COCP. It gives her an artificial cycle. Remember, she'll have regular cycles with COCPs only as long as you give the COCPs. Then you can also, we can support the later half of the cycle. We can support second half of cycle with progesterones. Look, she's a lady who is having high estrogens, but there's no progesterones. So yes, her cycle is something like this. Let me draw here. Her cycle is something like this. She's continuously proliferating only. So 0 day, 14 day. You want her to have progesterones, but she's not making. So I give her tablets of progesterone from the 14 day for 10 days, and that is going to make the endometrium secretory. It makes the endometrium secretory. So for 10 days, yes, for 10 days I give her progesterones. So I just make the endometrium secretory by my tablets. So for these 10 days, the endometrium will become secretory. When I stop the tablet, in a few days she gets a period. So you can give her COCPs, an artificial cycle, or you can support the later half of her cycle because she's making estrogen. I can give her progesterone from outside, and I can give her regular cycles for her 10 days of progesterone. Sometimes we give it only for 5 days. That also will give her regular cycles. And then hirsutism, we give anti-androgens. Please, for heaven's sakes, don't say COCP is the first line. Please, a lot of you will tell me, sir, COCP is the first line of hyperandrogenism. No, not at all, man. Anti-androgens are given. COCPs have estrogen and progesterone. So yes, the regular COCPs have estrogen and progesterone. That is not giving anti-androgen action. So you have to give special drugs if you want to discuss about combined drugs. We'll discuss that also. But if a woman is having hirsutism, anti-androgen, and that is spironolactone, and it is cyproterone. These are the drugs, and the first line drug is mostly the spironolactone, which we start. We start by 50 milligrams per day. Now, what is the treatment of the anovulation? Yes, this is what is known as ovulation induction. We do an ovulation induction. So yes, ovulation induction, just quickly remember the hypothalamus once again, jaldi se kar lenge. Pituitary, ovary, follicle, estrogen, feedback to the brain, which is negative feedback to the FSH. So this we know very well. Now let us compare this with the PCOS cycle. Slightly enlarged ovary, multiple small follicles, and this having thick stroma, it makes a lot of estrogen. You know that the estrogen in this woman is much higher. Estrogen in a PCOS woman is much higher than a normal woman. This high estrogen is giving a negative feedback to the FSH. So this is a PCOS lady, comparing her with a normal lady here. So when there is a PCOS lady, this PCOS lady is having high estrogen, gives a feedback to the brain and stops the FSH. Now, how can I make her ovulate? We can fool the brain now. The brain thinks that there is enough estrogen. So brain is keeping the FSH low. Guys, same line. FSH is for estrogen. Remember that line. FSH is coming from the brain to make estrogen. Now this woman, PCOS, is having so much of estrogen. And that high estrogen giving a message to the brain is very happy. Oh, there is enough estrogen, I'll keep the FSH low. So fool the brain in PCOS, fool the brain with a roadblock, fool the hypothalamus, tell the brain that there is no estrogen at all. Brain thinks there is no estrogen, brain will increase the FSH. Yes, FSH is for estrogen and there is high estrogen, the FSH is low in PCOS. Remember the LH-FSH ratio is more than 3:1 in PCOS. So that FSH which is reduced, I can increase the FSH by giving a feedback inhibition to the brain. So there is high FSH and that will make one follicle become bigger and now the woman will ovulate. So yes, this is a hypothalamic estrogen receptor blocker, clomiphene citrate. It's a hypothalamic estrogen receptor blocker, Yes, the dose is 50 to 150 milligrams per day. It is given from the second day, day 2 of the month to day 6. Day 2 is the second day of bleeding to day 6 and it causes ovulation in 80% women and pregnancy in 40% women. Now, we have another method of increasing the FSH. We know that the androgens are converted to estrogens by the aromatase. Now we can inhibit this. So there will be lesser estrogen or there will be no estrogen production because we have inhibited. So follow the blue. When you give an aromatase inhibitor, there is no estrogen production. Again, what is the purpose of FSH? To make estrogen. With the aromatase inhibitor, I reduce the estrogen in the body. So the brain thinks there is no estrogen, brain increase the FSH again. So yes, when there is reduced estrogen, there is increased FSH by the brain and that will cause the ovulation. So this aromatase inhibitor is known as the letrozole and this letrozole is 2.5 to 5 milligrams, again day 2 to day 6. But this letrozole, the benefits of letrozole, you must remember lesser twins because 10% twins with clomiphene citrate. Twins are supposed to be obstetrically complication. Twins is going to cause lot of obstetrical problems. So that's why lesser twins, only 3% with this. Better endometrium and lesser anomalies. Whatever pregnancies happen will have less anomalies if you're giving letrozole. So that's why letrozole is now called the drug of choice for ovulation induction. Please don't say it is a drug of choice of PCOS. For ovulation induction. So what did you do in these two conditions? Both the conditions you increase the FSH. Increase the FSH here and you increase the FSH here. So both the conditions you increase the FSH. Rest. So what do you do? Yes, what do you do in this? All these conditions you have increased the FSH. So FSH is increased and what we can do, we can also give some special drugs called the injection of FSH, injection of human menopausal gonadotropin. These also can be given. What are you doing? By letrozole, increasing FSH. What are you doing by clomiphene? You're increasing the FSH. So give FSH injections or human menopausal gonadotropin. Human menopausal gonadotropin is a combination of FSH and LH. You can give these drugs and they can also help the woman have a ovulation. Right. So that's about the ovulation induction. So sometimes women do not respond. Look guys, what did I tell you so far? I told you irregular cycles, COCPs, hyperandrogenism, anti-androgen drugs, and for ovulation induction, letrozole, clomiphene citrate. All right. We can also give metformin. Yes, metformin will increase the sensitivity, but don't say it is the drug of choice. Don't say it's the first line drug also. Please, it is not there. It is accepted by all standards. All colleges have said that metformin is a good drug to help, but not the drug of choice and not the first drug to be started. Remember, metformin can also be given. Okay. So yes, when a woman is non-responsive to treatment, sometimes whatever FSH increasing drugs I give, clomiphene citrate, letrozole, I give them the highest dose possible. I give injections of FSH, very high dose, she does not respond. Because the stroma sometimes is so thick. See this stroma here, can you see? This stroma is so thick, that thick stroma, can you read? The high local androgens from the stroma makes the follicles hard and prevent the response and growth. So to make the woman have ovulation, we reduce the local stroma by burning the stroma. Burn the stroma, not burning the follicles, right? So that is what is known as the surgical treatment of PCOS, laparoscopic ovarian drilling, LOD. Laparoscopically, we use a cautery. Burn the ovarian stroma by laparoscopic ovarian drilling. We use a cautery, and with that cautery, we make 4 to 6 holes. We burn the stroma. 4 to 6 holes are made in the ovarian stroma. We burn the stroma, and when the stroma is less, there is lesser local androgens, and the ovarian follicles respond better to ovulation induction. All right. So reduce the local androgens, increase the follicular response. So yes, this is the question which I wanted to ask you. A 23-year-old girl, she's having irregular cycles. So you can give COCPs, and she's having hirsutism, or they'll say acne. Acne is also because of high androgens. So same thing. It's either they'll ask you hirsutism or acne. So yes, now what you can give? For irregular cycles, you can give estrogen and progesterone. So we give ethinyl estradiol, and you can give cyproterone acetate. Wait a minute, sir, you said you give estrogen for the proliferation of the endometrium and progesterone for the secretion of the endometrium in OCPs, estrogen and progesterone. But why are you talking cyproterone now? Because cyproterone is a progesterone which has an anti-androgen action. So yes, this combination is a good drug to be given for a woman with irregular cycles and hirsutism. So I can give this. Okay, ethinyl estradiol will cause the proliferation of the endometrium. Cyproterone will cause the secretion of the endometrium, but this also causes the anti-androgen action. So that's why it's a very good combination. It's a estrogen with the drug which has got progestational action and an anti-androgen action. Similarly, we have another drug which is the ethinyl estradiol, which causes proliferation, and we have a drug called drospirenone. This drospirenone is going to cause secretion and anti-androgen action both. So that's why we have two drugs. One is ethinyl estradiol with cyproterone, but the latest drugs, the newer drug is the drospirenone. This drospirenone is available as Yasmin, this drug, this combination. Yasmin is the international drug. In India, we have Yamini, which is similar. So a lot of estrogen and anti-androgen drugs are combined. Those anti-androgen drugs are basically progesterones. So progesterones with anti-androgen drug, that of course can be given for a girl with irregular cycle and hyperandrogenism. All right. Endometriosis is ectopic endometrium. The etiology is the Sampson's theory of retrograde endometrium, and this retrograde endometrium happens to a lot of people, but incidence is only 10%. Those women who have increased estrogen and poor immunity. So you know that etiology. I'm here to just tell you a few important aspects of the endometriosis treatment. So 10% women will have endometriosis. Retrograde menstruation happens to 90% of women, but those women who have lesser estrogen, lesser immunity, they cannot clear these deposits, and they have high estrogens, so they keep on proliferating these deposits. So these endometrial glands, basically menstrual blood which is going retrograde, it is going to many places in the abdomen like the ovary, pouch of Douglas, bowel surface, and that's why the woman has very bad endometriosis. So yes, the types of deposit which you see, this can be a deposit in the ovary, and the ovary starts behaving like a uterus and starts menstruating within the ovary. So that's why you have a chocolate cyst of the ovary. And then these deposits, these are foreign bodies for the body, and the macrophages, the immunity will try to come and heal these areas, and healing happens with a lot of fibrosis. So the next problem are the adhesions. Can you see? These adhesions are a nuisance in endometriosis. Because these adhesions, the tube and the ovarian relation, you know that the tube should be over the ovary. So when the ovary ovulates, the tube catches the egg, and this tube should be having peristalsis also. Now this tube is stuck behind somewhere in adhesions. Ovulation happens here, but the tube is stuck with adhesion somewhere. So that's why there is infertility in endometriosis. So adhesion is a major problem. And then you have these blue spots or the powder burn lesions. Blue spots or the powder burn lesions. So powder burn, powder is gunpowder. Burnt gunpowder looks like this. On the matchsticks, you have gunpowder. When you light a matchstick, it leaves a blackish bluish residue. So the most common site is the ovary, and the second most common site is the pouch of Douglas, right? It can also be, these deposits can also be in the surface of the uterus, surface of the bowel, diaphragm, but can also be there sometimes in cesarean scars of the abdomen, not of the uterus. Scar endometriosis is on the abdominal uterine scars, okay? Sorry, abdominal rather than uterine, I meant. It is on the abdominal scar rather than the uterine scar. So abdominal scars will have this scar endometriosis, and every month they will keep growing, this area will keep growing bigger and bigger, and she'll come with a lump on her abdomen where the scar of the cesarean is, and she'll say, "Sir, this is hurting me every month for 5 days." So that is the scar endometriosis. Treatment of that is local excision. Now symptoms are pain abdomen, menorrhagia because there is high estrogen, and infertility, I told you already, because of the altered tubo-ovarian relation, and also because of the fact that there are poor quality altered tubo-ovarian relation, that you understand, but also poor oocytes, poor oocyte and poor embryo quality. Because there is so much of chocolate fluid, which is basically degenerated blood. The dead RBCs, they have their own interleukins and cytokines which destroy oocytes and destroy embryos. If there is a embryo somehow formed, it will implant somehow, there will be more abortion of those embryos. So that's why there is infertility in endometriosis. Diagnosis can be done by ultrasound most of the time. So we have this CA125 which is high, which will help, but remember, high CA125 is not diagnostic because it is high even in ovarian tumors. Many other things like fever and gut tumors, but it is not that we don't use it. CA125 is high and there is ultrasound suggestive, so yeah, it is helpful, but it is not specific for ovarian, not specific for endometriosis because it is high in many other conditions. Ground glass cyst on the ultrasound, see here, this ground glass cyst, the cyst is having blood, so when the sound waves go through, there will be this shady kind of ground glass. You must be seeing this in the offices, the glass doors. You know that somebody is walking inside the office, but you don't know who, because the ground glass will not let you see through. So ground glass appearance. Clear glasses you can see through, isn't it? So yes, ground glass appearance, but the best diagnosis is by a laparoscopy plus the biopsy of the lesion. You see the lesion. See, I told you these lesions. I do the ultrasound, I do the laparoscopy, and I see these lesions. When I see these lesions, I know that this is endometriosis to my look. I take a biopsy and send it to the path lab. Path lab confirms that yes, this is this deposit which you sent. This is basically menstrual glands. Okay, so you will see blood-filled macrophages in these areas. The macrophages will try to eat up that menstrual blood. So you will see blood-filled macrophages. So the best diagnosis is the laparoscopy with biopsy. In imaging, best is always MRI. So ultrasound is good, and even MRI we can do, but that is, MRI is always the best imaging. But we are talking not about the best imaging. We always ask you the best diagnosis. So usually an ultrasound is enough for making the diagnosis, but the best diagnosis by the laparoscopy and the biopsy. Diagnosis done. So after diagnosis, okay, after diagnosis, surgery to remove all the gross disease. So cysts, you can do a cystectomy, adhesions, you can do adhesiolysis, but the small deposits, see these small deposits which I showed you, can you cut these deposits? See, this cyst, you can do a cystectomy. These adhesions, you can do a adhesiolysis. But what about these small deposits? These small deposits, actually there is a big problem, because these small deposits cannot be taken care of because there are multiple such small deposits. There are so many such small deposits that you cannot cut all over the abdomen. So these are burned, these are fulgurated. So we fulgurate them. We burn these deposits by laser or by cautery. So that is what is known as fulguration. the small deposits. All right. So small deposits, I'll write that word at least, fulguration. Right. Remember, there is 60 to 70% recurrence in endometriosis. 60 to 70% recurrence is there. That's why we must give medical treatment to suppress. So surgical treatment to remove and medical treatment to suppress. So what is the cause of endometriosis? I told you in the beginning of the session, high estrogens. High estrogen is the cause. To suppress the recurrence 60 to 70%, you have to suppress the estrogen. So how do you suppress the estrogens? You suppress the estrogens by giving COCPs, which will reduce the estrogen in the body, I told you. Okay, so pain relief, basically reduce the estrogens, I told you. Pain relief can be given by the NSAIDs, and you can also give the COCPs, because COCPs make the cycles anovulatory, and anovulatory cycles are painless. So yes, you can get pain relief by COCPs also and by NSAIDs also. But disease control in endometriosis, COCPs long term will limits the endometriosis. Progesterons like depomedroxyprogesterone acetate, which is given 150 milligrams every 3 months. This is high dose progesterone. You can also give Dynogest, you can give Dynogest 2 milligrams daily. These drugs will suppress the proliferation altogether, because you're giving continuously progesterone. Remember, I told you progesterone causes secretion and stabilization. Now you're continuously giving the progesterone, it suppresses the proliferation at all. So that's why it causes atrophy of the endometrial glands. So yes, wherever there are the glands of endometriosis, they will stop growing. Of course, the periods will also stop, because the uterine glands also won't grow. But that is accepted side effect, because she's getting pain relief. Very painful condition, this endometriosis. So progesterone will cause atrophy, continuous progesterone, okay, not for just 14 days like normally women have. Continuous progesterone for 1 or 2 years we give. That causes atrophy of the endometrium within 1 or 2 months. Then you can give androgens, faster atrophy like danazol or gestrinone, also another drug. This causes faster atrophy. Of course, the side effect of this is that it's going to cause hirsutism and even virilization. Mind you, virilization is permanent. Clytomegaly, breast atrophy, hoarseness of voice. These are permanent changes. So remember that within maybe 1.5 years, mostly we start seeing these changes. So we keep an eye. Generally, danazol is not given more than 9-10 months, 1 year maximum, because we know that permanent virilization can happen. So you can give androgens, faster atrophy, GnRH analogues. Yes, you know the method of GnRH analogues. We give a continuous therapy, So like the pituitary will release the FSH and the LH, which acts on the ovary to make a follicle. But this pituitary is stimulated by the hypothalamus. So this is by the GnRH, and this is a pulsatile release. So when you give this continuously, GnRH is the same action. The hypothalamus acts on the pituitary by GnRH in a pulsatile form. But if you give GnRH analogues continuously, high dose, continuously, you are stimulating the pituitary continuously. The receptors of pituitary are not machines. You stimulate them once, they need relief, because it is once in 90 minutes in the luteal phase, once in 60 minutes in the follicular phase. That's the pulsatility of the normal GnRH. So you give drugs which are like GnRH. What are those drugs? Like leuprolin, naferlin, goserlin. We keep giving them in a high dose, so that they're continuously stimulating the pituitary. The continuous stimulation of the pituitary tires the pituitary in 3-4 days, 5 days. The pituitary cannot respond. So there is a down regulation of pituitary, desensitization of pituitary. So high dose continuous will cause the pituitary to cause down regulation. Okay, so there is no FSH, no LH, so there will be no estrogen, no progesterone, so there will be atrophy of the endometrium and the endometriotic deposits. So basically you want to do atrophy of the endometrium by GnRH, by androgens, and by continuous progesterones, and by limiting the amount of proliferation by COCPs. Their COCPs, remember, I am giving low dose estrogens for a very long time, so that also gives a lot of relief. Okay. So remember, GnRH if given for more than 6 months can cause osteoporosis. I'm not saying that you cannot give GnRH for more than 6 months. We have given for years sometimes. But if you're giving for more than 6 months even to young girls, they'll have osteoporosis because estrogen production is stopped. So remember, if GnRH requires for more than 6 months, then for osteoporosis prevention, give a add-back therapy with low dose estrogens. Yes, we can give estrogens in many forms, conjugated equine estrogens, low dose we can add. I'm not saying that when you're giving endometriosis treatment, you have to stop GnRH in 6 months. If you're giving more than 6 months, then you will have to take care of the bones. So continue the GnRH. It gives very good treatment. Best medical management of endometriosis is the GnRH and loads. But to prevent the osteoporosis, you give low dose of estrogens also along with that. All right. So hormone replacement therapy, our favorite topic. So what are you asking me before this? Treatment based on pregnancy and supposed to have a regular cycle patient PCOS but has hysteromegalovia, can supposed to have body hair since birth. Body hair since birth. No, body hair since birth is obviously androgen producing tumors or some other problems. Okay, androgen excess. It's not body hair, excess body hair since birth cannot be PCOS. PCOS presents as in adolescence, not even in puberty. In presence in adults and girls around 17, 18 is generally the age for generally most PCOS present around 21, 22. So no, I'll not say PCOS, not at all. So chali, let's get into hormone replacement therapy. The main indication, please remember estrogens are required for femininity and immunity. And the main indication of HRT is osteoporosis. And it is the vaginal atrophy. Whatever you do, remember the indications and the hot flushes. Of course, if you remember these three, I'm happy. You must remember the skin gets loose in menopausal women for loss of collagen. The facial hair will become prominent. Old, especially in women who don't go much to parlors, you'll see facial hair, ugly mustache type of hair and chin hair will start coming out, and hot flushes because of the increase in LH, increase in dopamine, increase in noradrenaline causes a vasodilation in the head, and a flash of heat goes back onto the spine and she gets suddenly irritated. Even if she's in an AC room, she suddenly get up and saying that I'm sweating, increase the AC or put the fan on, and she'll have a hot flush. She's very irritated, she's having loss of sleep, and she's angry easily, she's having depression also many times. So that's the problem with the woman in menopause. In addition to that, she'll having bones with osteoporosis. What is the most common fracture in this osteoporotic fracture? The most common fracture is the vertebral compression fracture. All right. And the pelvis will have more infections. Yes, pelvic fractures are there, but increase vaginitis, increase vulvitis, and increase atrophy of the vagina, dryness of the vagina, atrophy. So sex life also takes a beating. And osteoporosis, of course, I told you. So you must give hormone replacement therapy to women after menopause. It's not only for the purpose of periods. No, we are not giving for periods. It's for the purpose of her immunity and femininity. The complete makeup of woman changes after menopause. So for her femininity and immunity, both you have to give estrogen replacement therapy. They are contraindicated because the liver is the place where the estrogens are metabolized. So they cannot be given liver disorders. Follow-up cases of CA breast and CA endometrium, because these are both estrogenic cancers. Remember, hardly any woman is taking HRT in our country. I keep doing this exercise in the classes where I meet you people, and I'll ask you, there are 600 people, 500 people, and I'll ask you doctors, how many of your relatives are on HRT? You know, many, 90% of classes, not even one hand gets up. People don't take HRT at all in our country. People are scared. A lot of doctors keep scaring these mothers, these women who are 50, 52, 53, that if you take HRT, you will get cancers. So yes, only specialized hospitals where they're running special clinics of HRT clinics, those places HRT is given, educated people will come. But Look into your own families and see how many people are taking HRT. Not many people are taking. It's the complete femininity of woman which is based on the estrogen. So you have to give. Yes, you'll make sure that she's not having any predisposing causes of cancers. You can go ahead and give. Okay. So yes, the contraindications are uncontrolled hypertension and uncontrolled diabetes, uncontrolled lipids, just like COCPs I told you, known case of deep venous thrombosis or thromboembolic disease, I will not give. Previous coronary artery disease, undiagnosed vaginal bleeding, I will not give. Investigation before giving the HRT, that's why you must do the liver function test, lipids and sugars. If it is fine, then only give HRT. Pap smear for the cervix, mammography for the breast, TVS for the endometrium. The thickness of the endometrium should be always less than 4 millimeters, less than equal to 4 millimeters. If it is more than that, I will not give a patient the HRT. So make sure that you satisfy this. We'll also do an electrocardiogram to see that there is no predisposing coronary disease. So once all of this is fine, you can go ahead and give. I was trying to pull your leg by saying that none of your relatives are on HRT. You know, in the West, where people are, West, I mean to say the developed world, people are well aware about their, menopause, and they want to look feminine even after menopause. And that's why more than 50% women of the menopausal age in the West are on HRT. In our country, it is less than 0.1%. Yes, that's the problem. Please see, it keeps coming into exams. Why do you think it keeps coming into exam? Because the doctors in the good institutes, they all know that HRT is important, but somehow it is not percolating. I am trying a lot. I get emotional about this topic, even if it's an online class and even if it's an offline class. I keep telling you guys that HRT is extremely important for all women. But yes, you be careful, do all these tests and then give the HRT. So yes, what are the drugs? Yes, what are the drugs you give? You give estradiol tablet 1 to 2 milligrams per day. You can conjugate equine. Equine means horse estrogens. You can give 0.625 to 1.25 milligrams per day. Look, if you give these estrogens for all the body purposes, that can increase the endometrial proliferation and can cause cancers. So you must add progesterone. So you must add progesterone to reduce the CA endometrium chances. Look, why is there CA endometrium more? If you give estrogens for all the bodily purposes which are affected in menopause, you will have to give high dose of estrogens, and high doses cause the woman to have proliferation of the endometrium and cause endometrial cancers. Look guys, let's quickly go back, rewind and listen, because some of you seeing this in a recorded lecture. In this lecture, I taught you that COCPs, when I'm giving estrogen and progesterone. In COCPs, I'm giving the least dose which suppresses the brain. So the body has least dose of estrogen for 10 years or 12 years when you give COCPs. When I give HRT, I'm giving a highest safe dose because I want to take care of the bone, hair, the pelvic health, the sexual health, the mood swings, the hot flushes, the skin, everything I have to take care of. So I give the highest safe dose in HRT. So yes, this is also estradiol, and the drug which we gave in COCPs was also estradiol. In estradiol, I gave in COCPs was only 0.02 milligram. I hope you remember that. 0.02 milligram is only 20 microgram. Here I am giving 2 milligram. This is 2000 microgram. Look, the difference in the dose. That is 20 microgram. This is 2000 microgram with COCPs use. When I give HRT, it's the same drug, but I am giving a highest dose to give benefits in so many places. So this can cause hyperplasias and cancers. So when I discuss CA endometrium, the etiology will have HRT as the cause, not COCPs. COCPs prevents endometrium and HRT causes endometrium. That's how both of these were taught before I come to the chapter of CA endometrium. All right. So remember, the drugs which we're giving are the estradiol and the conjugated equine estrogens which we discussed, but we can also give tibolone. It's a synthetic estrogen. Synthetic estrogen which has a progestation metabolite, my favorite drug. You can give raloxifene. It's a selective estrogen receptor modulator. It's good for the osteoporosis. But yes, the side effect is hot flushes. So yes, NEET exam question was that you cannot give, which of the following drugs cannot be given if a woman already has hot flushes. So do not give raloxifene, because the selective estrogen action on the bone is this estrogenic, but on the brain it is anti-estrogenic. That's why there are hot flushes. So don't give when woman already has hot flushes, right? And plant estrogens like isoflavones, soya estrogen, they are good substitutes but not better. Plant estrogens are safer but not better. But now bisphosphonates, now this is where you and me are going to have sometimes, you know, we may be having different opinions about bisphosphonates. I'll tell you why. Because bisphosphonates are good, they are good drugs, and they are non-hormonal drugs, good non-hormonal agents for osteoporosis treatment. Yes, I agree, definitely. But they are not the drugs of choices for osteoporosis management in women, definitely not. The drug of choice, just in bisphosphonate, I am reminding you, drug of choice for osteoporosis prevention and treatment is HRT, no doubt about that. But the same HRT, however, remember these lines, however, HRT, if given more than 10 years, this itself increases coronary artery disease. Yes, I agree, HRT cannot be given more than 10 years. That itself causes coronary artery disease. So, therefore, after 60 years age, remember this red line, the drug of choice is bisphosphonates. So guys, I know this controversy is there. A lot of your internet sources, when you read, they'll say the first line management of osteoporosis is bisphosphonates. Yes, they are safer drugs. I agree, they are safer drugs. But are they going to take care of the other problems which a woman has in menopause? You have only osteoporosis to take care of. So if there is contraindication to all the other drugs, you can't give estrogen, give bisphosphonate. I'm not saying no. But yes, even when osteoporosis alone is asked, the drug of choice is no doubt estrogen, hormone replacement therapy. After 60 years, it is bisphosphonate. So, I'll take a liberty here to just show you Shaw's Gynecology. It is a book which you have to quote. Okay, I'm trying to quote my favorite book, Shaw's Gynecology. It's that book of reference for you. What is coming in the journals doesn't become your reference, because a lot of these sources will give you information which is contradictory to each other. All right. So, please understand, Shaw's is writing very clearly that natural estrogen and progesterone, tibolone, raloxifene are beneficial in osteoporosis if it occurs early in menopause. Osteoporosis occurring late in menopause benefits from bisphosphonates. And that's why this question came in INI-CET exam. So we are discussing INI-CET 2021 November, this question came, and after that I was thinking that the controversy will settle. There was a straightforward question, what is the drug of choice for osteoporosis management in women after 60 years? And I agree, the answer is bisphosphonate, because it is after 60 years. So if after 60 years it is bisphosphonate, so before 60 it is some other drug, right? From 50 years to 60 years of age, obviously some other drug. If they have asked you INI-CET, AIMS, PGI, JIPMER, my college, if they are asking you this drug of choice after 60 years, that means before 60 it is some other drug, right? And what is the drug? It is obviously the estrogens, and it is given in your books. So that's why books become your reference sources. Journals will say so many things which are contrary to each other. So yes, late in menopause, and see, prophylaxis osteoporosis. All the other drugs are given, bisphosphonates for late osteoporosis. K2 get to the next page in Shaw's. Other drugs for osteoporosis. We are talking about the chapter of osteoporosis and the other drugs for osteoporosis. The fourth drug is bisphosphonates. Finally, when they are discussing bisphosphonates, what are they writing here? When they are finally discussing bisphosphonates, what they are writing here? It is recommended that HRT should be prescribed in early menopausal age. After 60 years, osteoporosis should be managed with bisphosphonates. As clear as that. And they asked you this in the exams. Yes, I know there are many other opinions when you read journals and recommendations from different colleges. I mean to say Royal College. See, American College is all gung-ho about saying estrogens for osteoporosis. Royal College and Europeans, they say bisphosphonate. I know this controversy exists. What are we going to follow? What is coming in the books and what is followed in most of the HRT clinics. All right, bisphosphonates are no doubt very good drugs. For men, definitely bisphosphonates are very good. Men also, they say give testosterone and bisphosphonates. And women, of course, they say give the bisphosphonates after 60 years. I'm not denying that at all, but before 60 it is estrogens. Right, I have to stop with this one. I have to get to the next topics also. So recombinant parathormone is the only drug, the teriparatide is the only drug which makes a newborn. Denosumab is going to reduce the osteoclastic action. It works against the rankle antibodies, and this is the drug which is given, which reduces osteoclastic activity. All right. So what are you guys asking me about this? So now, in case both options given, we have to HRT if less than 60 years. Yes, obviously both choices will be given, and you have to write HRT. Yes, obviously both will be given. All right. Say endometrium, the age group is around 45 to 55 years of age. Most common type is the adenocarcinoma, but the subtype, the adenocarcinoma is the most common type, adenocarcinoma, but most common subtype is the endometrioid variety. Yes, that you should not forget. And poor prognosis variety are the serous cell variety and the clear cell variety. These are the ones which are the poor prognosis variety. Now, say endometrium is because of high estrogens, and I told you HRT will come here, not COCPs. Okay, and tamoxifen is a SERM. It is given for the prevention of CA breast recurrence after management by whatever surgery. You don't want a recurrence, you give this SERM. But remember, it is estrogenic on the uterus, so that can cause say endometrium. The tamoxifen. Anovulation condition like PCOS, they have high estrogens. And then conditions like estrogen producing ovarian tumors like the granulosa cell tumors, and then early menarche and late menopause, there are more periods and more exposure to estrogens. Obesity has more fat, and you told me that fat will convert the androgens to the estrogens by the aromatase enzyme. So that's why there will be more problems with fat women. And this line, diabetes mellitus, hypertension, obesity, this is the line which will come corpus cancer syndrome in your exams. Fat diabetic women with hypertension, classical well-to-do Indian women only will have say endometrium. Otherwise, don't say endometrium is a common cancer of India. It is always say cervix which is commoner. Say endometrium is seen, and we are becoming a fatter society, but still the upper middle class. Okay, otherwise middle class, low middle class and the poor people, we still have more CA cervix. Okay, nulliparity, no break from menstruation, no break from estrogenic action. And familial predisposition, there is CA breast, CA endometrium and CA ovary. If you remember these three, CA breast, CA endometrium, CA ovary. If a woman has these three, any one of these three, I mean to say, if a woman suppose has CA breast, what is the familial predisposition? If a woman has CA breast, her first degree cumulatives, her mother, her sister, her daughter can have CA breast, can have CA endometrium or can have CA ovary. Don't say CA cervix. CA cervix is not a familial cancer. It's a CA cervix is a more lifestyle kind of thing, because CA cervix is because of HPV, right? So yes, all of that etiology causes hyperplasia. Hyperplasia can be simple endometrial hyperplasia without atypia. It can be complex endometrial hyperplasia without atypia. So simple hyperplasia without atypia causes endometrium in 1% cases, and complex hyperplasia without atypia causes CA endometrium in 3% cases. But the same simple hyperplasia with atypia causes endometrium in 8%, and complex hyperplasia with atypia causes endometrium in 29% cases. So this percentages have come in the NEET exam so many times, and this is a very old study, but this is still valid. So complex endometrial hyperplasia with atypia causes endometrium in 29%. This figure has come in the exams. So what do you do when there is no atypia, and what do you do when there is atypia? Mind you, hyperplasia is a pre-malignant condition. Hyperplasia is not cancer yet. All that etiology which I told you causes hyperplasia. Hyperplasia causes cancer. So hyperplasia is pre-malignant condition. Now the woman is 45 years, 50 years with a hyperplasia. How do you know the hyperplasia? With a biopsy. What do you do? there is hyperplasia. If it is without atypia, you know the hyperplasia is because of high estrogen. You can treat it with progesterones. This is your question so many times. You can treat it with progesterones. But if it is with atypia, then the chance of cancer is high. You have to treat this with a hysterectomy. Excuse me. So if a patient has hyperplasia with atypia, you can go ahead and do a hysterectomy. Look, it is not still cancer, but I've gone ahead and done a hysterectomy because she can have a cancer later with this, right? So yes, if a woman has endometrium, the most common symptom, please remember, in a premenopausal woman and a postmenopausal woman. So in a premenopausal woman, it is menometorrhagia. What is menometorrhagia? Menometorrhagia. It is irregular acyclical bleeding. And postmenopausal woman, they will be postmenopausal bleeding. These are the main two symptoms. Of course, they can also be dirty vaginal discharge because of a pyometra. All of that can be also there. But irregular acyclical bleeding or menometorrhagia. So when a woman has irregular bleeding, she is diabetic, hypertension. So I am having a doubt that she is having endometrium, but always what is the first thing to do with a woman with irregular bleeding? Now this question has come so many times. Do not have any doubts. Please guys, listen to me. Any woman coming to the gynae OPD is mostly coming to you with irregular bleeding. Always examine her first. Do not say I'll do ultrasound first. Guys, ultrasound is done, the last thing in the OPD is the ultrasound. First, you always examine the lady, whatever lesion she has. If she is irregularly bleeding, she could be having a vulval lesion, vaginal lesion or cervical lesion. She can be having, right? Vulval, vaginal, cervical lesions. If none of them is there, then I suspect that could be a uterine lesion. So first thing is examination, and in nothing is found in the vulva, vagina, cervix. So what do you do in the OPD? In the OPD, I can do a biopsy, yes, with the Pipel biopsy. So workup is local examination first. Local examination to rule out vulval, vaginal and cervical lesions. You rule out these, and if not found, none of this is found, then you sample the endometrium, endometrial histopathology, endometrial sampling. You have to say this answer: irregular bleeding, not responding to treatment for 6 months. This has come so many times in the exam, and all of you end up saying hysterectomy, or you start saying progesterone therapy. Arey bhai, find out the diagnosis, what is wrong first. So vulva, vagina, cervix is fine. Then you have to sample the endometrium. Now in the OPD, if you see the uterus, like my hand is the uterus and this is the vaginal cuff. In the OPD, you can see only the vaginal opening. You can see the vaginal canal, and maybe you can see the cervix with the speculum. But can you see the uterus in the OPD? You can't see the uterus. So vulva, vagina, cervix is fine. What you can do with the uterus in the OPD? You can put in a thin pipe-like instrument, Pipel, and take a biopsy in the OPD itself. It's a painless procedure. It's a very thin Pipel biopsy, forceps. So yes, so what do we do when a woman is having irregular bleeding? In a woman is having irregular bleeding, you can do in the OPD a Pipel biopsy. Yes, this is sensitivity to 90%. Or you can take it to the OT and do a dilatation and curettage with the Sims curette. See, you can take the biopsy. Always say endometrial biopsy or endometrial histopathology or endometrial sampling. One of these words will come in your choices. And if this is available, you can do this. Even better than this, in the OT you can do a hysteroscopic biopsy. And hysteroscopic biopsy is the best assessment. Yes, this is the best method. You can see inside the uterus, and whatever is abnormal, you can take a biopsy. There is no chance that you'll miss. If there's endometrial cancer, 100% sensitivity by the hysteroscopy. So irregular bleeding, do a endometrial sampling. How do you do it? In the OPD, Pipel sampling, in the OT, DNC, or a hysteroscopic biopsy. Remember that, guys. Okay. So yes, transvaginal sonography is obviously done. I'm not saying we don't do ultrasound. Every hospital has plenty of ultrasound machines. But that is not the first thing to be done when a woman has irregular bleeding. Always examine her, and you can sample the endometrium in the OPD itself. So yes, staging is done surgically. Yes, all cancers in gynae are staged surgically. So you'll do a hysterectomy. She has a cancer, guys. You have to do a hysterectomy plus pelvic and para-aortic. Pelvic and para-aortic lymph node sampling. Don't forget that, pelvic and para-aortic lymph node sampling. So based on that, you get the staging. You take the uterus to the path lab, and the uterus, because she is 45 and she has a cancer. Now this uterus which you've done a hysterectomy sent to the path lab, you'll see the endometrium has the cancer. Has it gone to the myometrium? Less than half or more than half? So you have this 2A or 2B. Is it gone to the cervix? Sorry, less than half or more than half is 1A or 1B. Then if it is involving the cervix, it is stage 2. If it has gone to the serosa of the uterus, yes, 3A, it's gone to the vagina, 3B, it's gone to the pelvic and the para-aortic lymph nodes, which I told you. C1 is pelvic lymph nodes, C2 is the para-aortic lymph nodes. So you do a surgical staging, all cancers in gynae. Only CS cervix is staged clinically, and the treatment, stage 1, hysterectomy is enough. Hysterectomy is adequate treatment. But yes, if later the biopsy which you've sent and the biopsy shows that the grading of the cancer was grade 3. Okay, staging is stage 1, but the tissues which you sent are grade 3. Then if it is grade 3, then we can add a radiotherapy in stage 1 itself. Otherwise, stage 1, hysterectomy is enough. Stage 2, you can do a hysterectomy is already done. You will do a pelvic radiotherapy. Of course, stage 3 and stage 4 are individualized treatment. Some people give surgical treatment, some people give only chemotherapy, some people give chemotherapy and do a surgical treatment. So individualized treatment. So we are not asking you stage 3 and stage 4s. You can give many variations. Everybody has a different thought, and the treatment is going to give them moderate relief only, if nothing drastic. So remember, stage 1 and stage 2 is clear. Stage 1 is hysterectomy, stage 2 is radiation. Stage 1 you may give a radiotherapy if it is high grade. So what is the grade? On the grading also the prognosis is dependent. Prognosis best depends upon the staging. Yes, staging is on which it depends best. But yes, grading also is extremely important. If this is grade 3, then you will have to give radiotherapy also in stage 1. Also upon the lymph node status, that is also on which the prognosis is dependent. Estrogen receptor and progesterone receptor status. Now, remember, estrogen receptors are high, bad C endometrium. Progesterone receptor is high, good C endometrium, good prognosis. That is basic. High estrogen, bad prognosis. High progesterone receptor, good prognosis. But one exam they asked you, which is a stronger correlation. So that's here for you, that a progesterone receptor being high gives a good prognosis. That is a stronger relation than when there are high estrogen and they give a bad prognosis. So good prognosis with high progesterone receptor is a stronger statement than high estrogen causing a bad prognosis. This is also one of your questions. Right, CS cervix, yes, the most common genital cancer, and the type is always the squamous cell carcinoma, large cell keratinizing. Second most common is the large cell non-keratinizing. So it is the squamous cell carcinoma, large cell keratinizing. That is the question asked. It is due to 50 serotypes of HPV. Of course, it is most commonly because of 16, and most malignant is the 18. Now this 16 and 18, these serotypes, there are many other serotypes, almost 50 serotypes. These all act by the E6 and E7 oncoprotein. E6 and E7 oncoprotein of this virus is the reason why which there is a patient having CS cervix. Now it is due to the sexual practices most of the time, early sex, sex with many partners, partners having sexually transmitted diseases, more in commercial sexual workers, and in low socio-economic status, poor women. Okay, hygiene, cleaning up is a big problem. So the viruses don't get washed out. So low socio-economic status, women, smokers, all of this will also associated with HIV and HSV. But there are 50 serotypes. So that's why we try to reduce the burden of disease by giving a vaccine. Vaccine is of course against the 6 and 11, then it is against the 16 and the 18 which are common, then 31 and 33, 45, 52, 58. These 9 only. Please, this vaccine is good, but it is not greatest. It is good against 9 serotypes and the common serotypes. So, it is something better than nothing, but it's way too expensive. So, that's why, yes, the Prime Minister started a big campaign on in February, end of February, and that campaign is trying to get immunization to all young girls. So, if it is free of charge by the government and it is some prevention than no prevention, I am all for it. It's a wonderful thing to be done for the young woman, something better than nothing, but at the cost of very high cost of 11 to 12,000 rupees per vaccine and 3 such vaccines, and the prevention is only against these 9, then I say, please, if it is cheap, then maybe I can use it. Such a lot of expense, and the result is that it is preventing only against this 9. That is not very acceptable. So, yes, that's why I like this last line better than the above lines. Strategic Advisory Group of Experts on Immunization says that give at least 1 or 2 vaccines to all girls from 9 to 14 years. Then 15 to 21 also 1 or 2 vaccines. Yes, it is nice, but at least give 1 or 2 vaccines to young girls before they become sexually active. You're preventing them from the major serotypes at least. And of course, if it is free from the government, if it is not too much of expense for the people, right? So, schedule is, see, if it was expensive and it was sure shot prevention, I won't worry about the expense. It is not sure shot prevention. That's why I'm talking about the expense. So, yes, schedule is 0 day 2 months to 6 months to all girls from 9 to 45 years, all women rather, and 9 to 45 years, plus all men also. Yes, that's something which is missed. All men also. So, this is going to prevent CA cervix from these serotypes. So, that's where the problem is. You give the vaccine, it's going to prevent against these 9 serotypes. So, you have to continue the screening. Screening never stops. Screening has to continue. That's why there is some limitation. So, something better than nothing, that's the principle. I am all for it if you make this understood to the woman and then give the vaccine. Alright, so screening for CA cervix is best done by always pap smear. But there is one question which makes a lot of sense. What is cost effective? Even cheaper than the pap smear is the visual inspection against by the visual inspection with the acetic acid VIA. So, this is cost effective, but the best is always PAPs because it can reduce CA cervix by 70%. You know what, when I started teaching way back in 2004, I always taught you till 2013-14 that the most common cancer of women in India is CA cervix. Now we say most common cancer of women in India is CA breast. Second most common is CA cervix. I am very happy that we've been working very hard by doing all these pap smears. We're reducing CA cervix. All gynecologists have worked so hard. I want CA cervix not to happen at all. I want it to be like the West. West, when they show you the post-menopausal bleeding causes, they teach you endometrial atrophy in the West because they don't have CA cervix so much. CA cervix is rampant in our country because of the lifestyles and the poverty and the immunity in the woman. So, CA cervix is rampant in our country. It is still the most common cancer of gynecology in our country, gynecological cancer. So, post-menopausal bleeding is more because of CA cervix. CA cervix doesn't happen too much in the West. That's why they say endometrial atrophy or senile endometritis as the cause of postmenopausal bleeding in the Western world, in the developed world. But the whole world is people like you and me. 80% of the world is underdeveloped or developing. And what do we guys have? We from India, China, 55% of the world population. And then whole of Africa. Some of them are worse than us. Whole of South America. All the majority of the world is people like you and me. And yes, we guys get CA cervix. That's so simple. This is so common. I mean, each one of you, all your interns who are writing this INI-CET exam and all of you post interns who are writing, each one of you have seen CA cervix. I am very sure if you've gone to gynae at least 1 week or 3 months you would have seen a case of CA cervix. How many of you seen senile endometritis? Tell me. It doesn't happen so much. CA cervix is so much common in our country, right? So, please remember the cost effective method is visual inspection under acetic acid, but the best is always pap smear, okay? Then pap smear, way to do, transformation zone, first area to be affected, we discussed. Whom to do? All sexually active women are at risk. Yes, all sexually active women are at risk. When to start? 3 years after first exposure, first sexual exposure. Why after 3 years? Because it takes 3 years for the HPV to start showing effect. So please do not say after 21 years we do it for all girls. Look, that is a recommendation by the American books and by the Western books. Sexual activity starts much early in most of these developed countries. In our country, yes, at least 90% of sexual activity happens after a married life. So we cannot say that 21-year-old go to a village and say all 21-year-old girls come because my recommendations are this. Latest update is this. Are Western book ka can you put it into India? No, you cannot. So please, in our country, we say after marriage or after sexual activity, 3 years, please come to us, we'll do a pap smear because HPV, if at all has come to your body, it will show effect in 3 years. We don't say 21 years. Yes, most women at 21 are not married. Yes, they are not sexually active in our country so early. Okay, so please don't say 21. So frequency is once in 3 years till 30 years of age, but after 30 years, we do the code test, and that code test is pap smear plus the HPV DNA. If both of these are done, then you can do once in 5 years. Of course, if it is negative, the pap smear is negative and the HPV DNA is negative. This code test is a very important fundamental. If you're doing two tests, you're doing the pap smear and you're doing the HPV DNA in the cervical secretions and they are negative, then he has to come after 5 years because the HPV DNA has not even entered the woman's body so far. So even if she has sexual exposure tonight with HPV, it will take at least 3-4 years for the first effects to show. So please come after 5 years. But if doing only pap smear, then you can come in 3 years. Okay, after 30 also. Yes, remember that after 65, no more pap smear is required. Yeah, if they ask you WHO again, please, they are not going to ask you things by WHO every time. But if they ask you, you say after 60. WHO says after 60. Mostly we say after 65, no need of doing a pap smear. All right. But before pap smear, yes, you must make sure that the woman is not in periods, she should not be having vaginitis, she should not be having sex. So we say 24 hours to 48 hours, better 2 days, no sexual activity, and she is not in periods, and she should be not having vaginitis, right? An eye spatula, cytobrush or cytobroom you use. This is the eye spatula, this is the cytobrush, this is the cytobroom, and you rotate it 360 degree once. Okay guys, don't keep rotating it on the cervix. If you keep rotating on the cervix like this, you're going to erode the cervix and she'll bleed and your smear will have blood on it and will spoil your cytology. Okay, 360 degree once and fix it immediately. Fixative, please, fixative is the 95% alcohol. Please fix it immediately. Once you fix it immediately, then you will have the cells not drying. If you let it dry, the architecture gets spoiled. So fix it immediately, 95% alcohol, keep it in a Copland's jar, that white jar, and send it to the cytology lab. In the cytology lab, they are stained with the pap and close stain. Pap and close stain contents came in one NEET exam. Which one is not the part of the stain, like that the question had come. So eosin and hematoxin are always there in all your stains in right from your anatomy days. Then orange green and light green and Bismarck brown. So there are 2 greens and 1 brown with eosin and hematoxylin. And once you stain, the interpretation is that a normal smear will have blue cells and the red cells. See, blue cells and red cells, blue cell, red cell. So blue cell, basic basal cells, red acidic superficial cells. So there are 4 layers of cells in the cervix: basal, parabasal, intermediate, superficial. So superficial cells are acidic, so they take the red stain. Parabasal cells will take the blue stain. So that's why these are all normal cells. Don't think that red and blue will have different interpretation. They're all normal cells and they have a polygonal, see, 5 more than 4 sides, polygonal cells with a clear cytoplasm and a dark nucleus. Now, what happens when there is an abnormal smear? See, this is abnormal smear. Large nucleus. See, hardly any cytoplasm is seen. Such a large nucleus is there, and that large nucleus has replaced the cell totally almost. So, that is what is in the epithelium of the cervix. There is neoplasia, new cells in the epithelium, intraepithelial neoplasia. So, how many cells are abnormal? So, if less than 1/3 cells are new, we say CN1, and 1/3 to 2/3 are new, we say CN2. More than 2/3 are there. See, this one looks like a CN3. More than 2/3 cells are bad. We call it CN3. And if all the cells are abnormal on the smear, carcinoma in situ. So, abnormal cells, new cells which are not seen on the cervix. If you see new cells, cervical intraepithelial neoplasia, intraepithelial, because I am doing a smear on the surface of the cervix. Now, intraepithelial neoplasia has been seen. So, CN1 is a low grade squamous intraepithelial lesion. CN3 is a high grade squamous intraepithelial lesion. Remember, CN2 is also a high grade squamous intraepithelial lesion. So, dysplasia classification or the Bethesda classification, whichever comes, we are not worried about it, because don't get confused. CN1 they'll ask you, CN3 they'll ask you, or they'll ask you low grade or high grade. So, basically it is the same. The CN1 is low grade, CN2 and 3 is high grade. They'll ask you CN2 or 3, same treatment as high grade squamous intraepithelial lesion. So, what is the treatment? We'll come to that. But let's read about a little bit more about this lesion. Remember, if there is CN1, don't take it lightly. A lot of people say CN1 is not pre-malignant because it gets settled many a times. CN3 is pre-malignant. So, this CN2 is also pre-malignant. But remember, don't take it lightly, because CN1 only will become a CN3 in 5 years, and CN3 will become a CS cervix in 10 years. So, I will not neglect a CN1. But yes, what is the management of CN1? Remember that we can do a frequent pap smear now, a frequent pap smear which is once in a year now, and check the DNA, check HPV DNA. Whether it is a high grade are the ones, remember the 9 serotypes which I told you, those are the high grade ones, or it is a low grade HPV DNA. But yes, more than 60% spontaneously heal. More than 60% will spontaneously heal. That's why we say that you just keep waiting. 1 or 2 years, the patient will be fine. It's a virus. Virus just goes off, isn't it? It's a virus. It just goes off the body. So, we're not worried about it, because it'll get okay. But keeps having a look. But if it doesn't get better, if not better in 2 years, then treat like CN3. Then you have to treat like CN3. What is the management of CN3? Now, that is coming in exams. What is the management of CN3? More than 2/3 cells are abnormal. More than 2/3 cells on the surface of the cervix are abnormal. And when you take a smear, when you see that, oh, more than 2/3 cells are bad, CN3, it will become a cancer in 10 years. Mind you, you've done only a screening test. So, more than 2/3 cells are bad on the surface. You want to make sure it is only CN3. Yes, that's the meaning of this. You want to make sure it is CN3 only, and that's what you have to treat. If it is CN3, you want to make sure it is CN3 which you're treating by doing a biopsy, because if more than 2/3 cells are bad on the cervix, a few could be invading into the stroma. So, take a biopsy of the cervix to confirm if it is already invading or it is only CN3. So, if it is CN3, take a biopsy to confirm कहीं ये CS cervix तो नहीं है. Is it already an invasive cancer of the cervix? So, you must take a biopsy and find out if it is invasive. If it is not invasive, I have to treat CN3. If it is invasive, I have to treat cancer of the cervix. So, when it is CN3, you confirm with the biopsy. Please remember that part of the class. Alright. So, yes, management of CN3 is to take a biopsy to rule out invasion. So, how do you take a biopsy? That's what is a colposcopy, because rule out invasive CA cervix by a biopsy. That biopsy can be done by a colposcopy. You know, colposcopy is a 15 to 40% magnification. You look at the cervix. You want to take a biopsy, but how does the cervix look like? You've done a screening test. Cervix was looking normal. So when you do a screen test, cervix is totally normal, but a pap smear is showing CN3. So you magnify your vision by 15 to 40 times. 40 times the magnification of a colposcope, and a bright light is thrown in the vagina. So we call it a vaginoscopy. Vagina is also called colpos. Under colposcopic biopsy, under colposcopic visualization, you take a biopsy of the abnormal areas which you see. If at all there is invasion, it will be under abnormal areas, right? I am not saying there will be invasion. If at all there is invasion. So please concentrate. Tricky topic, slightly getting a little prolonged, but don't lose your concentration. Very important. CIN3, what do you do? Take a biopsy. How to take a biopsy? When you cannot see anything abnormal, you have to do a colposcopy. That's why you do a biopsy from those abnormal areas. You take a biopsy, and that biopsy, if it shows you invasion, then it is invasive CA cervix. So you can do the biopsy with a colposcopy, or you can use highlighters. You can use acetic acid, or you can use Lugol's iodine. That's why these things have been asked you in the exams. So you can do a biopsy by colposcopy, which I showed you. This is a colposcopic biopsy. So what are the highlighters for the colposcopic biopsy? Acetic acid will show you the rapidly dividing areas. They'll become white in color. So those areas are biopsied. Lugol's iodine will show you the resting areas will become brown, but the dividing areas will be white in color. So that's what tells you how to take a biopsy, either by just colposcopy, highlighters like acetic acid, highlighters like iodine, or you can also use a green filter. Some people use a blue filter also, but green filter is the classical filter, and you will see the abnormal vascular pattern to take a biopsy. So how to take a biopsy? It is very important. Now, what is the importance of acetic acid? This acetic acid will coagulate the proteins. So rapidly dividing areas will get coagulated and become white, aceto-white. Those areas you have to take a biopsy. I'm not saying there will be invasion. If at all there is invasion, it will be under those rapidly dividing areas which are white. So when you take a biopsy, you will see if at all there is invasion. Now the problem is you don't have a colposcope in all the villages in this country. Forget villages, most of the cities don't have, most of the capitals of the big states, they have a colposcope, but the other smallest cities don't have. So if you are doing this in a village, you don't have a colposcope, but you can put just acetic acid on the cervix, and with your naked eye you can look into the cervix and you can see white areas, and those white areas you can highlight and send them for a biopsy. So yes, visual inspection of acetic acid is a cost effective method. Yes, it's a jugaad, it's a arrangement. If you don't have the best like the colposcopic biopsy, you can do a visual inspection under acetic acid. Nowhere it is the best, because for visual inspection under acetic acid you need a trained person to do the assessment and take a biopsy, whereas a pap smear can be taken even by a nurse or by a a health worker. So that's why pap smear is the best. Visual inspection under acetic acid is a good arrangement. So yes, VIA, I'm not saying it is bad. VILI, visual inspection under acetic acid is cost effective. Visual inspection under Lugol's iodine is cost effective if you don't have a colposcope. Right, so you've done the biopsy and the patient has CA cervix. The most common symptom is postcoital bleeding. So if a patient has postcoital bleeding, the most common presentation of CA cervix is postcoital bleeding. Now tell me, if a woman says that I have got postcoital bleeding, what is the first thing you will do? Come, I'm just taking another water break. Tell me now. If a patient comes to you with postcoital bleeding, she says, sir, I'm married for last 5 years. I have a child. Recently, I've seen for the last 3 months, every time I have sexual relation, I'm having bleeding. First thing you'll examine, of course, vulva, vagina, cervix. Vulva, vagina, cervix is totally fine. Vulva is fine, vagina is fine, cervix has no lesion. It is looking grossly normal to you. But you know, the penis is hitting the cervix, there is postcoital bleeding. What do you do with the cervix? Come, tell me, guys. Come, what are you telling me? See and treat approach. No, there is no such answer. If there is postcoital bleeding, you have to tell me the answer now. I am waiting for that. So, postcoital bleeding, normal examination, then pap smear. Okay, normal examination, everything is fine, then you do a pap smear. So, postcoital bleeding, you are saying a pap smear. Pap smear is a screening test. And postcoital bleeding is the most common symptom of CS cervix. Just now you told me and everybody agrees. What is the most common symptom of CS cervix? Postcoital bleeding. When a patient has come to you with postcoital bleeding, you will examine and the vulva, vagina, cervix is fine. And then what do? A screening test. A patient is already symptomatic, guys. You can do a pap smear, but it is only 48 to 62% sensitive. You'll miss a cancer, guys. So, if a woman has postcoital bleeding, you don't do a screening test, you do a diagnostic test. Yes, when there is postcoital bleeding, you have to take a biopsy to find out whether there is an invasive CS cervix, colposcopic biopsy. Pap smear is a screening test. You cannot do a screening test when the patient is symptomatic. So, yes, this answer, you guys keep telling me that postcoital bleeding, you do a pap smear. Examine. I am not saying pap smear is contraindicated. It's hardly anywhere near the best test. When it is already a symptomatic patient. In a symptomatic patient, you do a diagnostic test and that's a colposcopic biopsy. INI-CET exam, this question has come, guys. Now, please listen to me carefully. All you interns, this question, please see the Q banks of INI-CET. There is this question which came around 3 years back. A woman has postcoital bleeding. She undergoes a colposcopic biopsy. The colposcopic biopsy is not conclusive. What is your next step? This language was given in the exams. A woman having postcoital bleeding underwent a colposcopy. Colposcopic biopsy was not conclusive. What do you do next? Conization. Yes. You have to do the next big step. You have to do a conization now. Take a conical tissue of the cervix and send it for the histopathology. So, yes, postcoital bleeding, already these questions have come in the exam and you guys are still answering pap smear. So, you have to understand that postcoital bleeding always says, so yes, go ahead for this, go ahead and say colposcopic biopsy. So, that's the most common presentation. Can also be dirty, foul smelling discharge. They can be a patient having pyometra. They can be cancer cachexia, but yes, she can be coming with symptoms of uremia, the most common cause of death. So, uremia is the most common cause of death in a case of CS cervix. Of course, next is hemorrhage and third is infection. Uremia, hemorrhage and infections. Alright. So, that's the staging of CS cervix. You've taken a biopsy. Remember, when you've taken a biopsy of the cervix, cancer cervix has come. Now, what is the stage of CS cervix? So, if you've taken a biopsy and you've got CS cervix, if you got a biopsy and with that you found out CS cervix, so that is what is a microscopic cancer. So, stage 1, look here, limited to the cervix. If it is microscopic cancer, less than 3 millimeter depth of invasion, 1A1. More than 3 millimeter invasion, 3 to 5 millimeter, 1A2. Now, it is big enough. It is more than 5 millimeter. 5 millimeters is ज़्यादा deep. You can see with your eye. 6-7 millimeter you can see with your naked eye. So, if you can see with your naked eye, it becomes a macroscopic cancer, still limited to the cervix. Less than 2 centimeters, B1. 2 to 4 centimeters, B2. More than 4 centimeters, B3. Now, it starts involving the vagina. Look here, this staging is extremely important. The complete staging is 2.5 A4 size pages in your books. This is just half a page staging. Please remember, I've given you color coding here. So, if the cancer is spread to the vagina, upper vagina is 2A, lower 1/3 vagina is 3A. Upper vagina 2A, lower 1/3 vagina is 3A. It starts involving the parametrium. I've given the blue code. Then 2B, parametrial involvement. Parametrium till the wall, pelvic wall is involved. That is 3B. So, 2A, 2B, don't say like that. 2A is vaginal involvement, 3A is lower vaginal involvement. 2B is parametrial involvement, 3B is parametrial involvement till the pelvic side wall. And when the growth is till the pelvic side wall, it gets compressed, it compresses the ureter and there is hydronephrosis. So, that's the stage which has come constantly in all the exams. Hydronephrosis stage is seen in stage 3B. It is the most common stage to the OPD when women come in our country. Okay, and stage 3 is the lymph nodes, stage 4 is bladder and bowel. Look, inguinal lymph nodes are not involved. Obturator lymph nodes, extrailiac group of lymph nodes involved in CS cervix. Those are the sentinel lymph nodes, obturator and the external iliac. All right. So yes, treatment of CS cervix. So stage 1 to 2A1 will do a radical hysterectomy. Just radical is enough to write, and beyond stage 2A2 we say a chemo radiation. So yes, that's why they keep asking you, what is the treatment of stage 3B? Stage 3B is the most common stage, and that's why the treatment of stage 3B is chemoradiation. So what is the chemotherapy you give? Mostly the cisplatin based chemotherapy you give. And radiation, it is given intracavitary and it is given extracavitary. Intracavitary, we put rods into the cervix, tandems. We put ovoids next to the cervix, the metal balls which are put containing the cesium source. So next to the cervix, you can put the ovoids. Into the cervix, you can put the tandems. So that's how you give the chemoradiation. But remember, if it is CIN3 with the biopsy, I told you CIN3 is there, I took a biopsy, it showed me invasion, it is CS cervix. But after the biopsy, you did the colposcopic biopsy and the biopsy showed you invasion, invasive CS cervix. You said the treatment is here. But what if it was still CIN3 only? It was not showing an invasion in the pap smear. So CIN3, you'll do the loop electrosurgical excision procedure. That is the best treatment. Yes, most young women only get CN3 and you can save the uterus. Just do the loop electrosurgical excision procedure. Like some of you were saying that, can you do cryoablation? You can do cryocautery also, yes, but the best treatment is this is the transformation zone which is having the abnormal. This is the transformation zone which is having the abnormal cells. And what you can do with this, you have a loop, a loop with high resistance, this wire, you pass current through it, it becomes red hot. So with this loop, you go to the cervix, and in the cervix, you can do this excision. You can do the excision of the, oh God, I excised too much, I guess. You can take off this transformation zone, loop electrosurgical procedure. In that, you just take out the transformation zone. All right, guys. So LEAP is the best treatment for CIN3. Right. Oh God, a lot of yeah, I know. Yeah, guys, maybe we can do all the other discussions some other time. You know, I was taking some very intricate topics. So yes, it'll be great if all of you limit your discussions. It'll be great. Yeah, I would love to say hi to all of you between the topics, yes, and take your questions also just now. So maybe just keep asking questions. So yes, how much radiation you give? Yeah, that's a good thing he's asked. So if you're giving radiation, if you give radiation in say cervix, so 2 centimeters lateral and 2 centimeters above, 2, 2, 2 and 2. This is point A, and 3 centimeters lateral is the point B. So point A is given the more radiation, 7,000 to 8,000 rads, and point B is given around 6,000 rads. So that's how you give. This is around 7 to 8,000. This is in 1,000, 8,000, and this is around 6,000 rads. You give the radiation, and it is given over a few days, not in one shot. All right. Yeah. So right, fibroids, I'll just tell you a little bit. If you see the fibroids, yes, let's see how many more topics we can do in our session. So when you're talking about the fibroid, the classification is the FIGO classification. Remember, always mention the muscle part first in the classification. So when you say the type 4, why am I starting with type 4? Because all fibroids start in the muscles. Now when the fibroids are starting in the muscle, let me see if I can show you. Yeah, I have this demonstration here. Okay, fine. So all fibroids start in the muscle area. If you see this, I made a fibroid on my hand with this marker. Now, if there's fibroid here, okay, you can see, I hope. Yeah, this is darker. So, I'm trying to show you a fibroid on my with a hand. Here, this is the uterus, this is the cavity, and this is the muscle here. In the muscle, there is a fibroid. So, with the contractions, this fibroid is treated as a foreign body. So, with the contraction, the fibroid will move outside or inside. It may go to the serosa, may come to the mucosa. So, with the contraction, when the fibroid moves, it may become totally into the serosa, subserosal, may come totally into the mucosa, submucosal, and many other areas in between. That's what I'm trying to show you here. So, always the fibroid start in the muscle. This is type 4. Now, from the muscle, it comes towards the cavity. Let's come this side. It is touching the cavity, but it is still in the muscle 100%. So, in the muscle, type 4, 100% the muscle, but touching the cavity, type 3. More than 50%. See here, more than 50% in the muscle, always muscle part first, but partly in the cavity. That is type 2. Then less than 50% in the muscle, always muscle part first and mostly in the cavity. And then submucosal pedunculated. Can you see the stalk? It is hanging by a stalk, pedunculated, type 0. Then from type 4, it may go outwards also. So again, say the muscle first. In the muscle, type 4, but more than 50% in the muscle and partly serosal, type 5. Less than 50% in the muscle and mostly serosal, type 6. And then subserosal pedunculated. Now, that is what is type 7. So, yes, we have to understand that fibroids will have a relation to the muscle and they are pushed outwards or inwards by the uterine contractions. And pedunculated means hanging, type 7. And type 8 is any cervical fibroid is called type 8. You don't have to say in the muscle, coming to the canal, going to the serosa. No, any fibroid in the cervix is type 8. So, that's the FIGO classification of the fibroids that keeps coming. So, if you look at this fibroids, which fibroid you can remove with a laparoscopic surgery? You put a laparoscope into the abdomen of a lady and looking at this uterus, which fibroid you can remove easily with a laparoscopic surgery? See, you put a laparoscope and looking like this. So, yes, you can remove the type 7 and type 6. Which one can you remove with a hysteroscopy? Hysteroscopy, I am going inside. Which fibroid you can remove with the hysteroscopy? Type 0, type 1. So, that's why we say the surgeries you will understand better if you remember this picture first. So, yes, most common problem with the fibroid is the bleeding, and bleeding is the most common presentation. Then there can be pain. Pain can be because of dysmenorrhea, spasmodic and congestive, but pain can be because of degeneration, and the most common degeneration is the hyaline degeneration. But most common in the pregnancy is the red degeneration. Yes, it starts in the second trimester. And please, no surgery. Do not operate a fibroid in surgery, you will kill her. Don't do in a pregnancy. Do not operate a fibroid in pregnancy, you will kill her. Fibroids as it is bleed a lot. Suppose a woman who is 40, non-pregnant, and you say do a myomectomy, do a hysterectomy, I am scared. Fibroids can bleed a lot. If the woman is pregnant, suppose she is a woman of 26 years and she is pregnant and she is having a fibroid and red degeneration and pain. Don't say do a surgery. No, you will kill her. She bleeds tremendously. Look, some of us have removed fibroids in pregnancy, but we are not teaching you that. What we can do as seniors and what we have done, that is postgraduate level, and there are variations to every rules, exception to every rules. But you have to know that fibroids bleed a lot in any myomectomy or any hysterectomy. So, fibroids in pregnancy bleeds like crazy. Don't touch them, only conservative management. Rarest degeneration is the malignant degeneration, and they've asked you the percentage in INI-CET exam, especially less than 1%. Okay, others are like the calcific degeneration and the lipoid degeneration or the cystic degeneration, but these are the ones which commonly come in the exam. Right, the treatment principle of fibroids. So, if these actually come more than the exact treatment. So, if you see a uterus with a fibroid which is only something like 2 centimeters in size and it is located as a type 7 and 2 centimeters, it's not causing any problem. So, small, less than 5,
asymptomatic, no pain, no bleeding, no infertility. So yes, no treatment is required. But there's a small fibroid which is less than 5. It is only 2 centimeters, but it is inside the cavity. Now, if it is in the cavity, it will cause pain, it will cause bleeding, and it may also cause infertility. So yes, treatment is required. What treatment we'll discuss? Just now we'll discuss all of that also. But required or not required, ये पता होना चाहिए. Then large fibroid, 10 centimeters, large fibroid with pain, with bleeding, with infertility, any one of them, the 3 main complaints PBI, treatment is required. Again, treatment is required. But the question which came in your exam is large fibroid more than 10 centimeters, asymptomatic, no pain, no bleeding, no infertility, but it's a large fibroid. She comes to me as a 52-year-old woman who's postmenopausal. She comes and says, sir, health checkup karana hai. So I've been sent to you by the the medical officer in the OPD for the gynae checkup. I'm doing a per abdominal examination and I see there's a big mass in the abdomen. I do the ultrasound and find out it's a 12 centimeter fibroid. Are you having pain? No, sir. You have a big fibroid. I didn't know. Are you having children? Of course, I'm menopausal. I have 3 children and there's obviously no bleeding. So she didn't come to me for any symptoms. She came for a healthcare checkup because she's an aware woman. While healthcare checkup, I find out by some luck that she has a large fibroid of 12 centimeters. Chance finding. What do? Do you leave it alone or do you operate? Please do not leave it alone. It's a large fibroid. A small fibroid you can leave alone, which is asymptomatic. A large fibroid may become symptomatic later. Yes, it may have a degeneration. It may have a torsion, which is a very painful problem. It may have a malignant degeneration. It may compact on the organs and cause compression of the bladder, compression of the bowel. So please, this one also treatment is required. Do not say treatment is not required. Treatment is required. It's the only place where no treatment is required when the patient has a small asymptomatic fibroid. So what is the treatment? Age after 40 years, completed family, you will do a total abdominal hysterectomy. I'm so sorry. You just say you do a hysterectomy, whichever hysterectomy you want to do. I mean, after doing so many laparoscopic hysterectomies, I'm saying do at the age. Yes, you can do abdominal hysterectomy by open surgery. You can do a laparoscopic hysterectomy. You can do any hysterectomy. After 40 years, the patient is completed her family. But remember, don't take out the ovaries till she's 50. Ovaries are functional till 50 years. So they have immunity and femininity. We discussed HRT chapter already. So younger woman, you do a myomectomy, and that is what is coming in the exam. Myomectomy can be done by laparotomy, any type and any size. So laparotomy you can do for any fibroid. Laparotomy open surgery. But laparoscopically, the skills are more and the complications are more if you don't, if you've not done many laparoscopic surgeries. So that's why we always say laparoscopic myomectomy, keyhole surgery, what all generally is recommended. There are maverick surgeons who do many exceptions, but what are recommendations? So laparoscopics, myomectomy, only taking out the fibroid because she's not completed family. So type 6 and type 7 like we discussed. Size, if less than 15 centimeter, 1 fibroid. If less than 5 centimeter, 3 to 4 fibroids you can take out. Hysteroscopic, type 0 or type 1. We already discussed this. Size less than equal to 3 centimeter, 1 fibroid only at a time. Okay, 1 fibroid only. These are the criteria. Asherman syndrome is secondary amenorrhea due to endometrial fibrosis, and that Asherman syndrome, these adhesions are there, and these adhesions is basically destroyed endometrium. So when there is a destroyed endometrium, what are the causes? Mostly it can be tuberculosis, but it can also be a over enthusiastic curettage. Younger first APG, second APG doing the first curettage over scrapes the endometrium and injures. So scraping beyond two warnings are there: grating sound and bubbling of blood. If you are scraping too much with your Sims curette and you're getting a grating sound, that means you're injuring the muscle now. Everything else is out. Whether you're doing an MTP, you're doing a DNC for irregular bleeding, or you're doing for secondary PPH. They can be DNCs for many reasons. Overzealous curettage. So overzealous curettage for MTP, for abnormal uterine bleeding, or for secondary PPH. All of these can cause
Escherman syndrome, and this is more likely to cause Escherman syndrome than the other DNCs. So this is also MCQ. And endometrial tuberculosis, because tuberculosis heals with scarring, lot of scarring will happen, and so endometrium gets totally destroyed. Obviously it cannot bleed anymore. So symptoms are hypo to amenorrhea, so either less bleeding or no bleeding, and diagnosis can be done by HSG. You can see filling defects. Please don't say HSG is the best. You've always seen HSGs coming in exams and they'll show HSGs with the filling defect. Don't say it is the best diagnosis. You can do a diagnosis by ultrasound also. You'll see fibrosis on the ultrasound, but that's also not the best. Best diagnosis by a hysteroscopy, and the best treatment is also by hysteroscopic adhesiolysis. So you will do adhesiolysis, and after that you follow with high dose estrogen and progesterone therapy. High dose to rebuild the endometrium. I'll give high dose estrogen and progesterone therapy, and that's why Escherman syndrome, hysteroscopic diagnosis and hysteroscopic treatment, followed by rebuilding the endometrium. Right, what are you guys asking me? Yes, more or less what we are discussing here. So let's see PID, inflammation of the pelvic organs, and the most common cause prevalence wise is chlamydia. Mind you, chlamydia is an indolent PID, no symptoms. Symptom wise it is gonorrhea, which is symptomatic. So those are the most common cause of PID, sexually transmitted, both of these. So please, PID generally happens, 99% PID happens to sexually active women, and that is because of chlamydia and gonorrhea. Chlamydia most common prevalence wise, there are no symptoms, that's why we call it an indolent PID. And symptom wise it is gonorrhea, pain abdomen, vaginal discharge and cervicitis, and then there's some fever, urethritis also. So that is what is gonorrhea. So yes, you can have mycoplasma, ureaplasma, even tuberculosis cause PID. Obviously tobacco pouch hydrosalpinx can be there, and they can be the beaded calcific tubes can be there. So tube is the more commonly involved in tubercular PID, all that we know, but PID most commonly is because of chlamydia and gonorrhea. So yes, symptoms are pain, abdomen, vaginal bleeding, not very characteristics, but the signs they will ask you. Fever especially is a criteria which is asked in the exam. More than 100.4 degree Fahrenheit, that is more than 38 degrees centigrade, you must admit the woman and treat. Increased C-reactive protein, leukocytosis, lower abdominal tenderness, and per vaginal examination showing cervical motion tenderness. So lower abdominal tenderness, cervical motion tenderness, and adnexal tenderness. So this is the clinical triad. This is the clinical triad of PID. This is a clinical triad of PID, that is low abdominal pain, cervical motion tenderness, that is the uterus is infected and you put your fingers on the cervix and move it, it will cause pain on the movement. So cervical motion tenderness, adnexa next to the uterus, adnexal tenderness. Alright, so you can do the clinical diagnosis by that. And additional criteria, you can do special cultures of endometrial biopsy. Endometrial biopsy, you can do special cultures for which organisms? The ones which usually cause PID. So that is gonorrhea and chlamydia. Gonorrhea you can send for the Thayer-Martin media, and chlamydia by the McCoy cell lines. Special cultures you can do, but the elaborate criteria, this name came, which is the elaborate criteria for the diagnosis of PID, and that is diagnostic laparoscopy. Best diagnosis of PID is by diagnostic laparoscopy. Having said that, please understand, I will diagnose PID in the OPD by the clinical triad. Pain, abdomen, lower abdominal tenderness, cervical motion tenderness, adnexal tenderness, my diagnosis is done. But yes, while doing a laparoscopy, I see inflamed uterus and tube. That is the clear diagnosis. So please be careful of the exam question. Sometimes your recall books, whichever sources you have, they do not give you the right recall. So they keep using terms like the first test to do, or the best test to do, or the gold standard to do. These are not the terms asked in the exams. Exam, they'll ask you very simple questions. What is the method of diagnosis of PID regularly in outpatient department? The clinical triad is enough. The signs and symptoms and the method which I told you. What is the best direct evidence of PID? Laparoscopy. Do you do laparoscopy for everybody? You know, in OPD, sometimes there are 100 patients coming to the general hospitals with pain abdomen in the gynae OPD, and out of which some 40-50 will be suspected of PID. Do you think we do 50 laparoscopies every day to diagnose PID? No. While doing a laparoscopy, if we see inflammation, we say it is PID. So yes, the best direct evidence of PID is laparoscopy. Please remember, ultrasound showing a tubo-ovarian mass. These are the two elaborate criteria for PID diagnosis. Treatment is, of course, one shot cephalosporin, mostly ceftriaxone. Ceftriaxone, just one shot. Remember, just one injection. Ceftriaxone injection or cefotoxim injection, cefoxitin, any one shot is good for the gonorrhea. Gonorrhea is very, very sensitive, and doxy is good for the chlamydia. Now, chlamydia treatment with doxy is 14 days, and metronidazole for the anaerobes and for the bacterial vaginosis. Very important. Bacterial vaginosis is a causative organism, so vaginitis, not for the PID mostly, but yes, it creates situations for the relapse of PID. Bacterial vaginosis can cause PID also. In fact, it can cause chorioamnionitis. We'll read that, and it can cause abortions also. So that's why don't think that bacterial vaginosis is a simple bug. So yes, metronidazole is the drug of choice. Why? For bacterial vaginosis, because if you do not treat bacterial vaginosis, there will be relapse of PID. So this causes relapse of PID, and that's why metronidazole is part of all PID regimes. Whenever there is PID, metronidazole is part of it, because it gets the anaerobes and the bacterial vaginosis. Bacterial vaginosis killing is important because it prevents the further recurrence of PID. Sometimes they'll ask you alternatives for doxycycline. Azithromycin, especially for pregnancy. Azithromycin is safe in pregnancy. Alternative for metronidazole is clindamycin. But yes, metronidazole is safe in pregnancy. Don't think metronidazole alternative is for pregnancy, they have asked. Alternative to metronidazole is clindamycin. By itself, metronidazole is safe in pregnancy. It's a category B drug. Even first trimester, we have given it. If there is bacterial vaginosis, you can give it. So, vaginitis, normal pH of the vagina is acidic, 4.5. So, this is acidic pH, yes. But remember, even relatively alkaline, that is 5, 5.5, 6.5, etc. These are relatively alkaline. So, I want you to understand this, that acidic pH causes candidiasis, alkaline pH causes the trichomoniasis and the bacterial vaginosis. So, alkaline pH is more than 7, but even if it is lesser acidic, we say it is relatively alkaline, it is lesser acidic, it is pertaining towards alkalinity. So, yes, so pH is 6, 6.5, that is actually alkaline, but it can cause trichomoniasis and bacterial vaginosis. So, relative alkalinity is also important to understand. So, yes, this pH of the vagina which is acidic, it is maintained by the lactobacillus. Yes, it's a friendly vaginal bacteria. This will eats the glycogen in the vagina to survive, and when it releases the monosaccharides after consuming the glycogen, it releases the H2O2 and the lactic acid. So, that gives the immunity in the vagina, this lactic acid. Right. So, that is the chart which I always show you. I am coming out of the screen here. You must take a good look at this, pause it and see it in your free time. Bacterial vaginosis is the most common vaginitis, is caused by the Haemophilus vaginalis, also called the Gardnerella vaginalis. Now, see, it has got an alkaline pH, it's got a creamy white discharge, fishy odor, and it's got the whiff test. That is, if you add secretions to the, if you add the potassium hydroxide to the secretions, it gives a ammoniacal whiff, and it has got the clue cells. I'll just show you the picture. The clue cells are, yeah, these are the clue cells, the vaginal epithelial cells with embedded bacteria. So it's got the clue cells. So yes, there are 5 criteria. 1, 2, 3, 4, 5. Any 3 or more are enough. Please, there is no pruritus in bacterial vaginosis. See, there is trichomoniasis, severe pruritus, and in case of candidiasis, out of proportion pruritus. No pruritus in bacterial vaginosis. And this criteria is Amstel's criteria, which I told you. It causes all these infections. The treatment is by metronidazole. Diagnosis by the nucleic acid amplification test. And only the woman is to be treated. It does not have sexual transmission. Only the woman has to be treated. The male partner does not have to be treated. Now, there are recommendations that you must treat both man and woman. Till it comes in my books, of course, I'll check the latest Harrison whenever it comes. If Harrison says, go ahead and treat the man also, we'll teach you next time, treat the man. So far, there are a lot of ideas which are coming up in journals and a lot of recommendations are there, but they don't get accepted immediately. It is better to treat the man and woman. Yes, it's coming up, we know that. But right now, please remember what is given in the books. That is what is your MCQ, and treat only the woman so far. Alright. Then trichomoniasis, treat both man and woman because sexual transmission common, and it is caused by a flagellate protozoa which is motile, causes severe inflammation. So it causes the red macules. So that is what is known as the strawberry vagina, which you see here, strawberry cervix, strawberry vagina, and these are the trichomonads. So yes, it causes greenish yellow discharge, and the treatment is metronidazole. It's got severe itching. And candidiasis has got a curdy white discharge. Yes, see this one, this is a curdy white discharge, and that is what is known as the cottage cheese like discharge. Candidiasis has got 2 forms, dimorphic fungi, spores and mycelia. Spores cause the infection, mycelia cause they will proliferate and cause the adherence. So these mycelia cause the adherence of these white discharge to the vagina or to the cervix. These mycelia cause the adhesion and the invasion. They are the cause of the pain. So these white plaques, when you try to remove these white plaques, these mycelia, they snap out of the vagina and they will cause petechial hemorrhages. So that's why we have all that written here for you. On trying to remove this white plaque, they are petechiae. Diagnosis done on Savarot-Zakar, and the treatment is local antifungals is better than the systemic antifungals. Local creams and tablets. Orally you can give fluconazole, but local cream and tablets are good. Also remember complicated candidiasis. Remember, very important. Candidiasis is only one organism you remember. It is acidic pH and it is Candida albicans. What are the other organisms? Non-albicans species we say them. So complicated candidiasis, NEET exam question. Non-albicans species like Gibraltar tropicalis, it is recurrent, difficult to treat, and it is seen in immunocompromised hosts like HIV, pregnancy and diabetes. Right? So that's about the vaginitis. You must remember that in candidiasis, better to treat man and woman both. And trichomoniasis, treat the man and woman both definitely. Bacterial vaginosis, so far I am teaching you, treat only the woman. And when it comes in the books, we'll ask you in the exams. What comes out in journals doesn't become their recommendations, they don't get accepted immediately. Right? So, cause of abnormal uterine bleeding, you must remember abnormal bleeding is the main presentation to the OPD. So we have this palm coin, classification. All right, polypedenomyces, leiomyoma, malignancy, coagulopathy, ovulatory dysfunction, endometrial causes, iatrogenic causes, and not classified. So this palm coin, palm and a coin, this is now the accepted nomenclature. So please, you know the treatment of adenomyosis is hysterectomy. You know the treatment of fibroids is myomectomy for a younger woman and hysterectomy for an older woman. But they don't ask you treatment of a fibroid anymore. They'll say this woman is suffering from AUBL, leiomyoma. They'll say she's suffering from AUBM, malignancy. So they'll ask you questions like this nowadays. So you must remember this classification, the cause of abnormal bleeding. We discussed a lot of gynecology already, all of them present with abnormal bleeding. So these are the causes you must remember. First line is always NSAIDs and tranexamic acid for the abnormal bleeding. And yes, second line is to give hormones. Remember, progesterones will stabilize endometrium. Estrogens will make a new endometrium to stop the bleeding. That's why progesterones are the first line hormone. NSAIDs and tranexamic acid is overall first line treatment of abnormal bleeding. Treatment of the cause, of course, fibroid treatment, adenomyosis treatment. She's bleeding right now. In the middle of the night, she's coming with bleeding. First thing, you don't do hysterectomy. You stop the bleeding, NSAIDs and tranexamic acid. If they don't respond, you can give progesterones. Next, we give estrogens. Also, we can cause atrophy of the endometrium like androgens, GnRH analogues, intrauterine devices like the IUCD with levonorgestrel, the Mirena IUCD. With this, you can cause atrophy. All these three will cause atrophy of the endometrium. I told you atrophy is a good mechanism of treatment in gynecology. We discussed in endometriosis. We can also do in androgens, with androgens, GnRH analogues, which we give continuously, or IUCDs, right? And surgical treatment. If nothing works, we can do surgical treatment of DUB. That is, you can go ahead and scrape the endometrium out. Yes, the last resort of a gynecologist is to do a curettage. So that is why DNC is called a therapy, a therapeutic curettage. It's called a therapeutic curettage. And remember, I'm not scraping the hell out of it, okay? I'm doing a very gentle curettage. I'm not going to make her have Eshelman syndrome. So when I do a curettage, let's say 35-year-old woman is having too much of bleeding, I do a curettage, next month she'll have periods. Don't think we always do a Eshelman syndrome. So we'll do a gentle curettage, take out the endometrium, she'll have periods. Whereas there are some other procedures like ablation. Ablations are going to stop the periods. I'll explain that to you. So you can do a curettage. Sometimes we can also do uterine artery embolization by the PVA, polyvinyl alcohol. Polyvinyl alcohol particles. We can embolize the artery and reduce the bleeding. We can do endometrial ablation. Now this is permanent amenorrhea, unlike the DNC which I was telling you. DNC will do, and after that next month she'll have a periods. But sometimes a woman who is more than 40, generally for more than 40 years we do this, and we burn the endometrium with a microwave. Look here, this is the uterus, and in this uterus I put a probe, a microwave probe like this, and this will send the microwaves inside and burn the lining. This lining which is bleeding every month. We'll not do it when she's bleeding. We'll stop the bleeding by all the drugs which I gave, and then we'll burn the lining with a microwave or a thermal balloon. There's a balloon with the fluid with dextrose 5%, and we have a probe attached to a machine which heats up this to 87 degrees. So we can either do a microwave or a balloon thermal ablation. We also have a radio frequency ablation. So these are the newer techniques. This question came. They are the next generation. They are the second generation techniques of endometrial ablation. So we do endometrial ablation only for women after 40. Yes, she'll never bleed again. That means she'll never come to the hospital again with this complaint. And she's 40. If she stops period also, it's fine because she already has children by that time. But yes, sometimes nothing works, then we do hysterectomy. So if nothing works, then hysterectomy is there as an option. So you can do microwave ablation, you can do thermal ablation, radio frequency ablation. Earlier we used to have something called first generation. First generation was the transcervical resection of the endometrium, TCRE. Transcervical resection of the, a lot of people still do it, hysteroscopic scraping of the endometrium while burning the endometrium, TCRE, first generation. They asked a question in NEET, I think around 4 years back, second generation ablation techniques, these which I am telling you. Alright, I think I'll take a short break. I'll just take a swig of water and come back. I'll give you 5 minutes break, guys, and we'll get back to this discussion. I have to change the batteries also of my mic. Just give me exactly 5 minutes. Right, guys, thanks for waiting all this while. And Arpit Kumar, drug of choice after 60 years is bisphosphonate. See, why am I so confident when I'm saying this? Because it has come in your exams. It has come in the INI-CET exam. I know all our forums, we have this discussion. A lot of students have this discussion with us. Some teachers have this discussion. And there is discrepancy in this. But how can we come out of this? We should have a basic source of whatever the questions which have come in the few years and what is given in the books. At least some clarity has to be there. Look, I'll be very happy if the exam conducting agencies, INI-CET or whether it is NEET exam or even MCI exam, if they just give the answers, I'll be the happiest. I'll change all my answers. I mean, they have the INI-CET exam, and after 2 days, the results of the expected answers are given in the newspaper or on the online sources, and all of us know what they're expecting. It will be the best thing, but they won't be able to give you that, because moment, let's say for example, AIM says that these are the answers. Somebody from MAMC or somebody from LHMC or okay, no, this is not the answer. Nowadays, this is the best answer. It's not so clear. When you have the NEET UG exam, that time physics, chemistry, biology has outright straight accepted ideas. Here it is medicine. That's why nobody gives you the answer, because every answer will be contested by somebody else who is equally intelligent, and he might be right. So that's why, to prevent controversy, we don't give the answer, but it actually increases the confusions. So go ahead and what is coming in the exams and what is there in the books, that is the closest we can get to the truth. Okay, right. So let's get into the NEET PG live course. We'll talk about this, the bio-wire, we'll come to that also. So tubectomy is the permanent sterilization procedure of a woman, and the timing of tubectomy, most common timing in our country is the postpartum or the puerperal, like we say. Now, postpartum or puerperal sterilization is the most common, and the best time to do is in the first 2 to 3 days. We'll do it in the first 2 to 3 days, because uterus is an abdominal organ. Yes, you can feel the uterus. She's delivered just now. You can feel the uterus like this in the abdomen. So one small incision on the abdomen, you can reach the uterus and catch both the tubes. So that's a very easy tubectomy to do, and also convenient, because women in our country are not going to listen to us. They're going to deliver, and we'll tell them, come after 6 weeks, we'll put a copper T, or come after 6 months, we'll give you OCP. They'll say, aayenge. And next they're going to come only for a delivery to the hospital. So we say, you have delivered a second child, tomorrow morning I'll do a tubectomy, convince the husband, and that's why puerperal or postpartum sterilization is the most common in the country. Best time is the first 2 to 3 days, because the uterus is an abdominal organ. When does the uterus become a pelvic organ? 2 weeks. Hey, hello, it becomes a normal organ in 6 weeks, pelvic organ in 2 weeks. Okay, so yes, best time is first 2 to 3 days. Maximum it can be done is till 7 to 10 days, because in 10 to 14 days it becomes a pelvic organ. And interval, that is another timing. Okay, this should be in bold. Timing, I've told you, one is the puerperal, second is the interval, that is after 6 weeks of delivery. And then there is a concurrent third, that is along with some surgery, let's say like a cesarean section or a MTP. So you can do concurrent, interval or puerperal. In our country, we do mostly the puerperal sterilization. Mode of entry is mostly the laparotomy. In our country, we call it a mini lap, which is 1.5 to 2 inches incision. You can also do a laparoscopy entry. Laparoscopy is increasing, and it is mostly the preferred method in camps, but there are a lot of complications which happened some 4-5 years back. So yes, it has still not taken over the mini laparotomy incident. So we still do a lot of mini lap, small incision, and do a tubectomy. Site of tubectomy is always the isthmus. So isthmus is the site. Why the isthmus? You must understand, why do we cut at the isthmus? Because not because it's the narrowest. No, it is not the narrowest in the first place. The narrowest part is the intramural area. But when you cut at the isthmus here, the cut ends are uniform. These cut ends are uniform. So what is the reason of talking about the cut ends? Because sometimes what happens, that a woman has had a tubectomy after 2 children, and then she has a divorce and the husband gets the custody of the children. or she loses her children because of some misfortune, and she says that I want to get married again and have more children, or she wants to have more children, whichever way, whatever is the misfortune which has happened. So yes, if you cut the tubes at the isthmus, the cut ends are uniform. See, the cut ends are uniform. So that's why to reanastomose this is easier. Whereas if it is the isthmus and the ampulla, then see, the reanastomose won't be perfect. So that's why we do a isthmic sterilization always. So narrowest part of the tube is the interstitial. This is the narrow area, and the cut ends are uniform. So you can do a good reanastomosis, easy, not easy exactly, but a good result reanastomosis, up to 80% successful. So that is why we say isthmic sterilization. Then instrument used is the Babcock forceps. When you're doing the open surgery, at least Babcock's forceps, it's a atraumatic forceps. If you see the grip, this is a very atraumatic. It does not injure the tube, and this Babcock is also used for bowel surgery. It is atraumatic on the bowel also. Then technique used for ligation, Pomeroy's, the modified Pomeroy's. Like the Shirodkar is now called the modified Shirodkar cerclage. So it is modified Shirodkar, modified Pomeroy's. We are not asking you what's the difference between Pomeroy's and modified Pomeroy's. No, that is all too technical for the level of PG entrance. Okay, just remember, modified Pomeroy is the most common. We make a loop of the tube like this, and then we tie the tubal ends together, and then we cut above. So the problem with this, that the cut ends are together. So this may have a spontaneous recanalization. That's the problem. Now Parkland is, that's why my favorite surgeries. When you make a loop like this, you tie this separately and you tie this separately. Both the cut ends are separate from the day of surgery. Cronus is not done anymore because that is fimbriectomy. Cronus, what do? You cut the fimbria and throw it off. So what will you reanastomose if you really want to do it next time? And Madelinas is also not done because it is crushing only. You're only crushing the tube. So that's why it is high failure. So Cronus is not done because you're cutting out the fimbria. Madeline is not done because you're only just crushing the tube. You're not cutting the tube, so it can fail a lot, right? You can also do laparoscopic procedures, like you can do laparoscopic rings. See, these are the laparoscopic rings, salastic rings called the Fallope rings. They are applied on the tube using this laparoscopic ring applicator, shortly called laparocator. So I don't know whether you can see this. There are these two prongs. There are these two prongs on the tip of this. So these two prongs, what do? They will hold the tube. Suppose you're going to ligate the tube, they hold the tube and pull the tube into the cylinder, and there's a ring which is there, this fallope rings, they are fired onto the fallopian tube. So this tube, you make a loop like this, of course it is next to the uterus like that, and on this you will slip this ring. Fallope ring is like this. So this, you're not cutting the tube, you're just putting the ring. It'll cause ischemic necrosis of this ring, and this will slough off, it will fall off in 1 or 2 days. So eventually it gets cut. But laparoscopic procedures can be clips also. This, the Filshey clip or the Hulka clip. So Filshey is flat. See, there are no teeth. Hulka has teeth. I remember that between two teeth you can imagine a U. My way of remembering things. Hulka will have a U between the teeth. Hulka, and Filshey is flat. So these are the clips. Now clips are very convenient because suppose this is the tube, you just apply like this. The clips you just apply like that. So usme kya hoga ki the damage to the tube is very less. That's why these are the methods by which you can do a minimal damage to the tube. That's why they have the best reanastomosis success, the laparoscopic clips. So wrong ligated structures, what are the most common wrong ligated structure are the round ligament. See, please remember the relations. The relation of the lateral part of the uterus. First, you have the round ligament which is going in front to the deep inguinal ring and the inguinal canal, and the tubes on the side, and the ovarian ligaments on the back. So when you're ligating the tube, this tube is next to the round ligament. So that's why the round ligament is the most commonly wrong ligated structure. And for God's sakes, don't say the ureter. Ureter is a retroperitoneal structure. You can ligate the small bowel, you can ligate the appendix by mistake sometimes, even the ovarian ligament has been ligated by mistake. But you cannot ligate the ureter because ureter is not in the abdomen, it's a retroperitoneal structure. That's why a lot of people do this mistake. Right. Okay, so reanastomosis success. Reanastomosis success is best with the laparoscopic clips, like I mentioned earlier, and worst with cauterization. Now, I didn't show you cauterization because that's the worst technique, isn't it? So it will destroy the tube. See, when you cauterizing the tube, like you're passing current through this tube and you're heating it up like that. So it's going to heat up the tube and cut it, but the heat damage will go on both the sides and destroy the tube from inside. So there's technically no reanastomosis possible if at all required. That's why it's the worst reanastomosis. Now, vasectomy, nowadays we're doing the non-scalpel vasectomy. We do the NSV camps are there, non-scalpel vasectomy, and the instrument used are this ring forceps to hold the vas, but this is the stabbing artery, dissecting or stabbing artery forceps. So this stabbing forceps, not artery, that's the wrong name I said. Artery forceps का आदत है ना बोलने का, I'm so sorry. It's a stabbing forceps. So this stabbing forceps, with this you just make an incision, you know, somewhere here in the scrotum. You make an incision in the scrotum, get inside, and then with this stabbing forceps go inside. Of course, after local anesthesia, you go and hold the vas from one side, from the other side, and pull them out and stabilize with this ring forceps. With this you stabilize, you hold it, and then you do the ligation. So yes, you're not cutting anything on the scrotum. So moment you say something to a man like, okay, I'll make a small cut on the scrotum and ligate your vas, and he's like, you know, that sudden discomfort, even hearing can be there in men because of a testicular procedure. So we say, now we are going to just give you a block so that you don't get pain. We just make a stab wound, and it's a very simple surgery compared to your wife's tubectomy. Your wife can even as much as die because of tubectomy sometimes. It has happened. Of course, we don't say that, we say it is much more complications. But yes, in a case of vasectomy, it's much more simpler, and we give you more money. In India, more money because of vasectomy is given to the patients. The men get more money. So yes, the educated men will mostly come. The people who are working in the government, those who are the the government officers, the clerks, and the officers, and the jawans, and all these people who are in the services. Mostly these are the people who will come because they understand these things better. People in the villages, they have a lot of ideas that vasectomy can cause loss of libido, loss of manliness, and inability to work, and erectile dysfunction. All these misconceptions are there. So that's why people in the the middle class, low middle class is generally scared of vasectomies. But we are trying to help, and a lot of this education, we do a lot of vasectomies in my hospital, St. Stephen's Hospital, and we do a lot of them. But yes, I wish it was more than the tubectomies, because tubectomies, yes, it is much more complications. A lot of women have died with tubectomies. Okay, so precaution with a vasectomy is that when you do a vasectomy, the part distal, see, suppose you've done the vasectomy here, the part distal to this part, this will have sperms for a long time. This part will have sperms for a long time. That is how long? It is as long as 3 months. So 3 months or 20 ejaculates. Look, William says 20 ejaculates, so I have to teach you that. They'll ask you anyway from the reference standard books. So Williams Obstetrics says 20 ejaculates. I know the PSM book says 30 ejaculates. So I have to refer to Williams. That's the standard book for obstetrics. So 3 months or 20 ejaculates, that may take for the semen, the sperms to get over in the distal part. So therefore, post vasectomy, use alternate methods of contraception, and that alternate method is given for 20 ejaculates or 3 months. Then also do a semen analysis. Again, do a semen analysis, and that should show a azoospermia. Remuneration by the Government of India. Tubectomy, in the non-focus states, you give 600 rupees, but high focus states like Bihar and UP and all these places, you give 1100 rupees to the man. In fact, you give 200 rupees to the motivator. And high focus states, you will give even more money in tubectomy and vasectomy. Low focus stage, you give lesser money, right? Shoulder dystocia, we'll see a few topics in obstetrics also. Shoulder dystocia, that is the head of the baby has come out. Once the head comes out and then you try to take out the shoulder, but the shoulder is stuck. So please remember, shoulder dystocia can happen to 1% of deliveries. The head to body delivery time is more than 60 seconds. Please remember, the reason is a large baby. So I was trying to show you that you hold the head, you see the whole head of the baby and give a gentle downward traction, and the anti-shoulder disengages from the pubic symphysis. But if the baby is big, if the baby has big shoulders, then the shoulder gets stuck. So don't pull anymore, because you're going to cause a brachial plexus injury. C5, C6, Erb's paralysis, C8, T1, Klumpke's, all that can happen. So yes, first thing to do is always the MacRoberts, flexion of the hip joint, please. First thing is MacRoberts. Second is suprapubic pressure. So MacRoberts is first. MacRoberts is flexion more than 90 degrees of the hip joint. MacRoberts is first. Then next is the suprapubic pressure. That's the Rubin's suprapubic pressure. Many other names are there of this one. And Wood's corkscrew. Wood's corkscrew maneuver. You turn the baby like this. You see, this is the head of the baby. You turn the baby. You hold the head while giving downward traction. You turn the baby like this. So when you turn the baby, this shoulder delivers from the posterior soft vagina. So while giving a downward traction, turn the baby. So that is, you turn the baby like this, and then you turn the baby again like that. So anterior shoulder comes from the posterior vagina, and then the second shoulder also comes back to the posterior vagina and delivers. You deliver one shoulder and then you turn back again. So the other shoulder also delivers from the posterior soft vagina. So both the shoulders are delivered from the posterior soft vagina. That is what is called a corkscrew kind of a movement. All right. Then Gaskin's all four. That is the next thing. You make the woman, rest on all fours, two hands and the legs, and the weight of the baby comes to the maternal abdomen. So you see, the anterior shoulder is still stuck under the pubic symphysis, but the posterior shoulder, this shoulder will come out from the soft vagina. If Gaskin's doesn't work, then you have to do the Javanelli's restitution. Put the baby back inside and do a cesarean section. Hypertension pregnancy, remember the definitions? Yes, what are you guys asking me? Okay, fine. So hypertension pregnancy can be pregnancy se pehle. Patient has hypertension even before she got pregnant. So that is chronic hypertension, now she is pregnant. Or it can be hypertension starting first time in pregnancy. So yes, gestational hypertension, BP more than 140/90, the Protocol 5 sounds are used after 20 weeks for the first time. And then it is also called the transient. It is called the transient hypertension. Why? Because it gets all right after delivery. So gestational hypertension or transient, because she was never hypertensive before this. Now she got hypertensive during pregnancy after 20 weeks. And then there is preeclampsia with gestational hypertension if there is proteinuria more than 300 milligrams in 24 hours, or 1+ by the dipstick, or urine protein creatinine ratio more than 0.3, more convenient and much faster. And then it can be early onset if the hypertension happened before 34 weeks, or it can be late onset if it is after 34 weeks. Also, this woman now, if she has a convulsion, generalized tonic-clonic convulsion, we say it is the eclampsia. So these are the main problems of gestational hypertension. It can be chronic hypertension also in pregnancy. Remember, chronic hypertension will be worse in pregnancy. So what is eclampsia? Eclampsia is with convulsions, but when the woman is convulsing, see, tonic-clonic, tone, first the tone increases, the full body tone increases, and the mother is obviously unconscious, she is fallen down, and then clonic action, full clonic action is there. During the convulsion, nobody breathes. Any convulsion, forget eclampsia, any other head injury causing convulsion also. So when there is a convulsion, the woman is not breathing, she has hypoxia. Baby can get hypoxia, and the baby can get very easily permanent hypoxic damage or even die because of the eclampsia. The mother can also have liver and renal failure, intracerebral bleeding, abruption, HELP syndrome, pulmonary edema, DIC, and even death can happen to a mother. So when eclampsia happens, it is the worst case scenario. So that's why we always say magnesium sulfate for the convulsion, IV labetalol for the blood pressure, plus delivery. You cannot continue this pregnancy. This is the worst case scenario. After eclampsia, there is no pregnancy continuing. So please understand the outright fundamentals. Eclampsia is equal to delivery because it is gestational hypertension, and that is because of a bad placenta. So taking out the placenta, that means taking out the baby is the best management. So eclampsia, max self, delivery. But you keep forgetting IV labetalol. So I've written that for you first thing today. Because when I ask you what is the drug of choice for hypertensive emergency in pregnancy, you say IV labetalol. But when I say the treatment of eclampsia, you say max self. If you express yourself more, you will say do a delivery. But all of you forget IV labetalol. Arey bhai, IV labetalol is for hypertensive emergencies, correct? This is that hypertensive emergency. As an obstetrician, I don't know any other hypertensive emergency in pregnant mothers. This is that hypertensive emergency for which labetalol is made. Alright, so that's the drug of choice here. So labetalol, max self, and delivery. Okay, now there is a condition called imminent eclampsia, which is before the eclampsia stage. Gestational hypertension, preeclampsia, eclampsia. The imminent eclampsia comes here, or impending eclampsia. Imminent eclampsia. That's the stage just before. So what are the signs? The signs which tell you that the woman may throw a convulsion. So the signs are that she's got headache, nausea, vomiting, blurring of vision, exaggerated knee jerks, epigastric pain. Epigastric pain is not because of gas. It is because of a subcapsular hematoma of the liver. Subcapsular liver hematoma is the cause of the epigastric pain. Pulmonary edema, low platelets, rising liver enzymes, deranged renal function, and blood pressure more than 110 diastolic. Proteinuria more than 2 grams per 24 hours is worsening hypertension. More than 3.5 grams, you know, is nephrotic range of proteinuria. So if you see all of this, then what is the treatment? Stay connected with the class. Don't get distracted. Gestational hypertension plus proteinuria is preeclampsia plus convulsion is eclampsia. Now, I am telling you straight just before eclampsia, you are smart enough, you are in the ward, you see the blood pressure of this mother is more than 110 diastolic, exaggerated knee jerks, headache, nausea, vomiting, blurring of vision, you know she is going to throw a convulsion. Don't wait for the convulsion, give the treatment which I told you just before. Antihypertensive treatment, magnesium sulfate and delivery. If she is having imminent eclampsia, you have to commit to a delivery. Yes, same treatment, same dose of magnesium sulfate again. All right. So yes, why is there eclampsia? Because of hypertension. And why is there hypertension? The worst problem which can happen in pregnancy is eclampsia because of hypertension. So please understand, hypertension is because of poor placentation. Very important picture. After 20 weeks, there is vasodilation. That is normal to happen in all pregnancies. Look at this spiral artery here. The spiral artery, can you see, is very muscular. This is pushing the blood into the placenta. The placenta is basically villi which are dipping into this blood pool. So this black thing is the blood pool which is made by the spiral arteries, and these spiral arteries, when they give the blood pool, the villi of the baby are jutting into it, and this villi will suck in the nourishment from this blood. Of course, no blood is taken by the baby, only this villi are dipped like straws into the blood pool of the mother, and this straw is going to just suck in the nourishment, not the blood. All right. So yes, this villi will get more blood because these vessels which are narrow in the beginning become dilated later. Yes, can you see that last picture? They become dilated. How do they become dilated? The trophoblastic cells, they will invade and replace the smooth muscle. See, these blue cells are trophoblastic cells. So narrow spiral arteries, dilated spiral arteries by the third trimester. So this trophoblastic cells, which are not from the villi, they are extravillous trophoblast. Extravillous trophoblast of the blood vessels. So extravillous blood vessel, endovascular trophoblast. So endovascular extravillous trophoblast, they are replacing the smooth muscles. So INI-CET question was there, what is the problem in PIH? cause of gestational hypertension. One line would have been enough. Poor placentation, but they want to know more. What is poor placentation? The extravascular, endovascular, extravillous endovascular cytotrophoblast is not adequately replacing the smooth muscle. Okay, so villi has trophoblast. The trophoblast which is outside the villi, extravillous, has to come to the vascular, endovascular area and replace. If that is not happening, then the blood vessel will not be as dilated. It will be narrow blood vessel. So if there is a narrow blood vessel like this, the flow to the placenta is less. So yes, if this vasodilation is not adequate, if it is not adequate because of the reason just explained, then there will be vasospasm. Yes, there will be vasospasm. So vasospasm is the main etiology because of which the mother increases the blood pressure. There is autoregulation, adrenaline increases in the baby, and that adrenaline will cause the mother to contract the heart much harder, and that will increase the blood pressure. That high blood pressure will go through these narrow vessels and give nutrition to the baby. So these narrow blood vessels are the reason because of which the mother has to increase the blood vessel, and that blood pressure is going to give the nutrition to the baby. So at the cost of mother increasing the blood pressure, the baby gets the nutrition. Now this blood pressure is not high only in the vasculature of the placenta. This high blood pressure is there all over the body. High blood pressure goes to the kidney, renal injury, proteinuria, liver, SNR injury, subcapsular hematoma, brain injury, convulsions, eye injury, papilledema, blindness. All of that can happen because of the high blood pressure. So that's why this high blood pressure is the main reason. So remember, what else is contributories? Remember this vasospasm which I told you, that's what I explained here. This vasospasm is the main cause. What is also contributory to vasospasm? Also contribute to vasospasm. Three more things you have to learn. A bad immunity. The T helper 1 function increases versus T helper 2. T helper 2 function should be more. The humoral immunity is in charge of the immunity in pregnancy, but the T helper 1 immunity increases sometimes, and that increases cytokines, and those cytokines cause vasospasms. So yes, immunity will contribute to the vasospasm. Imbalance between vasodilators. There is lesser nitric oxide. There is there is lesser prostacyclin PGI2. Vasodilators are reduced, and increase thromboxane A2, increase angiotensin. So vasoconstrictor TXA2, thromboxane A2 I have written here, increase in angiotensin and reduction in nitric oxide and PGI2, prostacyclin. So that will also contribute to the vasospasm. What else will contribute to the vasospasm? Lesser angiogenesis, lesser angiogenesis. Look, when there is a formation of placenta, you want good blood vessel formation. For good blood vessel formation, you need angiogenesis. That angiogenesis is less. So transforming growth factor, okay, more important rather than placental growth factor is also important, but transforming growth factor, vascular endothelial growth factor. These are the growth factors which gets bound. They are bound by the anti-angiogenic factors. So this is bound by the soluble endoglin. Now this VEGF is bound by the soluble FMS like tyrosine kinase 1. Soluble FMS like tyrosine kinase 1. So TGF gets bound by soluble ENG. Vascular endothelial growth factor gets bound by SFLT1. Guys, don't get disinterested. This has come in your exam. Don't think it is going above and too much. This has come in INI-CET exam. All the etiology which I just told you. So no wonder we have to discuss this in detail. Please remember, soluble ENG and SFLT1, they are commercially available tests to predict hypertension occurring in pregnant mothers. So please remember, anti-angiogenic factors are more, angiogenic factors are less, vasodilators are less, vasoconstrictors are more. Immunity of T helper 1 type is more and helper 2 is less. All of this contribute to the vasospasm, which is the main etiology of hypertension. Once you understand that, then the other things are understood. Liver will have subcapsular hematoma, epigastric pain. Kidney will have swelling, glomerular endotheliosis. Swollen kidney C, normal kidney, good open fenestra. Swollen kidney, closed fenestra. This picture is glomerular endotheliosis. So, liver will have subcapsular hematoma because of SNR damage, glomerular endotheliosis. RBC will have hemolysis. What is the evidence of hemolysis? Decrease in lactic dehydrogenase, increase in schistocytes, and there will be decrease in the haptoglobin. Haptoglobin is required to bind to the free hemoglobin after the hemolysis. That free hemoglobin is bound by the haptoglobin. So, that haptoglobin will be utilized. So, low haptoglobin is a good diagnostic test for the hemolysis. And then brain will have intracellular hemorrhages, visual scotomas, convulsion due to increase in the glutamic acid, which irritates the meninges and causes convulsions. Treatment of hypertension pregnancy, of course, OPD management, drug of choice is labetalol. You know, it is a alpha plus beta blocker. 100 to 200 milligrams per day we can give, and up to 2400, yes, 2400 milligrams, I'm sorry, per day can be given. It's a alpha plus beta blocker. You can give methyl-dopa, which was a previous drug of choice, hydralazine, prazosin. Read about these drugs a little bit, but the drug of choice is labetalol. Remember, since it's a alpha plus beta blocker, it's not given in asthmatics. Contraindicated drugs are ACE inhibitors. They cause hypocalvaria, this calvarium, this head, small hypocalvaria. And they will be also renal agenesis, which will cause the baby to have, the mother to have oligoamnios and the baby to have a Porter's syndrome, and intrauterine growth restriction. You will not also give furosemide in beta blockers. These are the 3 drugs. This has all come in exam. ACE inhibitor is more important, and then beta blockers and furosemide. These contraindicated drugs are the ones which they are asking more. And then fetal surveillance, apart from giving the antihypertensive treatment, fetal surveillance. Now, this is what we are going to discuss just in a few more minutes, because fetal surveillance, very important for all high risk patients. Of course, important for all normal women, but fetal surveillance like NST, biophysical profile, these are the excuse me, these are the tests which will make us push the pregnancy towards term. We know that the drug of choice is labetalol. Will continue the pregnancy, taking it as closer to term with a vigilance. So, fetal surveillance is the most important tool for an obstetrician. Okay. So, treatment of eclampsia, please, eclampsia is different. Drug of choice is magnesium sulfate. We are not talking about the OPD management anymore. The drug of choice is magnesium sulfate for the eclampsia. Hypertension, it is a labetalol, IV labetalol, but for eclampsia, convulsion, cerebral suppressant is magnesium sulfate. Regime of choice, I know only one regime now, and that is the Pritchard regime. Now, in the sense, ever since my final MBBS 1993, when we were posted in the labor room in JIPMA, my professors told me, forget reading all the other regimes, only Pritchard regime is what is coming in the exam, this is what we are giving, and ever since that has been the method of choice. Okay. So, Pritchard regime, the dose is, yes, 14 grams, grams are not milligram, 4 grams IV and 10 grams IM. These are the 14 grams is the loading dose, right. You can give plus 2 grams if it is not working, but remember the IM dose has to be split into the buttocks, one in right and one in left, because 10 grams is 20 ml. So, you give 10 ml in one buttock and 10 ml in the other buttock. Alright, best definitive management is the delivery. Why? Because the blood pressure gets normal within 1 week in 90% of patients. So, give the max self and deliver. But suppose she delivers at 10 p.m. tonight, she can still throw convulsion for the first 24 hours. So, you have to continue giving max self. So, continue max self
5 grams now, not 4 grams IV. This is 5 grams IM, 5 grams intramuscular into 24 hours after delivery or after the last convulsion, whichever happens later. So when you're giving this, you must monitor the magnesium sulfate regime. Now, this is extremely important MCQ, monitoring knee jerks and respiratory rate, because this should be, knee jerk should be present at least minimal knee jerks. You know the grading, na? 0, 1, 2, 3, 4 of knee jerk. So at least minimal knee jerk, grade 1 should be there. Respiratory rate should be more than 14 per minute, and output should be at least more than 100 ml in the last 4 hours. So 5 grams for 24 hours after delivery, 4 hourly. Now you will understand the importance of this 4 hourly, because when you give 4 hourly, you will give only if the magnesium sulfate is cleared by the kidney in this 4 hours. So for that clearance of magnesium sulfate, you must have at least 100 ml of urine in the last 4 hours. So magnesium sulfate has renal excretion. So urine output should be more than 100 ml in the last 4 hours. And magnesium sulfate is a cerebral suppressant. So knee jerk should be present. Respiratory rate should be more than 14 per minute, because the magnesium sulfate, if it is not cleared out by the body, then there will be respiratory arrest because the suppression of the brain. Knee jerk is upper motor neuron reflex. So that's why suppression of brain, the knee jerk will go off. Once you satisfied this, then only you give this every 4 hourly. Question was asked that the woman is under a magnesium sulfate maintenance regime and the last 4 hours, the urine output is only 70 ml. Withhold the next dose. Okay. Then therapeutic levels of magnesium sulfate are 4 to 7 milliequivalents per liter. So first sign of magnesium sulfate toxicity is when it is 8 to 10, and that is knee jerk suppression. Knee jerk suppression is the first sign of magnesium sulfate toxicity. More than 50 milliequivalents, there will be respiratory arrest, and more than 25 milliequivalents, there will be a cardiac arrest. Right. So when you're giving this and there is a toxicity, so calcium gluconate. Now this is standard dose of calcium gluconate, 1000 milligrams or 1 gram, that is in 10 ml over 10 minutes IV. That is the dose of the calcium gluconate, drug of choice. Hypertension control, IV labetalol. We can start with 20 milligrams, repeat 20, then repeat 40, then give 40 if required, give up to 80. We can give up to 220 milligrams in 24 hours, up to 220 milligrams. Till we keep giving 20, then 20 and repeating. We can give 40 also, so that the BP is controlled, up to 220 milligrams in 24 hours. Tablet labetalol, I told you, for BP control in the OPD, 2400 milligrams in 24 hours. IV labetalol up to 220 milligrams in 24 hours. Timing of delivery, remember hypertension, mild hypertension control on drugs, we can go to 39 to 40 weeks also. Uncontrolled hypertension, 37 weeks. All right. So when we talk about diabetes in pregnancy also has the same kind of information which is important, like hypertension pregnancy. Diabetes can also start early in life, like a 10-year-old girl is a diabetic, now she gets pregnant, pre-existing diabetes. And she could get diabetes for the first time when she is pregnant. That is, she's never been a diabetic. Her sugars increase after 24 weeks of gestation. That is known as gestation diabetes. Needless to say, if a woman is having a diabetes for a long time and now she gets pregnant, this will be worse in pregnancy, the pre-gestation diabetes. So overt diabetes and gestation diabetes, both are the diabetes. There is the White's classification, Priscilla White's classification. She was a hepatologist. So yes, more the years, worse is the prognosis. So if associated with nephropathy or the neuropathy and the retinopathy, all this will have worse prognosis. More years,
worse is the prognosis. So that is overt diabetes in pregnancy. Now gestation diabetes starts for the first time after 24 weeks. First time high sugars. So yes, here again the placenta, just like hypertension which is after 20 weeks, diabetes after 24 weeks, gestation diabetes that is after 24 weeks, because human placental lactogen, yes, the human placental lactogen from the placenta obviously has a insulinase action and also increase insulin resistance. These are the reasons why which a woman has a gestation diabetes after 24 weeks. So yes, before I go into more detail, please tell me one thing. If a woman has gestational diabetes, what are the problems of a newborn? Gestation diabetes, what are the problems in the newborn? GDM, problems in the newborn. 3 times I've asked. So please guys, I request you to give me your attention. Gestation diabetes happens after 24 weeks of gestation, and after 24 weeks, if the sugars are high, it will not cause anomalies. Please don't say GDM cause anomalies. Now this is the biggest mistake a lot of you make. INI-CET, this is that exam. Every year, twice a year, I get so much satisfied because what we are trying to teach you in the classes, it is proved by the INI-CET questions, because they have asked this question at least 4 times in the last 6-7 years, that which of the following is not seen in a baby born to a mother with GDM: hypoglycemia, hypocalcemia, hyperbilirubinemia and neural tube defects. You will not see neural tube defects in GDM. You will not see anomalies because the baby is already made in 12 weeks. In the first trimester, 9 to 11 weeks, in fact, the baby is already formed. So if the sugars are increasing after 24 weeks, the baby is already made. How the hell will you have anomalies? So please, GDM, no anomalies. Now that is what is the only funda which I wanted to express here. Overt diabetes, yes. First trimester, when the mother is pregnant, that time if the sugars are high, that causes the anomalies. Whatever you guys want to tell me in the list, overt diabetes causes anomalies. GDM doesn't cause anomalies. Now that's the reason why when a woman comes to me for the first time in the early pregnancy, 6 weeks, 7 weeks she comes, I will screen for pre-existing diabetes. Definitely I'll screen. First trimester the sugars are high, she will have anomalies. So HbA1c should be less than 6.5% and fasting blood sugar should be less than 95 milligrams per deciliter. Serum fructosamine should be between 258 to 288 micromoles. But the best test is this one. Best test is the glycosylated hemoglobin, because it gives me the sugar control over the last 3 months. So that's why this is the best test for screening for the pre-existing diabetes in pregnancy. Now screening for gestational diabetes. Now this is obviously done after 24 weeks. It is obviously done after the 24 weeks. And yes, you will do the one-step test. Very important. There's so many tests you keep reading, and the one which is asked in the exam is always this, especially INI-CET exam. They've asked you these values. So one-step test, and only that you have to read. So you give the fasting levels first to the lab. They should be less than 92. She takes the 75 grams glucose load, 75 grams, okay, not 50, not 100. And after 1 hour, the value is less than 180. And after 2 hours, the value is less than 153. This is normal. And any one abnormal value, is equal to diagnosis of GDM. Diagnosis, guys, please be careful. I am teaching you a screening test. I am teaching you a screen test of GDM. It is done after 24 weeks, 75 grams of glucose. And out of these 3 values, even if one is abnormal, I am saying it is a diagnostic of GDM. That's why it is called the one-step test. That's why this is the best test to do. You get the patient for a screening. If one value is bad, we say it is diagnostic of GDM. That's why this is called the one-step test. You don't have to now do the 50 grams glucose challenge, and if that is bad, you do the 100 grams glucose tolerance test after fasting. All that is not done anymore. We do these. There are a lot of other guidelines. There are DIPSI guidelines and few other guidelines which we keep reading for the sake of understanding, and we discuss that in PG forums. But what is coming in the exam, I have taught you just now. Right, guys? So anomalies are mostly the cardiac, the most common group, and the most common is the transfusion of great arteries. Now this is a specific defect. This is a specific defect. Then structural, you see the sacral agenesis. Now the sacral agenesis, you see it is also a specific defect. Now these are specific. What is the meaning? That if a baby has transfusion of great arteries, it is a diabetes in the mother. Suppose a baby has VSD, the mother can have diabetes, can have even rubella, can have phenytoin ingestion, folic acid deficiency. VSD can be many causes. But if the baby has transfusion of great arteries, it is definitely diabetes in the mother. Similarly, sacral agenesis is specific defect. They have asked you this question in INI-CET, which is the more common specific defect. The transfusion of great arteries is more common specific defect than the sacral agenesis. Then of course, they can be VSD, they can be PDA, and sacral agenesis, they can be neural tube defects, and they can be abdominal wall defects, and they can be swallowing defects. Abdominal wall defects are like omphalocele and the gastroschisis, and they can be swallowing defects. Swallowing defects can be so many, right from cleft lip to cleft palates and to esophageal atresia, duodenal atresia. They're all going to cause swallowing defects. I'm not going into the great detail of that, but please remember, anomalies are not in GDM. Anomalies are seen only in pre-gestation diabetes. That's why I told you the screening so specifically. So management is diet, and the diet is to normal pregnancy versus diabetes. Please remember, normal pregnant woman, we give 35. Okay, I'll write it here. We give 30 to 35 kilocalories per kg per day. But diabetic, well controlled, we give 24 kilocalories per kg per day, and uncontrolled we give 20 kilocalories per kg per day. So it is called the medical nutrition diet. I'm not going to compromise on the nutrition. I'm going to give a good carbohydrate, protein and fat mix. But the net number of calories we are going to reduce because the sugars are high. We are very strict with diabetes in pregnancy because the problem is intrauterine death of the baby. So that's why sugars are controlled by a profile method. I'll do 4 values. I'll do fasting, then 2 hours post breakfast, 2 hours post lunch, and 2 hours post dinner. And if I have the perfect control, any diabetes, mother has GDM, mother has pre-gestation, the management is the same. It is insulin in diet. But remember, anomalies are seen only in pre-gestation diabetes. Rest everything is the same. The management is insulin and diet. So now I'll do the fasting, post breakfast, post lunch, post dinner, admit the patient, and if it is still high, I start insulin. So what are the targets I have in mind? Keep sugar like this: fasting less than 95, PP less than 120. Please keep an eye on this one. Very important. I'm highlighting this for you now. Fasting less than 95, PP less than 120. Now, please don't come and ask me, sir, fasting till 126 is normal. We know it so from so many sources. This is a pregnant mother we are talking about. If I have diabetes, I'll be very happy that my fasting is less than 126. But this is talking about a pregnant mother. If the sugars are high, there is intrauterine death of the baby. In a pregnant mother who's got diabetes, the fasting can never be more than 95. Sometimes we say 100 tak chalega, but no, that is also not very well accepted. 95 and less is normal. And PP should be less than 120. In fact, if it is 124 also, sometimes our endocrinologists will come and get angry if we have not started insulin for them. Yes, because high sugars can kill a baby in the uterus. So the values are different from non-pregnant women and men. The fasting can be 126 in those people, but in pregnant mothers, less than 95. Okay, so that's why do the profile method, keep the sugars controlled. Once the sugars are controlled, she goes home. Drug of choice obviously is insulin. Of course, you know the oral hypoglycemic agents metformin and glyburide. These are now approved.
fundus examination to rule out retinopathy. And remember, if it is background retinopathy, that is almost 80% of retinopathy. It can be also proliferative retinopathy, which is 20%. If at all there is retinopathy, it will be proliferative, but they will have no delivery in a case of proliferative retinopathy because there is neovascularization, and with the increase in the contractions and the straining which is happening in labor, this proliferative retinopathy can have retinal hemorrhages and even a detachment. So that's why we say if it is a proliferative retinopathy, the woman has to deliver by a cesarean section. Diabetes well controlled on diet, 40 weeks we can deliver. GDM, that is GDM well controlled on diet. GDM not controlled on diet alone, medication required, 38 to 39 weeks we can go, because this is GDM. If it is pre-gestation diabetes controlled on drugs, 37 weeks is maximum. Diabetes which is not controlled even on drugs, so 34 weeks, moment you get lung maturity, you will deliver. So these are the criterias. Fetal surveillance, remember before that. All right. Okay guys, I think we are mostly listening now. Okay, fine. After hypoglycemia, you have been listening. Okay, fine. Take care. So fetal surveillance, now that is the most important tool for a gynecologist to continue pregnancies till term. What makes an obstetrician? Obstetrician can do surveillance. If you know drug of choice for diabetes is insulin, drug of choice for hypertension is labetalol, that is good. But to know surveillance is to become an obstetrician. So surveillance, antepartum and intrapartum, that is what is going to take the pregnancy to term. So visits, we say ideal visits are, ideally we say they should be something like 12 to 14 visits, and India we say they should be at least 4 visits, and WHO, if they ask you WHO, please then only say WHO. So WHO we say it should be 8 visits. And fetal heart rate you can see by the stethoscope, by the Pinard fetoscope, and daily fetal movement count should be more than 10 in 24 hours and the baby is healthy. Non-stress test, now that is the assessment of the sympathetic and the parasympathetic nervous system. So every time the baby moves, the heart rate should increase. So if the baby is moving and the heart rate is increasing, it's a healthy baby. Non-stress test, that's a funda. So you put a probe on the mother's tummy, and every time the baby moves, if the heart rate increases by 15 beats, that's a healthy baby. So usually started at 32 weeks, antepartum surveillance. So non-stress test, can you see this? There is a probe, one probe on the mother's abdomen. Please be careful. Huh? Sometimes they ask you a very simple question. There are 2 probes and they'll ask you what test is going on. So 2 probes is not NST, 2 probes is cardiotocography. Here is 1 probe on the abdomen, that is an NST. So started at 32 weeks, and with the fetal movement there should be acceleration. See, the heart rate is 120 to 160 normally, and suppose the heart rate of a baby is 130. Now the heart rate is staying like this. With the fetal movement, the heart rate increases, comes down. With another fetal movement, the heart rate increases and comes down. So with the fetal movement, the heart rate increases and goes up to 150. So increase should be more than 15 beats per minute, lasts for more than 15 seconds, should happen at least 2 times, more than or equal to 2 times in 20-minute study. That is what is a reactive NST. So 2 accelerations, more than 15 beats. See, from 130 it's gone to 150. More than 15 beats lasting for more than 15 seconds, occurring at least 2 times in a 20-minute study. That is what is a reactive NST. Okay. Now, normal pregnancy we do once in a week. NST only we are talking. High risk pregnancy we do twice in a week. Controlled diabetes and severe hypertension we do once in 48 hours, and uncontrolled diabetes we do daily NST. And what's a non-reactive NST? Mostly normal baby, mostly the baby is sleeping, but it could be non-reactive NST also means that the baby has not moved because he's sick. So non-reactive NST first of all doesn't mean fetal distress, don't say that. Baby could be sleeping or baby could be having some compromise. I'm not saying non-reactive NST is okay. So yes, first of all non-reactive NST you will see for 40 minutes,
and if it is still not reactive, then we say it is non-reactive. We give food. Repeat after a meal. Repeat after a meal. Once you give a meal, the sugars will increase and the baby moves. But yes, even if that does not increase, then it is better to do a biophysical profile. Okay, so repeat after meal, or you can startle the baby, give a loud noise, vast vibroacoustic stimulation. You can do that also. Do vibroacoustic stimulation test. Vibroacoustic, that is one vibration probe is there on the abdomen. It just wakes up the baby. Loud noise is made. Simultaneously, there's a brrr, like that. One sudden movement is given by that vibration. So, loud noise and startling by the movements. The baby wakes up and the heart rate increases. So, if the baby is fine, then you will get reactivity by VAST or by repeating after meal. But if it is a baby of a mother who is diabetes, be careful. Diabetes people already have high sugars. So, if there are non-reactivity in a diabetic pregnancy, whichever diabetes, then do a biophysical profile. Be careful. Okay. So, biophysical profile, yes, as it is, it's 5 things. Non-stress test, like I told you, on ultrasound you'll see the fetal movements, fetal tone, fetal breathing. Fetal breathing is basically swallowing. Okay, the baby is not breathing inside the mother's uterus. Baby is swallowing like it shows a chest expansion. And amniotic fluid index is also 2 marks. So, 10 by 10 is a perfect biophysical profile. And 8 by 10 is an acceptable okay type of biophysical profile, but less than 6 by 10 is a compromised fetus. It is a compromised fetus. And modified biophysical profile, yes, that's the question of the INI-CET people. Very common question and very simple. NST and AFI only, because this biophysical profile takes 45 minutes to 1 hour. This modified takes only 10 minutes. So, normal AFI, all of you know, normal AFI is 10 to 15 centimeters. I'm sorry. It's 10 to 15 centimeters. Oligoamniosis less than 5 centimeters, and polyhydramnios is more than 25 centimeters. And amount is normally 1000 ml. Less than 500 ml is oligoamnios, and more than 2000 ml is polyhydramnios. Guys, I said 2000 ml. I did not say 2500. 25 you will tend to say 2500. More than 2000 is polyhydramnios. Any single pocket less than 2 centimeters is oligo, and more than 8 centimeter is polyhydramnios. Now, what is the amniotic fluid with the gestational age? With the gestational age, now this is also a needless controversy keeps happening. 32 to 34 weeks, 1000 ml is the maximum. 36 weeks it is 800 ml, and 40 weeks it is 600 ml. So, maximum at 32 to 34 weeks. Okay, if they ask you one, go ahead and mark 32 because it came in the MCA exam. Recently, I have not seen this question coming in any exam. MCA exam, the choice was 28, 32, 36 and 40. But one of these 32 to 34 should come because that's where it is the maximum. So, 32 came, go ahead and mark that, but both will generally not come in the exam. After the like is only reducing. So, Doppler of the umbilical arteries in fetal surveillance, this tells me about the perfusion. It is about the perfusion umbilical arteries. Look, middle cerebral artery Doppler is not done generally for well-being. Middle cerebral artery Doppler is done for the anemia assessment. That is for that more specific. But for general well-being, we do the umbilical artery Doppler. So, when you say the umbilical artery Doppler, so there will be systolic flow, diastolic flow, systolic flow, diastolic, systolic, diastolic. This is what is normal. This is normal. But sometimes there will be systolic flow and there will be a notch. So, diastolic notching is the first compromise sign, of compromise, the diastolic notching. And then you may have sometime systole, diastole, absent diastolic flow. So, absent diastolic flow, now that is a severe compromise. In severe compromise,
what will you do? You will deliver. You will deliver in 1 or 2 days. Maximum 1 or 2 days. We generally deliver the same day, but you can say theoretically you can wait up to 24 hours. So yes, severe compromise, because diastole there is no flow going to the baby. Now there is a systolic flow, but diastole there is a reversal. Systolic flow, reversal in the diastole. Reversal diastolic flow. So reversal diastolic flow, that is imminent death. The baby is about to die, imminent death. Now that baby better be out by cesarean section. So if more than 28 weeks, do a cesarean section. That baby is about to die. So reversal diastolic flow. So flow should always be towards the baby. Systole, diastole. Systole more, diastole less. Just like you and me have 120 by 80. But if the flow is coming out of the baby, that means the baby is alive basically because of the systole. Systole stops, the baby is dead in 30-40 seconds. So if there is a reversal diastolic flow and the baby is viable, that is after 28 weeks, you must take out that baby. Right? So intrapartum surveillance, of course, similarly is the fetal heart rate with the stethoscope and the pinard fetoscope during labor intrapartum. Fetal scalp blood pH. You make a small cut on the head. There is a conical instrument, go into the vagina, and sometimes more reliable than other things is to make a small cut on the head of the baby, get around 1 ml of blood. In that ml, you can check for the pH of the baby. So that is what is known as the scalp blood pH. Less than 7.2 is acidosis. Cardiotocography is the best test, best intrapartum test. Fetal cardiotocography, intrapartum surveillance. So there are two things. Cardiotocography. Whose cardia I am worried about? Fetus. Toco means uterine contraction. So yes, cardiotocography, there are two probes. See, there are two probes here. Cardiotocography. So with the uterine contraction, you see the fetal heart rate behavior. So in that, what do you see? In that you see the uterus contracts, heart rate goes low. Suppose the heart rate was 150, it came down to 130. So it's not distress, it is deceleration. Less than 100 and more than 180 is distress. So 120 to 160 is normal. Between that up and down is known as acceleration or deceleration. I told you 15 beats acceleration, reduction of 15 beats deceleration. So if it is 150 comes to 130, there is no distress. So don't panic first of all. So with the peak of the contraction, you see the lowest heart rate. Peak ke saath you see the lowest, known as the nadir. That is what is type 1 or early deceleration. It is seen in head compression, and head compression is normal. Head is compressed and heart rate goes to 130. It is not distress. So this is normal in active labor, more than 4 centimeters dilatation. This is active labor, and in that it is normal. This is the safest deceleration. Safest deceleration is the earliest deceleration. Uterus contracts and it is contracting for 45 seconds. When it compresses the head, that is going to cause the heart rate to reduce, because that causes vagal stimulation of the baby. Alright, so that is safest deceleration. Type 2 deceleration, there is a contraction, the heart rate goes low much later. See, the peak and the nadir are not coinciding. That's why it is called a late deceleration. The peak of the contraction is over. After the peak, the reduction of the heart rate starts, because the placenta is insufficient. Uterus contracts, placenta squeezes and gets empty. Uterus relaxes, placenta should refill. But now the vessels are bad, like in PIH, vasospasm. So when the uterus contracts, placenta empties slowly. When the uterus relaxes, placenta refills slowly. That's why it is a late deceleration. Type 2 is a late deceleration, and that is seen in placental insufficiency. Placental insufficiency, and that is not normal. That is not normal. All right. And then there is a variable deceleration. There is a variable deceleration. Heart rate goes low, much lower, less lower. So this is not coinciding. So variable deceleration. variable deceleration is seen in umbilical cord compression, and it is the most common deceleration. Variable deceleration, umbilical cord compression, it is the most common deceleration, and this is mostly safe. I'm sorry for crowding up a little bit here in this slide, but I want to tell you all of these three together. So, variable deceleration, the heart rate goes down, comes up, but it is not the same because the umbilical cord is over the neck of the baby, hand of the baby, back of the baby, leg of the baby. Umbilical cord can go anywhere in the body of the baby, and with the the contraction, the cord can get compressed. The most likely cord gets compressed and then immediately gets relaxed also, because cord is not at against one place and it is compressed forever. So, cord compression is a momentary kind of a thing, and that's why it is mostly safe. Yes, they can be bad cord compressions, prolonged cord compressions also, but mostly they are safe. So, mostly safe, and they are the most common deceleration. So, yes, what is the safest deceleration? Early. What is the commonest deceleration? Variable. And what is the deceleration which is not tolerated? Late deceleration. See, the heart rate is 150, it has gone down to 130. But I am not tolerating this. Why? Because the pattern of deceleration is not good. Forget tolerating a distress. We don't tolerate one type of deceleration. Any heart rate less than 100 is distress, more than 180 is distress. Forget distress. We don't tolerate distress ever. We don't tolerate one deceleration. If this woman is around 7-8 centimeters, I may be very vigilant, increase the the oxygen we give her, we put her in the left lateral position, hope that it corrects and we deliver her fast. Suppose she is around 3-4 centimeters with the deceleration, we may end up doing a cesarean very early for this patient. So, late deceleration is not tolerated because this will become distress eventually. So, that's why late deceleration is not tolerated, early deceleration is safest, and the umbilical cord compression is the commonest. Alright. So, definition of PPH, alright, fine. Let us see the heartthrob of the topic. Significant bleeding from any part of gestation of the genital tract. Any part of the genital tract. Please don't say just the uterus being atonic. Sometimes the uterus is well contracted, the vagina has got a laceration, the cervix has got a laceration, that can cause PPH. Okay, significant bleeding is more than 1000 ml after delivery. Look, there are a lot of other definitions, more than 500 ml in a normal labor, more than 1000 ml in a cesarean section, we know all that. But the significant bleeding is more than 1000 ml. Now, the mild PPH is less than 1000 ml, moderate PPH is 1000 to 2000 ml, and severe PPH is more than 2000 ml. Now, this is from the regular accepted definitions. Now, I know there are more new updates coming every now and then, and there's a lot of discussion amongst you students. So, why not the latest updates which have come in 2025, December, November? Look, all these updates are not to be recommended, not to be accepted immediately. They are recommendations. They have come by WHO. Yes, WHO is a World Health Organization, world recognized body, ultimate, working very hard and doing very good job. But moment they give us a recommendation, we don't accept it immediately. The Ministry of Health and Family Welfare has to give their own acceptance. So, we have our Lakshya guidelines, we have our booklets in the labor rooms with Lakshya. So, we have our own setup. So, we don't follow what the WHO says overnight. So, please do not think that these become your questions immediately. What is done in your labor rooms, what is practice, and what is stuck as Ministry of Health and Family Welfare boards in front of a labor room is what is the practice. So, yes, WHO updates are there. I am giving it for your consumption. Please see that yes, WHO update says more than 300 ml with abnormal parameters like pulse rate is 100, shock index is more than 1, BP is less than 100, systolic. So, with that 300 ml with these parameters is PPH, or more than 500 ml of blood loss is PPH. So, yes, we are not going to implement this immediately. I have just written it. If at all they ask you what is the latest update on the PPH amount by WHO, something like that comes, go ahead and write this.
You're a doctor, you should have limitless knowledge. But this, don't forget, the significant bleeding is 1000 ml. Don't forget these things. These are still very much valid. Yes, and we are not disregarding what we generally follow in the labor room so fast, because WHO is going to come out with another update in 6 months. There are many other things which updates keep coming. We don't change them overnight. All right. So yes, primary PPH is bleeding within the first 24 hours. Of course, it is most commonly in the first 1 hour, and most common cause is the atonic PPH. And secondary PPH is bleeding after 24 hours up to 12 weeks, and that is most commonly because of the retained bits of placenta, and they get infected and cause secondary PPH. So, fundamental of PPH is that you've taken out the placenta. Moment you take out the placenta, there's a flabby uterus, and that is going to bleed from these vessels at the base of the placenta. So, when the uterus contracts, the crisscross, yes, this is the word which has come in your exams. Crisscross muscles, see the crisscross muscles, they will squeeze the blood vessel. See, this pen is the blood vessel, and this crisscross muscle fibers will squeeze these blood vessels, and the bleeding stops. So, you want the uterus to contract immediately. That's why the massage, guys, gentle massage on the abdomen. You have to do that. That's what promotes the contraction. You give your oxytocin, fine, but your gentle massage is going to promote a contraction. Yes, guys. So that is the crisscross muscle. So what are the living ligatures? They've asked you the live or the living ligatures of the uterus. The crisscross muscle fibers are the live ligatures of the uterus. So cause of PPH most commonly is the atonic uterus because of the large uterus, injuries to the uterus, to the cervix, that is trauma, and coagulation defects like von Willebrand's disease, so thrombin defects, and retained bits of placenta, that is the secondary PPH. So that is tissue. So yes, tone, trauma, thrombin, tissue, 4 T's of PPH. 4 T's of PPH are tone, trauma, thrombin, tissue. So these are the causes of PPH most commonly. Prevention of PPH, always say the active management of third stage of labor. And in active management of third stage of labor, please remember, very important that in active management of third stage of labor, we will always give oxytocin after the delivery of anterior shoulder. Why now itself you give 10 international units? You can give it IM, we can give it IV in slow infusion, not as a bolus. Why after the anterior shoulder? Because I told you in the shoulder dystocia that once the baby's Bible diameter, the head comes out, the broadest part of the baby, the next broadest are the shoulders. So when the shoulders come out, I know there is no dystocia. Now I know the delivery will complete. So head is out and there is no dystocia, shoulder is out. Now I know the delivery will complete. I give the oxytocin to the mother now itself, because by the time I deliver the baby and deliver the complete baby, legs and all, and then I will hold the baby down for a minute for a delayed cord clamping, and then I will clamp the cord slowly, and then I'll attempt the control cord traction. It doesn't come out. Then again I'll attempt the control cord traction. It doesn't come out. Finally, when it comes out, it is 10-15 minutes. So by this total method of delivery, I get 15 to 20 minutes of oxytocin time. The oxytocin will reach its peak action, and that peak action moment I finally take out the placenta, the peak action of oxytocin has been achieved, and that will squeeze the uterus and stop the bleeding. So that's why delivery should be at the delivery, the oxytocin should be given at the delivery of the anterior shoulder. I know that the baby will now definitely complete the delivery. There will be baby having no problem. Delayed cord clamping, more than 60 seconds. Why? Because it increases HP by 1 gram%. Wait a minute, delayed cord clamping. If you read your Williams Obstetrics, please, all of you, I'm sure most of you have access to libraries and some of you have the ebooks. Please see Williams Obstetrics, and they are telling early cord clamping. The standard is early cord clamping. We in India do delayed cord clamping. Yes, so that our poor babies will get at least 1 gram of extra hemoglobin after birth. So we hold the baby down a little bit and wait for the placenta to drain some more blood into our babies, and 1 gram of hemoglobin is increased. But what is Williams saying? Early cord clamping. But yes, Williams is a great book. They say early cord clamping or delayed cord clamping has got no effect on the management or the incidence of PPH. Please remember, this is the least important component. Yes, this is the least important component. And please, all you interns, today, I'm telling you, there is enough time for exam. Those who are working interns, go to labor rooms, wherever you are, whether you are in Delhi, MAMC, LHMC, you are in the south, wherever you are. Just go to labor rooms and see that big board which is stuck there, and they are giving you the steps of the active management of third stage of labor, and they are not writing delayed or early cord clamping. It is the least important component. So when they talk about the 3 more important ones, this is not even there. So this is for our convenience that we give a delayed cord clamping so that the babies get 1 gram of extra hemoglobin. It's not even there. I'll show you that poster just now. Don't worry. Okay. So control cord traction by the Brandt-Andrews technique. Okay. This Brandt-Andrews technique is basically that you put a hand on the fundus of the uterus, one hand on the cord. So gently pull the cord and give a counter traction. This is the method of doing the gentle cord traction, and that is what is done, control cord traction. And the most important one, uterine massage. You have to do uterine massage. Yes, gentle uterine massage. I did not say bimanual compression. Look, as recent as 2025, it has come in 3 exams out of the 5 exams in a year. They asked you a question, where is the uterine massage done in active management of third stage of labor? They asked you a question, which of the following is not done in the active management of third stage of labor? They said oxytocin. Then they said control cord traction, bimanual compression, and uterine massage. So you had to write bimanual compression not done because uterine massage is done. INI-CET has kept on asking these questions. So do not get into confusion. Yes, I know that there are some recommendations by WHO, but WHO is giving the recommendations for many other countries which don't have so many healthcare personnel that we have. So you cannot have one person after delivery doing uterine massage and the other patients are ignored. So yes, WHO also used to say, do a self-assessment of the uterine tone. Tell the patient to assess her own uterine tone. And if she feels it is loose, call the doctor. You think you're going to do that in your hospital? In AIMS or JIPMER or PJ, wherever you're going to get your MD now? You're going to tell the patient, check your uterus yourself? No, WHO has said. Somebody is going to get very angry with you in your college. So please, WHO is giving us recommendations. We don't implement them immediately. Because what is pertinent to our setup is what is followed in the hospitals, and that is what is asked in the exams. So don't get too perturbed by regular updates which keep coming. Follow what is given in the hospitals first. That is what is going to come in the exam. Keep these updates in your mind. I'm not saying you ignore them. Okay. So uterine massage has to be done. Let me show you what is written in this board which is there in front of all medical colleges. Yes, Ministry of Health and Family Welfare. Mandatory for all deliveries, vaginal and abdominal. Injection oxytocin 10 units IM immediately after birth. Control cord traction once the uterus is contracted and the cord is cut. And uterine massage to keep the uterus contracted. It is still there. You know what? As recent as 5 hours back, I called my friends in LHMC in Maulana Azad College. I mean, I'm just mentioning that it is there in these big hospitals even now. I'm not saying that they are not listening to the updates. They may implement it very fast. But right now, it is still there in all the major hospitals. Why am I using these names? Because they are government hospitals and they are not going to do things which are not good. They are going to follow things. So see please this here. Look here guys. See this picture here? See this here? Here. There's a very thin line written here. It is there in all the government hospitals, this picture. What is that thin line? It is here. For use in medical colleges, district hospitals and first response units. So I'm not saying that you are doing wrong by following the recommendations of the government. Yes, these are definitely the things which are still followed, and please do uterine massage. The updates are important, don't ignore them. They're all very important, but keep them in your mind. If they ask you what is the latest, please go and write whatever is coming in media regarding the internet. You see so many updates which are coming from WHO. You read the guidelines. 2012 onwards, WHO is saying don't do uterine massage. But so many questions have come in all these years about uterine massage. Okay. So let's not waste too much time. Drugs for PPH management. Drug of choice is oxytocin. Now carbetocin is a new entrant. In place of oxytocin, you can use carbetocin. Yes, it's a new entrant, and we are also saying that it is part of the active management of third stage of labor you can give. So carbetocin 100 micrograms in 1 ml given IV over 1 minute. All right, you can give methylargometrin 0.2 milligrams. Misoprostol. Misoprostol is given. You can give it sublingually 200 micrograms, or we prefer giving 800 micrograms rectally. Carboprost is PGF2 alpha. Now this PGF2 alpha is not obviously the first drug, but this is that drug, go-to drug. If none of the drugs work, then we use carboprost. So that is that go-to drug. Before giving to the surgical management, this is a drug. Of course, I am not saying there are some other drugs also like tranexamic acid. It's a very good drug. Tranexamic acid is given for all bleedings nowadays. Everywhere, even trauma, they give tranexamic acid. They give it for bleeding from the tonsils. They give it from the bleeding from the uterus also. So please remember, tranexamic acid is not the best drug for PPH, but it is given as an inclusive drug to help. So remember, carboprost is that go-to drug. We give it 250 micrograms intramuscularly. It's never given IV, because it causes sudden hypertension. Tranexamic acid is given 1 gram intravenously, antifibrinolytic. Then if nothing works, then after these drugs, the first surgical method for reducing the bleeding is the uterine tamponade by the Bakri balloon. Now this is becoming a very common question. How do you give uterine? What is the first surgical method? Uterine tamponade. Put a balloon in the uterus which will distend and compress the bleeding points. Drugs are going on. So Bakri balloon, I'll just come to your questions. This is the Bakri balloon, and you distend it with 500 ml of normal saline. Okay, and Bakri balloon. Then if that doesn't work, then you have to open up the abdomen. When you open up the abdomen, you see the uterus is flabby, so you can tie down the uterus with 2 ropes. See these 2 ropes. So when you tie down the uterus like this, that is the B-Lynch hemostatic suture or a brace suture. See, this is a patient who had abruption. Abruption is a reason for a patient having PPH also. So see this, these are 2 ropes which we have tied, right? B-Lynch. Then you can do uterine artery embolization again by the PVA particles. Now somebody was asking me that polyvinyl alcohol, just the same particles which we discussed with the abnormal uterine bleeding management. Then uterine devascularization. How do you reduce? Somebody was asking me what is the chain of events, how do you do the sequence of the vessels which you ligate. Obviously the first is the uterine artery ligation, and then after uterine you ligate the ovarian, because there is a very good healthy anastomosis between these two. So next is the ovarian artery ligation, and the last is the internal iliac artery ligation before you think of hysterectomy. Now internal iliac artery ligation, remember the posterior division is only 3 divisions: superior gluteal, iliolumbar, lateral sacral. Short gills, okay, short gills, fishes have gills, short gills, or the current heartthrob of the country, Shubman gills. Alright, you can remember whichever way. So superior gluteal, iliolumbar, lateral sacral, that is the posterior division. So this is the common iliac, this is the posterior division, this is the anterior division. So what do you ligate? Please, we do not ligate the posterior division. We do not ligate the common iliac or do not ligate the internal iliac here. We ligate only the anterior division, guys. We ligate only the anterior division, because anterior division has the uterine artery. Now they have asked you the branches of the posterior division, branches of the anterior division, you have to mark them up. Remember the posterior division branches, the simple questions sometimes come in INI-CET, all the following are the anterior division branches except, like that, by exclusion if you remember the posterior division. Those easy questions you can answer. But sometimes the question is, what is the principle of the ligation of the internal iliac artery? The principle is to, yes, principle is to reduce the flow but not to stop the flow. It is a snug ligature. It's a snug ligature to reduce the flow. It is not a ligature to squeeze the hell out of this blood vessel. We are not blocking the flow. So, reduced flow in the uterine artery will make sure that the uterine bed, this is the uterine bed which is bleeding. This uterine bed which is bleeding, in this the flow will be reduced, and sluggish flow will promote the thrombosis. Sluggish flow will promote the thrombosis. That's why you're reducing the flow, not stopping the flow, right guys? So let's quickly have a presentation and presenting parts discussion before we move on. But yeah, some questions are there. In uterine massage is done. Yes, I'm very happy you agree. And in which condition delayed cord clamping is not done? RH negative pregnancy, because more blood will go from the baby to the mother. HIV positive mother and HBsAg positive mother you will not give, because infection can come from the mother to the baby. And if the baby is sick, if there is hypoxia, birth asphyxia is there, baby is not breathing well and the baby is looking sick, and you know the heart rate was less before the delivery was happening, all these conditions you will do immediate cord clamping. And remember, it is the least important component of PPH prevention. Whether you do early, whether you do late, it does not have any bearing on the incidence of PPH. Remember that, okay? Least important. So that's why you saw the board which I showed you, which is there in the medical colleges, and I showed you the government of India's recommendations that the delayed or the early cord clamping is not even mentioned in that. Okay, na? So don't say that is a very important component. It is good for our babies because it increases the hemoglobin by 1 gram. Okay, fine. Okay, so all right. That's a nice thing to read. Hats off. Okay, chalta hai. Thank you so much. But we are going to talk about the revision of the most common presentation and the presenting parts. So, revision of presentation and presenting parts. Most common presentation. See, presentation is part of the baby in the lower segment. What is there in the lower segment? Either the head or the breech. So, head is in the pelvis, cephalic presentation. Breech in the pelvis, breech present. Most common presentation is cephalic. Most common malpresentation is breech. Now, what is the most common presenting part? So, if the head, see, this is the, let's say this is the lower part of the mother and there's a cephalic, see, cephalic presentation. This is in the lower segment, cephalic presentation. Now, this cephalic presentation can be having many parts depending on if the head is flexed. So, if the head is flexed, I'll show you without the pelvis. If the head is flexed and going into the pelvis, vertex. If the head is extended going into the pelvis, face. If the head is straight and going into the pelvis, brow. So, see, this is a brow presentation. See, this is a brow, deflexed head. If it is flexed, it is the vertex. If it is extended head, see, it is the face which is going inside the pelvis. So, that is the presenting parts. So, if the presentation is cephalic or breech, presenting parts depend on the attitude of the head. Flexed, vertex, deflexed, brow, extended, face. Then, what is the most common presenting part? It is the vertex. Most common presenting part is the vertex. Most common position of vertex. Now, that is the next big thing. So, if you see the position depends upon the, suppose we are talking vertex, this is vertex. Position depends upon the location of the lowest bone in the pelvis. So, vertex is the presenting part. Lowest bone which I can feel is the occiput. So, lowest bone of the vertex is the occiput. And where is the occiput? See, the occiput is next to the lambda, the triangular suture. If the occiput is anterior, occipito-anterior is the position. If the occiput is like this, occipito-posterior. If the occiput is here towards the left, left occipito-transverse, right occipito-transverse, right occipito-posterior. So, these are the positions of the presenting part. Position depend upon the location of the denominator in the pelvis. So yes, this most common presenting part is the vertex. Most common position of vertex is the left occipito transverse 40%. It can be left occipito anterior also, lesser. Now, most common malposition of vertex is right occipito posterior. Now, this is what keeps coming in exam. So, I did not want to end our discussions without that. So, occipito posterior towards the right. Right occipito posterior. Now, right occipito posterior hits the pelvic floor, and if the pelvis is like a lady's gynecoid pelvis, the pelvic floor will rotate this and make it occipito transverse, right occipito anterior, and then direct occipito anterior, and this delivers by extension. So, most occipito transverse will, most occipito posterior rather, most occipito posterior will become occipito transverse, occipito anterior, like this and deliver. Sometimes occipito posterior cannot rotate because there is a anthropoid pelvis. So, it stays occipito posterior and that delivers as occipito posterior itself. So, when it delivers as occipito posterior, look where is the face looking. Look at the face of this baby. The face is looking at the pubic symphysis. See, face is looking at the pubic symphysis. So, yes, it is not face presenting part, it is still vertex. Vertex has come out as occipito posterior, and then when it comes out the face of the baby, we look at the pubis. So, face to pubis delivery in persistent occipito posterior. So, yes, not too many words, I am sure you have read it, that is why we are going a little fast about it. So, right occipito posterior hits the pelvic floor, in a gynecoid pelvis becomes anterior and delivers. Right occipito posterior does not rotate. MCQ very recently, many exams. It stays occipito posterior. It delivers as occipito posterior and the head comes out with extension, but it is looking at the pubic symphysis. That is face to pubis. Alright. So, fate of the occipito posterior. In 80% of cases in a gynecoid pelvis, it rotates to occipito anterior and delivers. Now, in 15 to 60% cases in an anthropoid pelvis, it stays occipito posterior and delivers by face to pubis, FT pubis I have written, face to pubis. Now, this another one which I must tell you now, because I thought you should write this before I tell you the third one. Now, occipito posterior, see here, the occipito posterior towards the right sometimes cannot rotate, it becomes direct or persistent occipito posterior and delivers by extension, face to pubis. But sometimes what happens, that occipito posterior, right occipito posterior, when it hits the pelvic floor, right occipito posterior, when it hits the pelvic floor, it rotates to occipito transverse and it stops. See, it cannot deliver as transverse and it stops because it is an android pelvis, male type pelvis. There is no space for it to rotate anteriorly by itself. So, yes, sometimes what happens, the occipito posterior rotates a little to occipito transverse and stops. When it stops here, a transverse cannot deliver. I told you a straight occipito anterior can deliver and a straight occipito posterior will deliver. Sagittal suture should be straight in the pelvis like this. Occipito posterior delivers, occipito anterior delivers. But when it is occipito posterior and it rotates to occipito transverse, which we are discussing now, occipito transverse cannot deliver, but a doctor can put his hand inside the vagina and hold the head, and with the hand can rotate to occipito anterior. Once it is rotated to occipito anterior, he takes his hand out and applies forceps and takes this head out. So, yes, occipito posterior even if it comes and stops at occipital transverse, and if the patient is in the hospital, a good doctor can rotate it manually and make it occipital anterior, take his hand out, apply forceps and take the baby out. So yes, in a android pelvis rotates to occipital transverse and stop. We can do manual rotation, MR, manual rotation, forceps extraction, right? Manual rotation and forceps extraction, right? It doesn't matter if less people are watching. It can eventually be, because it's a long lecture, eventually they'll see in a recorded lecture. That doesn't matter as long as one of you is watching. All right, guys. So that's about this. So I can just show you this in the picture here. Gynecoid is the most common pelvis. Second most common pelvis is the anthropoid, and the rarest pelvis is the platyploid. This is the rarest pelvis. So we'll discuss these three because these three can have occipito-posterior. So gynecoid pelvis, suppose I'm trying to make the occiput by the arrow. See, this is the occiput by the arrow, and you can make out. This arrow is the occiput and it is towards the sacrum. Now, when this gynecoid pelvis has an occipito-posterior, it can rotate once, twice and thrice. 3/8 of a circle, it rotates anteriorly and delivery is possible. It rotates to occipito anterior and delivery is possible. It can stay occipito posterior also deliver, but in gynecoid it can rotate to occipito anterior and delivery is possible. 3/8 anti-rotation. Now, if it is occipito posterior in a anthropoid pelvis, the side walls are parallel. See, these side walls are parallel. So this rotation is not possible. So yes, this question is coming so many times. No rotation possible. I wrote it already, but I am revising it again. No rotation possible. So that is persistent occipito-posterior, and that will also deliver. If it is posterior also, it will deliver. Takes some time, but it delivers, and delivers by phase 2 pubis. Now, third one, the android. The front walls are narrow. So there is a roomy pelvis in the back part of the pelvis, but front part, the forepelvis is narrow. So this rotates to occipito-transverse, but it cannot rotate more on its own. So it stops. So yes, it rotates to occipito-transverse and stops. Yes, that is what is called the deep transverse arrest. Yes, somebody has written that, deep transverse arrest. So you can do a manual rotation and a forceps extraction. You can rotate it and then take your hand out and apply forceps and take out. Yes, some people can also do a forceps rotation and a forceps extraction. You can do that also. You can rotate rotational forceps. Kieland's rotational forceps can be used. So forceps rotation and forceps extraction. I wish we could do that demonstration here, but some other time. Right, guys? So that's the list of things which I got for you today. But then if you have some more doubts, we are already here. Okay. Right. So thank you so much for your patient listening, and we are all here for your questions, and those who are going to write their comments on this, I will be reading this and I'll answer you back on the chat. So don't think that this is the last session. We are always connected with you. PW excels in staying connected, and I'm sure that most of you are going to see this as a recorded lecture because this is a rather long lecture, and I'm sure you have many things to see. So some of you have not seen it live. Those you see in a recording, you're most welcome to send in your queries on the chat and we'll be answering them to you. All right, guys, thank you so much. Lovely having a session with you and interactive. Thanks for your feedback, and God bless you. All the best with the results.